우주강산에 비친 달아
내 중심으로 강강 쏠래 이거 하게 된 거 그냥 놀래 북북동이 내 동네 내 중심으로 강강 쏠래 Turn around slow down 멍 때려 아무것도 안 할래 바보 같은 짓만 골라 주머니는 무겁지만 I don't live play again 다시 보긴 결제 Damn bad 아니고 난 배짱이 우리 엄만 일어나 놀래 대한학교 설레비네 첫 번째 힘안 들이고 나까지 난 볼래 Oh way 광선 보석 참을린 그래 내다 가만히 가나 때다 I pray for myself 못 때라 우리 번님 어디 가고 모두 신어 세워라 내워라 답답한 건 넌데 왜 나를 붙여놔 세워라 내워라
달아 밝은 달아 우주강산에 비친 달아
나 떠나고만 싶어 별이 기대 쉬어져 바람은 날 반겨 날 따라 심장이 뛰어
이랑이 방송합니다. 오늘 한산댁 할머니 100번째 생일을 축하해 주시기 바랍니다.
난 뮤에 우리 지금 너랑 함께 난 빠지고픈데 저 아름다운 뮤에 We were 지금 넌 어디야 baby Give me the addict 지금 바로 내가 출발할 테니 아무거나 고쳐도 티가 나 여부 너 챙겨도 날씨도 완벽해 사진도 찍어줄게 같이 걸어갈래 시원한 바람은 우리를 반겨 너도 느끼길 바래 지금 내 앞에 앉아 너 하고 싶은 거는 다 해도 돼 없잖아 type 나도 따라갈게 걱정 말고 drive 눈이 보이기는 완전 리리야 아름다운 적용 바로 네 뒤에
Welcome to the Master Symposium on Facial Plastic and Cosmetic Medicine 2021. It is a delight having all of you here. Thank you for participating in this affair. Dr. Jung-Ho Seo, Director of KCCS and KSKCS, will be beginning the conference with an opening speech. Please welcome Dr. Jung-Ho Seo.
Welcome to the International Joint Masters Symposium. On behalf of KCCS, I would like to express my sincere congratulations on the joint conference. Coronavirus has been a huge game changer. I would like to express my respect and appreciation to doctors who are devoted to treatment and research despite the difficulties on the long-lasting coronavirus pandemic. I hope that the coronavirus pandemic will end as soon as possible and we can return to daily life by gathering all medical capabilities. All attendees can learn much knowledge and updated operative techniques through this symposium. I am sure this joint conference will continue to contribute to the development of cosmetic medicine. Finally, I would like to thank all faculties and staff for their effort. I wish the best to you and your family. Thank you very much.
Thank you, Dr. Jung-Ho Seo, for your welcoming speech. Now we will be starting Session 1, the 23rd Shinmian International Rhinoplasty Workshop. Dr. Tae Bin Won will be speaking on functional rhinoplasty concept and techniques. He is the visiting fellow of the Department of Otolaryngology, University of Pittsburgh School of Medicine, Pittsburgh, Pennsylvania. Visiting Associate Professor, Stanford, Otolaryngology, Palo Alto, California. Also Professor of the Seoul National University Pundong Hospital.
Hello everyone, my name is Taebin Won and I work at Seoul National University Bundang Hospital in Seoul, Korea. I really hope that the 23rd International Rhinoplasty Workshop runs smoothly as butter. The title of my talk today is Functional Rhinoplasty, Concept and Techniques. Let me start by sharing a case with you. This is a middle-aged lady who presented with a chief complaint of nasal obstruction. She had a previous history of septal turbinoplasty, and as you can see on her endoscopic view on the right and left side, her septum is straight and the turbinates are not swollen. She has no allergy. So the previous doctors recommended her to seek a psychiatric consultation because she seems to be too preoccupied of her nasal obstruction. So before jumping into an endoscopic exam or using a nasal speculum to inspect the nasal cavity, you can see a few features on her basal view. First, there is a recurvature of the lateral nasal wall, and her columellar base is a bit wide. So these collectively is making her nasal passage a bit smaller. On gentle inspiration, you can witness a bilateral collapse of her nasal airway. So the diagnosis that I made was a dynamic nasal obstruction due to a sidewall collapse and a wide columellar base. I performed bilateral alar Baton grafts to increase the support of the alar valve and a columelloplasty, which will narrow the wide columellar base. The columelloplasty included resection of bilateral medial footplate and the intervening soft tissue. This is a pre-op and post-operative inspiration photos of the patient. You can see that the recurvature has been improved and the wide columellar base has been narrowed, thus increasing the size of her external nasal valve and her nostril. Her subjective nasal obstruction also improved dramatically. This is an airflow map showing the airflow pressure of the regions of the nasal cavity. As you can see, that this area has the most highest airflow pressure, and this is the nasal valve region. Therefore, the nasal valve is the area of the nose most critical for nasal airflow. Traditionally, the nasal valve can be divided into the internal and external nasal valves. However, there is some confusion regarding the exact location of the external valve. Therefore, I personally divide the external valve into the alar valve and the rim valve. I will explain to you more specifically in the following slides. So the boundaries of the internal nasal valve are quite established. You know the septum, the caudal margin of the upper lateral cartilage, and the head of the inferior turbinate. This is a view of the internal nasal valve of a patient after removing the inner lining. You can see the anterior septal angle and the lateral crus of the lower lateral cartilage and the caudal margin of the upper lateral cartilage. So this is a more close-up view of the internal nasal valve, the caudal margin of the upper lateral cartilage. Actually, this would correspond to the scroll area. So from a dorsal perspective, the internal nasal valve would correspond to the scroll area when you're performing a rhinoplasty. The boundaries of the alar valve would include the nasal septum and the nasal floor, and the alar cartilage, specifically the lateral crus of the lower lateral cartilage and the soft tissue lateral wall. The alar valve would usually correspond to the alar groove. So if you have a patient who has a salient alar groove, it would mean that there is an increased chance of an alar valve problem. The rim valve is more caudal towards the nasal nostrils, and the boundaries would include the columella, the medial footplates, the alar rim and lobule, and the nostril sill. So the key points in performing a nasal valve reconstruction or nasal valve surgery is first to determine if there is indeed a nasal valve problem, and second to determine whether it is a static or dynamic obstruction, if it's an internal or external alar or rim valve problem, or both. So in other words, to determine the epicenter of collapse, and finally to look for concomitant nasal deformities. This is just to go over some terminology. So nasal obstruction can be static or dynamic. Collapse would usually mean a dynamic obstruction, and stenosis would mean a static obstruction. So this patient that I showed you at the beginning of my presentation has a dynamic collapse of the alar valve, and this patient would have a static stenosis and static obstruction because of a rim valve stenosis. The evaluation maneuvers for nasal valve obstruction, the famous Cottle test, where you pull the cheek soft tissue. This will improve simultaneously the internal and external nasal valve. Therefore, I usually like to perform the modified Cottle's test, which is also the Q-tip test, where you use a Q-tip for gentle support of the regions of the nasal valve. So this can pinpoint and localize the epicenter of collapse. So in this patient, as you can see, when I'm performing the Cottle's test, you can see that the internal nasal valve and the external nasal valve collectively widens and opens to increase the passage of the nasal airway. This is a patient complaining of bilateral nasal obstruction. You can see on gentle breathing, there is a severe collapse of the left side. The right side, there is a severe caudal deviation causing the static obstruction. And the left side, you can see that there is an inward collapse of the lateral wall. So there is an internal and alar valve collapse. Cottle tests and Q-tip test will reveal the epicenter of collapse. So how often in Koreans and Asians? Unfortunately, there is no formal study conducted in the Asian population. We would suspect that there's probably less than the Caucasian because we have a wider nasal angle as shown by a article by Dr. Hongyul Jin. And we have a thicker skin, which would provide a resistant sidewall. This is a comparative study of Koreans and Caucasians of the internal and external nasal valve angles using a 3D multiplanar reconstruction. And you can see that there's a wider internal and external nasal valve angle in Koreans. Next, I will show you briefly using clinical cases some techniques for improving the internal nasal valve. So most of these procedures are usually used in combination. This is a young male patient complaining of bilateral nasal obstruction. On frontal view, he has a narrow middle vault. His Cottle test and Q-tip test was positive, showing a collapse of the internal nasal valve. On lateral view, he had a slight dorsal depression. So to improve the narrow internal nasal valve, we separated the upper lateral cartilage from the dorsal septum and then placed bilateral spreader grafts. On top of the spreader grafts, we have placed a dorsal onlay graft and then placed a flaring suture of the upper lateral cartilage to strengthen the lateral sidewalls in the upper lateral cartilage region. So the spreader graft opens the internal nasal valve and improves the static obstruction. It also widens the middle vault, however, does not reinforce the lateral wall, so it cannot resolve the dynamic lateral wall collapse. Therefore, it is often used in combination with other procedures. One of them being the flaring suture, where you place a mattress suture on the lateral edges of the upper lateral cartilage, and you use the dorsal septum as a fulcrum. This is a pre and post-operative frontal photographs. There's not much change in the appearance of the external nose. However, on close-up view, you can see that the width of the mid-dorsum has increased, so has widened a little bit. There's an increase in mid-dorsal height because of the onlay, and also improvement in static and dynamic nasal obstruction. This is another case, a young male patient complaining of nasal obstruction. He also has a narrow middle vault and a positive Cottle test, and was determined to have an internal nasal valve problem. So we placed bilateral spreader grafts for opening up the internal nasal valve. Also, both upper lateral cartilages was very weak, causing a dynamic collapse during inspiration. There's a slight recurvature of the upper lateral cartilage. Therefore, with the septal cartilage, we placed bilateral upper lateral cartilage baton grafts. So the upper lateral cartilage baton grafts will strengthen and stabilize the upper lateral cartilages and avoid lateral wall collapse. So a good indication would be in a patient who has a narrow middle vault and an internal nasal valve dynamic collapse. This is a pre and post-operative frontal photographs. You can see that the mid vault has widened, but has improved the overall appearance of the external nose. Again, a little bit of fullness or widening of the middle vault on chin and chest view, and a slight elevation of the dorsal line on the three-quarter view. This is a young female patient complaining of nasal obstruction. If you see her external nose, she has a mid-vault pinching, a narrow middle vault, and also a supratip depression on her three-quarter view, and she has an internal nasal valve problem. So in this patient, I harvested the ear cartilage and placed it in the region of the supratip to lift the caudal margin of both upper lateral cartilages using the natural curvature of the ear cartilage. So this would be the butterfly graft. So the butterfly graft, using the natural curvature of the concave cartilage, will lift up the upper lateral and also the cephalic margin of the lower lateral cartilage as well, therefore improving the internal and external nasal valve collapse. You have to be careful of a polypic deformity. However, it is a good indication if you have a supratip depression. So it's kind of a breathe right implanted into your nose. Pre and post-operative photographs shows the improvement of the mid-vault pinching and more definition of the nasal tip as well. And also you can see the improvement of the supratip depression because of the butterfly graft. And again, improvement of the mid-vault pinching in the frontal views as well. And finally, I'm going to introduce some techniques for the external nasal valve. This is a male patient complaining of bilateral nasal obstruction. This is a short video clip of the patient. He has had multiple nasal surgeries, including a septoplasty. His facial photographs shows a supratip depression on the lateral view. His nasal septum was quite straight. No issues with the inferior turbinate. The CT scans also show that there is no anatomical problems in his nasal septum. He has a dynamic collapse of his nasal sidewalls bilateral. I'm performing a Q-tip test to try to identify the epicenter of collapse, which would be quite there in between the internal and external alar nasal valve. So I decided to perform a butterfly graft. I'm harvesting the ear cartilage from an anterior approach. This is the ear cartilage. I'm determining the epicenter of collapse, which would be in the scroll area and the caudal margin of the upper lateral cartilage. So I'm trying to mobilize the lateral wall and to stabilize it. This is the butterfly graft in situ. And after that, to further stabilize the lateral sidewalls, I am performing a alar baton graft. First, I'm dissecting a pocket for placement of the baton graft. This is the bony piriform aperture, so it's quite lateral. Then I'm designing the baton graft from a residual piece of septal cartilage. and then placing the beaten graft in the pocket, which is extending laterally to the bony piriform aperture. So this is the placement, which is quite lateral, and the lateral margin is extending to the bony piriform aperture for stabilization. So this is after conclusion of bilateral Baton grafts. So this is 4 days afterwards. I can see that there's still some swelling. However, the lateral wall collapse has improved quite substantially. So the pearls of performing a alar Baton graft is to place the Baton graft in a non-anatomical position. So you don't place the Baton graft on top of the alar cartilage. You place it laterally in the soft tissue area. So it's more lateral and cephalic, and it's oriented to support the cephalic alar valve. And it has to extend to the piriform aperture for maximal stabilization. This is a pre and post-operative facial photographs. You can see that there's a little bit of fullness in the lateral nasal wall, which was predicted and told to the patient before surgery. Improvement of the dorsal depression due to the butterfly graft, and the improved dorsal profile on the three-quarter view. This is a young male patient with left nasal obstruction. He had a history of trauma when childhood. On his external appearance, he has a depressed left alar region causing alar nasal valve collapse. After dissection of the nasal tip, you can see that compared to the right side, the left lateral crura is curled inside, causing recurvature and obstruction of the alar valve. I've dissected the mucosa off of the lateral crus and placed a lateral crural strut graft. You can see the lateral crural strut graft has improved the recurvature of the alar valve. So the lateral crural strut graft, which is secured beneath the lateral crura, can improve nasal valve collapse due to the alar deformities or the lateral crural deformities. It strengthens and lateralizes the lateral crura and supports the alar valve. This male patient complaining of nasal obstruction has multiple factors. He has a deviated nasal septum and a deviated external nose. And also you can see a prominent alar groove and a drooping of his nasal tip. After degloving, you can see that there's a severe concavity, bilateral concavity of the lateral crus, causing a severe alar valve collapse. So a severe concavity above, and from below it would be a recurvature. I've dissected the vestibular mucosa off of the lateral crus. I've cut the medial and lateral part of the lateral crus and then turned it over in a flip-flop fashion of the lateral crus of the lower lateral cartilage so that the convexity is facing to the dorsal side and the concavity is facing to the nasal side. Pre and post-operative pictures after performing the flip-flop procedure. You can see the concavity has been changed to a more convexity, and I've sutured in place so that the alar margin has come down a little bit more to improve the alar retraction. Again, another view after the flip-flop procedure, the concavity changed to a more convexity of the lateral crus. And this is the pre and post-operative facial photographs. It is quite early because he was coming from abroad. And also you can see that the severe alar groove has improved. And also the alar retraction has improved as well. Alar rim grafts are traditionally used to support the rim valve of the external nasal valve because it increases the support of the alar rim. In these pictures, it has been introduced through a separate incision, but if you perform a open rhinoplasty, it can also be introduced from the medial side of the alar rim. This is a young female patient complaining of nasal obstruction. You can see that she has a weak, narrow sidewall as well as a dynamic internal and external nasal valve collapse. So I've placed bilateral spreadographs to open the internal nasal valve, a septal extension graft, and bilateral alar rim support grafts, as you can see here, to support the external nasal valve or the rim valve. Postoperative pictures show a slight widening of her middle vault and also support of her external nasal valve or the rim valve. This is the last case. She's complaining of left side nasal obstruction, which was caused after a draft 3 procedure where she had a nostril injury and scarring because of the thermal injury of the drill. She has the rim valve stenosis, and this is also common if you use a Foley for epistaxis, posterior epistaxis control. So I performed a wide scar lysis, placed a cartilage graft for rim support. The cartilage graft is quite big. You can see the pocket is from here all the way into the nasal floor. And then placement of a retroauricular skin graft into the rim nostril region. A silastic sheet bolstering was placed and kept in situ for 2 weeks. This is a postoperative 1-year photograph with a patent rim valve and nostril, and an endoscopic view with a patent nasal airway and well-taken skin graft, and a quite stable rim valve. So the take-home message, Asians also have nasal valve problems. It is another cause of nasal obstruction. There are various surgical techniques for the internal nasal valve, alar nasal valve, and the rim nasal valve. It can be performed alone or more commonly in combination. The choice of technique depends on the epicenter of obstruction and the concomitant external nose deformity. Nasal valve procedures frequently involves changes in the external appearance, which generally results in a more harmonious nose. Lastly, I would like to stress that the nose is primarily a breathing organ, and therefore form and function must go hand in hand. With that, thank you for your attention, and I really hope that you keep safe until we meet very soon again in the near future. Bye bye.
Dr. Hong Yer Jin will be speaking on common functional issues and their solutions in revision rhinoplasty. He is the director of Dr. Jin's Premium Nose Clinic, Republic of Korea, and he has won the Academic Achievement Award from the Korean Otolaryngology HNS Society.
Hi, I'm Hong Yoo-jin from Dr. Jin's Premium Nose Clinic, Seoul, Korea. This time I want to talk about nasal obstruction issues after rhinoplasty, which is very common. So when we do rhinoplasty, it's very important not to sacrifice nasal function for form. But unfortunately, 5 to 20% of patients develop nasal obstruction after rhinoplasty. When you see these kind of patients, the location of the obstruction and anatomic etiology are two important factors that we should consider. Evaluation is often complicated by scarring, altered anatomy, lack of operation data, and preoperative findings. So this is the summary table of the location and anatomic causes of nasal obstruction developed after rhinoplasty. The most common location is the septum. It can be an uncorrected one or a newly developed one. The most common sites are caudal and dorsal deformities. Secondly, superior middle vault is commonly involved, which is upper lateral collapse after aggressive hump resection, or if you do too much medialization after osteotomy, it can cause also the middle vault static obstruction. Thirdly, tip and lateral cross, which is very common pinching phenomenon after lateral cross suturing or too much recruitment, or the lateral cross can be paradoxically concave, or the alar rim can collapse. And nostril, which is an external valve, the cicatricial stenosis is very common. If you do over and over again the open approach, you can cause a lot of stenosis, cicatricial stenosis of the nostril, which is very difficult to correct. Sometimes the alar base seal excision can be too aggressive and it can cause nasal obstruction too. Columellar deviation thickening is common, and dorsal collapse, which can be a disastrous phenomenon, loss of septal support, nasal bone, and upper lateral collapse, typtosis, all totally causes nasal obstruction. And finally, mucosal lining can be a problem, and sometimes mucosal hypertrophy or loss can cause nasal obstruction. So first, the septum. Pre-existing septal deformity can be undetected. It can be diagnosed but not corrected properly, or even newly developed septal deformity can occur. Turbinate hypertrophy, synechia, perforation are also commonly combined after septal rhinoplasty. Recently, tip surgery is stressed, so a lot of people do septal extension graft, which can be malpositioned if it's not adequately fixed to a very stable caudal septum. So these are all causes the problem of the septal deviation and nasal obstruction. This is one article that I published, which described the sites, etiology, and solutions of persistent septal deviation in revision septoplasty. I analyzed 100 consecutive revision septoplasty patients and analyzed those factors. So what I found was the sites of residual deviation in revision septoplasty, it was the center of the septum, which is the area of transition from septal cartilage to septal bone. And secondly, caudal septal deviation was also a problem. And also 21% showed whole cartilaginous deviation. The bony deviation was rarely a cause for revision septoplasty. Then what are the procedures to correct the persistent septal deviation? A lot of people do timid chondrotomy. I mean timid separation of the cartilage from the bony septum. And they conservatively remain a lot of deviated portion because they are afraid of the keystone collapse. So proper chondrotomy and conservative excision of the deviated portion solve the problems. Second most common cites the caudal septum, which was properly corrected by septal batten grafts. And spread grafts help to stabilize the dorsal deviation. And also suture fixation of the caudal septum to anterior spine was necessary. The caudal septal deviation can be either fixed with a batten graft, but also by the curvature cut and realignment with the sutures. Sometimes, very rarely, septal reconstruction, either partial or total, was necessary. Here is an illustrative photos of the surgical patients which had remained septal deviation. If you look closely, I did a chondrotomy all the way up to the dorsal portion. And the caudal septum, the cartilaginous septum, has many cross-hatching incisions. So even though this caudal septal deviation is remaining, the main cause of this deviation is timid chondrotomy, which did not conservatively excise the deviating portion. So this is the cross-hatching incision of the cartilage to correct the deviation, but it did not work. It's an old technique and it's no longer used anymore. So if you see a septal deviation, especially at the caudal area, you need to use other methods. So here you see a caudal septal deviation causing nasal obstruction after rhinoplasty. So I cut out the most convex either or concave portion and overlap it and sutured, and it made the caudal septum straight. So this is the curvature cut and overlap with the sutures. Or you can straighten the deviated caudal septum by using batten graft with a septal bone like this. You make a hole with an 18 gauge needle, and it can be a very useful strut or splint or batten to correct the caudal deviation. So here is one case complaining nasal obstruction left side after silicone rhinoplasty. You can see her dorsum is very smooth, nicely augmented, but you can see the caudal septum has been deviated to the left side. Surgical photos show a silicone implant on the dorsum, cat grafted by conchal cartilage on the tip, but you can see the caudal septum has been deviated to the left side very much. It's because septal extension graft on the left side was crooked by skin pressure after surgery. It was not properly fixed or positioned, so I removed it with the silicone and the grafts and the septal extension graft and made it straight by splinting grafts on the caudal septum. So the dorsal silicone implant was replaced by recartilage graft with a folded temporalis fascia and the caudal septum has been reconstructed by a straight piece of recartilage, and tip has been rebuilt. But this is only 1 month after surgery, but you can see the dorsum has been nicely replaced with recartilage grafts. You can see the shadows of brow tip aesthetic lines bilateral, and tip has been lowered a little bit. There was a little too much cephalic rotation and too much nostril show, which was decreased after surgery. And this is the lateral view showing almost same dorsal height, but the tip has been lowered a little bit very naturally. So this is a three-quarter view. You can see the tip shape improvements. This is the highlight view of the basal view, showing more symmetric nostril, which means the caudal septal deviation by malposition, the septal extension graft has been corrected nicely, and she can breathe better with even better shape of the nose. Another case showing a deviated nose with nasal obstruction after rhinoplasty with a silicone. The basal view shows straightened tip and caudal septal axis deviation, and he has no longer nasal obstruction anymore. And now we move to the middle vault. What happens to the middle vault if the patient complains of nasal obstruction after rhinoplasty? What I found significantly common was inferiorly medially collapsed upper cartilage after hump resection, especially when the hump was large and it was resected and was covered by silicone, but there was nothing done to prevent nasal obstruction after hump resection. So the inferiorly medially collapsed upper cartilage causes airway obstruction and nasal obstruction. And secondly, when you do a lateral osteotomy or medial or lateral osteotomy, too much medialized bony pyramid can cause nasal stenosis because the upper lateral cartilage connected to the nasal bone comes inward a little bit, and it causes nasal valve stenosis. And thirdly, when there were multiple surgeries, damaged weak upper lateral cartilage collapsed into the nasal cavity can cause nasal obstruction. So here is one case. She had multiple surgeries on the face and the nose, but you can see the previous surgeon marked medial lateral osteotomy, hump resection, and onlay grafts on the nasal dorsum. And after surgery, her nose looked like this, but she complains of nasal obstruction bilateral. You can see a little bit of depression on the bony cartilage junction. I think it has been developed by hump resection. And the nasal bone has been medialized after lateral osteotomy, and tip is a little bit pinched. She brought her own 3D model after CT taking, and you can see the bony pyramid is deviated to the right side. Nasal bone has been cut and medialized a little bit. You can see it from the axial view. So when she breathes in, there is a little collapse of lateral nasal wall. Bilateral spreader grafts were placed to widen the airway. After that, a butterfly graft using conchar cartilage to strengthen the lateral nasal wall and to prevent the collapse with inspiration. This butterfly graft has been done, and it also camouflages slight depression on the mid-dorsum. This is months after surgery, and you can see that her middle vault collapse has been corrected and other things did not change. So this is a magnified view showing improved width of the middle vault and the tip shape. And lateral view shows the middle vault collapse has been corrected. Three-quarter view. The basal view shows also an improved brow tip aesthetic line and the middle vault width. And she no longer has lateral collapse with inspiration, and she can breathe much better than before. What are the common causes of nasal obstruction at the tip and lateral crura area? Commonly, pinched tip, which is formed by recurvature of the lateral crus after dome binding sutures, can cause nasal obstruction. Paradoxical concave lateral crus, damaged over-resected lateral crus, or even dynamic collapse of a lateral wall during inspiration by too much excision of the lateral crus can be a cause of nasal obstruction. Here is one case showing a nasal obstruction after rhinoplasty. He also had an alar base resection and septoplasty and a lot of procedures on the tip and the dorsum. So the endoscopic view shows very narrow external nostril inlet with a little bit of medial crural base widening, and you can see it's not clear, but a little bit of concavity and obstructions of the lateral crus area at this portions bilaterally. The operative photo shows very concave lateral crus. Here you can see bilaterally, which plunges into the nasal cavity and causes a little bit of obstruction at the nostril inlet. The cephalic turn-in flap, which means insides and the cephalic portion is folded into undersurface of lateral crus, and also a lateral crural strut grafts has been done to straighten the curvature of the lateral crus. So bilateral turn-in flap, bilateral lateral crural strut grafts were done, and also teeth grafts were done for cosmetic purposes. This is an early post-operative photos, but you can clearly see the overly indented superior alar groove has been corrected by the maneuvers that I explained, the lateral crural strut and lateral crural cephalic turn-in flaps, and tip has been elevated a little bit. This swelling will go down with time, and it will make the brow tip aesthetic line slimmer than now. This is a basal view showing improved tip projection, and lateral crural pinching was well corrected. So the nostril size may look narrower than before, but you can see the inlet inside the nasal cavity is wider than the pre-surgery status, so he can now breathe much better. What happens to the external nasal valve, I mean the nostril inlet, when the patient complains of nasal obstruction? A very diverse etiologies. Columella thickening can cause nasal obstruction. It can be caused by too much grafts or foreign body inflammation. Columella deviation can cause nasal obstruction. Over-resected alabase may narrow the nostril inlet, or disastrous thing, nostril cicatricial stenosis can be a cause of nasal obstruction. So here is one case who complains of nasal obstruction after rhinoplasty. So this is her CT scan showing some shadows on the premaxillary area, and this very thick widened columella causing nasal obstruction. Surgery revealed pus coming from the premaxillary area, and you can see the grafts, premaxillary grafts, 3 layers of silicone has been removed by operation. The swelling and infection caused by this premaxillary silicone graft was the cause of nasal obstruction. This is after surgery, which shows a patent nasal airway. Another example showing nasal obstruction after rhinoplasty. He complains of left nasal obstruction only, and the basal view shows clearly curved, deviated columella, which is the main cause of left side nasal obstruction. He had a silicone implant which was replaced by recartilage, and septum was okay. Only the deformity of the medial crus of the tip cartilage was the main cause of the columella deviation causing left obstruction, which was corrected. The columella deviation by medial crural deformity was well corrected, and you can see bilaterally symmetrical patent nostril inlet. Multiple rhinoplasty causing cicatricial stenosis of the nostril. She only can breathe through this small catheter through her nostril. Correcting cicatricial nostril stenosis is very challenging. You can do a multiple Z-plasties along the caudal border of the nostril. Also, you need to do a composite grafting after widening the seal area after scar removal. Even after successful stenosis surgery, you need to keep the airway for about 6 months to permanently maintain the nostril size. So this is years after surgery showing a widened nostril airway. Unfortunately, she can breathe much better through her nose. But sometimes a severe scar contracture, cicatricial stenosis, needs a tissue transfer either from the forehead or either from the forearm to reconstruct nasal lining and defected tip and columella. And here she used the forehead flap to cover the deformity of the columella and the tip, and the airway stenosis was much improved by this kind of surgery, and she can breathe much better through her nose. Lastly, dorsal collapse, which means significant loss of structural support, especially the septum, and it can be caused by overly resect the cartilage or infection necrosis. So the saddle, upper lateral collapse, columellar retraction, tip-tip projection, multiple phenomenon can occur. And reconstruction of L strut, middle vault reposition, and tip support, and dorsal augmentation are all necessary procedures to relieve nasal obstruction and improve cosmesis. Here is a lady who had 10 rhinoplasties, including 2 self-ripped cartilage. Now she has a contracted saddle nose, retracted columella, nasal obstructions, and she wants cosmetic and functional improvement. Operation photos show a total collapse of the dorsum. There is no septal support at all, and the septum shows melted down rib cartilage and upper lateral cartilage collapse as well. Surgery included cartilaginous septum support with the septal replacement and also the middle vault reconstruction, and a drill for the fixation was needed at the nasal bone, and K-wire fixation of the dorsal graft after septum reconstruction, recartilage. So you can see the surgical photos, the whole septum was replaced by the recartilage. Of course, the upper lateral cartilage is reattached to the new septum. This is about 1 month after surgery. You can see well-augmented dorsum and the septum, which shows a nice brow tip aesthetic line after surgery. Three-quarter view shows the dorsum augmentation, and the lateral view also shows a well-augmented dorsal bridge with intact tip support. And inside the nasal cavity, the whole septum was newly constructed, holding the dorsal rib cartilage onlay grafts. And this is the basal view. The scar will improve with time. So in summary, I told about common causes of nasal obstruction after rhinoplasty, exact location and anatomic etiologies of obstruction, and site etiology-specific techniques to solve those problems. So after this lecture, when you see a patient complain of nasal obstruction after rhinoplasty, I hope you can wisely solve those problems. Thank you so much for sharing your valuable time with me, and I was very honored to be part of this program. Thank you.
Dr. Dong Hak Jung will be presenting on the various septal reconstruction techniques. He is the president of the Asian Society of Asian Cosmetic Surgery, past co-chairman of the International Congress of Cosmetic Surgery, professor of Inha University Medical College, visiting professor of Yonsei University, and the manager of Shinmya Rhinoplasty Clinic.
Good morning, everybody. What I'd like to discuss today is about nasal septal reconstruction. Septal reconstruction, there's two reasons. First, there is no septum, absent septal cartilage. Second thing, weak cartilage support. In that case, we have to do septal reconstruction. The best material for septal reconstruction, that is costal cartilage. Typical appearance of the no septum, that is like this, cellulose and then retracted columella. Two things, typical appearance. In this case, we have to prepare septal reconstruction. It's most common causes nowadays, septal reconstruction, that is contracting nose case. In her case, there is no septum. Then there is no recoiling force. When you give a pressure, it totally collapsed. In that case, no septum. If she doesn't have septum, if you give augmentation, it will make problem. Then you have to, the first step, the septal reconstruction, and then the augmentation. Then you can get the better result. The causes of septal reconstruction, that is, already I said, first contracting nose, and then after septal surgery, and then congenital anomaly, tumor, infection, hematoma, trauma, and so on. They have a contracting nose, no septum. She doesn't have septum, and then she also had septal perforation. Then she has Binder syndrome, no septum. It's congenital anomaly. And also she had T-cell lymphoma, and it's no septum. And then trauma. Septal reconstruction, there is, I think it's several ways. First, extracorporeal septoplasty. I think there is also kind of septoplasty, septal reconstruction. And then caudal septum problem, in the case, caudal septum reconstruction or reinforcement of caudal septum you can do. And then finally, whole septum reconstruction. Septal surgery, septal reinforcement, already I said. And also extracorporeal reconstruction. There is kind of septal reconstruction, I think. Then septal reconstruction is like this. I will show you later. And then the septal surgery. There is the first thing, caudal septal reinforcement. He had a very, very thin caudal septum, and then there is incision. Then just less than 4-5 millimeter, they're very weak. Then I gave one piece of lip cartilage, but its curvature is different. One curvature and then the other curvature like this, it stitched together can make strong support. Weak caudal septum then means it's a caudal septum, no caudal septum, and then already you saw it's very weak, or below part no caudal septum. In that case, we can do two ways. First, caudal septal reinforcement, already you saw, and then caudal septal reconstruction. I will show you later. Anyway, after caudal septal reinforcement, the result. The extracorporeal septoplasty to make whole septum. He had a really serious septal deviation, then took out the whole septum and then made like a new septum with septal cartilage, sometimes ear cartilage together, and then insert like a septal shape. In that case, no need fix to the keystone area. Yeah, it's you can do. And then he doesn't have septum, no septum. And then the previous clinic, they gave him augmentation. It's no septum, but Then the augmentation is so many pieces of Gore-Tex because no supporting structure, just insert Gore-Tex, 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 so many Gore-Tex, almost 2 centimeter. In that case, yeah, of course you can get the augmentation, but the septum will go down. There is maybe breathing problem. As I made new septum with septal cartilage and then lip cartilage. Then like a septum, then I insert. Almost no augmentation, just septal reconstruction, kind of extracorporeal septoplasty. Then it's we can get the enough height. There's the second way. The first thing is whole septum, like a whole septum and insert. But you can use L-shaped septum. It's took out the cartilage and then L-shaped. In that case, you have to fix to the keystone area and then nasal spine. You have to fix. It's now it's nasal spine puncture and fix this part, and then usually remnant of septum is together, stitched together, and tip surgery. It's same way, same. They take out and then L shape, then insert. Now it's we start. Let me show septal reconstruction, not septal surgery. The first thing, caudal septal reconstruction. There is no septum, no caudal septum, and just using the lip cartilage, then like a septum. Very simple. Then first caudal septal reconstruction, then reconstruction. It's a contracting node case. Yeah, it's caudal septum is very weak. It's almost remnant, not cartilage, a kind of soft tissue, and then there's some defect. It's very weak. And the first, I just stitch it together. But as you can see, it's very weak, still very weak. And then using the lip cartilage, no piece of cartilage, and then caudal septal reconstruction I did. It's my books. Nowadays, my new book, volume 3. It's a septal reconstruction that just I showed you the caudal septal reconstruction, but it's the other way, the one piece septal reconstruction. It's like a original septum using the lip cartilage carving like original septum and then insert. He just did septal reconstruction, but looks like augmentation. It is same, just septal reconstruction. It's like this, carving and then insert. In this case, it's a long axis carving like this. Maybe can induce easily the warping. Then, but it's the older people, not a big problem. 40 to 50 in that kind of patient, they almost no warping. Then in that case, you can use whole piece, just one piece cartilage. Then like septum insert and the operator cartilage attach. Just septal reconstruction, septal cartilage reconstruction. It's very nice. The one-piece reconstruction with augmentation. So septal reconstruction using the rib cartilage and then augmentation together. You can get the good result. And also, if you use long one, in that case, no need tip surgery, just no need strut, no need extended spread graft, just one piece, it's possible. But it's too big, in that case, can happen easily, warping, then should be careful. It's just one piece, just strut, and then ESG together, and then tip surgery together, longer and higher. The L-shaped reconstruction. If there is a big septal perforation in that case, and also septal mucosal problem, in that case, you can use L-shaped reconstruction. It's like this, but sometimes a different shape you can also use. She had a big septal perforation. Is just one piece like this. Insert, fixed to the nasal spine using the wire. Then finally.
In this older but nevertheless relevant video, we demonstrate our application of the monounit rib cartilage L-shaped septal reconstruction. We mainly reserve this for cases of the large septal perforation and saddle nose, where we need to create a strong straight septum that will be able to withstand dorsal augmentation. As you can see, we have added supporting batten grafts on either side of the caudal component of the L-shaped septal reconstruction graft. We call this the reverse T-shaped strut configuration. It allows the strut to remain stable as it locks down over the anterior nasal spine and maxillary crest. We have discussed this in more detail in another video. The entire L-shaped unit is sutured to the septal remnant posteriorly and the upper lateral cartilage dorsally. The lower lateral cartilages are then mobilized and sutured to the new septum. Over the tip, we have added perichondrium to protect the overlying skin from the hard rib cartilage beneath. This concludes the case.
She had contracting nose case. She is also contracting nose case. The filar reconstruction with dorsal graft. There is it's a strong, it's strong support. He is also Binder syndrome. It's a no septum, and then it's like a pillar. It's big and then thick one. And there is a maxillary crest. It's a I made groove for the maxillary crest, and then stitch it together, fix the pillar like a septum here. The strong support, and then finally augmentation. It's almost 1, 2, 3 centimeter augmentation, kind of 3 centimeter augmentation. And then fixing, I used wire fixation. It's like this. And she is also same. There is no septum. Then it's like a pillar. It's a strong support. And then this is for the augmentation, the rib cartilage augmentation. It's finally like this. And then truss structure is using lock technique. It's the most commonly I favorite technique, that is truss structure nasal reconstruction. There is, truss structure. They bridge, there are two ways. One is a suspension bridge. Then the other one is a truss bridge, truss structure bridge. It's the same. It's one long ESG and then two legs. There is relatively strong support spontaneously. It's a lock technique, that is lapping of coastal cartilage technique. It's the first thing, it's like this. It's ESG and it's a lapping of using coastal cartilage. There is strut and ESG, but if there is no septum, in that case, one more strut, like a strut here. And then we can, and also usually I use a short axis curving like this. But if you use long axis curving, in that case, can happen easily warping. Then it's my recommendation, that is short axis curving. When you use truss structure septal reconstruction, in that case, my recommendation, my suggestion, that is short axis curving. That is better. It's my article. It's first for septum, and then second thing for tip surgery. And also long ESG. You don't need fixed to the keystone area. Just the upper lateral cartilage stitch. It's okay, because there is a septum, and then there is one strut. There is two legs, relatively strong support. Usually I don't do keystone area stitching. I don't do. She doesn't have septum. There's one piece of cartilage that for septum. And then second thing, there is strut. Yeah, it's like this. Then cut, and this lapping lock technique. The same. There is no septum. It's one legs here for septum, and then the end of ESG there, one more cartilage is strut, and then there is a perforation using the perichondrium. Then it's a septal septum, then upper cartilage. Then there is long ESG, and then one piece of cartilage for septum. And then finally, it's a strut, one strut. It's then it's covered by perichondrium for smooth. It's the same. Okay, you can see the video. He is 21 years old, young man. It's a typical appearance. It's a cellulose like this, and then retracted columella. It's a typical appearance, but it's just no septal perforation, and the septum is almost straight. Usually 4 to 4.5 centimeter carving for bridge, and then short axis carving for the tip surgery, and then septal reconstruction. It's a short axis like this carving. There is a cortex, medulla, and cortex. If there is a cortex and medulla cortex, in that case, warping is very, very rare. It's carving. As I said, lapping, it's a lock technique. Because like this, stitch will make a strong support, and then it's two cartilage is very thick. It's half remove, half remove. In that case, the width is not too much thick. You don't need keystone area. You don't need stitch fixed to the keystone area. Just upper cartilage stitch, it's okay. But when you make a pocket for the 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 neo septum, then it's possible. It's small pocket is better. It too widely. If you make widely pocket, in that case, it's not stable. It's a hump remove. He had a small hump. They make a smooth using the less. And then it's a lock technique also for tip surgery. For augmentation, bridge augmentation, for tip surgery. Uh, in case of contracting nose or small nose, the stitch is very difficult. Then release for below part of transcolumnar incision, you can stitch easily. Immediate post-op. whole septum reconstruction with strut and ESG. That is it's almost same, but it's a little bigger one. Usually I made, in case of truss structure septal reconstruction, in that case, strut and septum is almost same width, but in this case, sometimes you can use big septum and then ESG and strut you can use. There's no septum collapse totally. Then it's a little bigger one you can use. And then it's same, almost same, truss structure, almost same. And then septal perforation together. It's many cases, they are no septum and then also septal perforation. In that case, you have to do septal perforation fixed together. There is septal perforation. And it's just like this, septal reconstruction, but they just septal perforation is a stitch. There is small perforation. In that case, using the perichondrium, you can cover the small perforation. Generally, just the perforation case, just one side stitch and one side, the other side, you can use perichondrium, the other things. But when septal reconstruction together, it's possible both sides closure is better. The operation. And then sharp shaped reconstruction, they also. It's a 1, 2, 3, 4, 4 things. It's almost same truss structure, but it's a stronger. It's 1, 2, 3, 4. 1, 2, 3, 4. It's you can use it like this way. It's as I said, most common cause our clinic, the septal reconstruction, there is contact nose, because the contact nose patient, they have already so many times operations, then finally there is no septum. Then also X-graft you can use. Usually X-graft just for tip surgery, but if there is no septum, in that case you can use type 3 or type 2. So you can carve the long one for substitute septum, long one. It's ESG and long cartilage. Sometimes it's not stable. In that case, you use one more thing. This one is usually for tip surgery. Then septal cartilage, just one or two pieces of cartilage can use for tip surgery. But septal reconstruction, you should use a long one. There's no septum. In that case, it's long one from the maxillary crest area, and then long ESG. It's like this. You can get the same result. You can get the same result. Okay, this is my new book. Okay, thank you, everybody.
한국인을 넘어 세계인을 지킵니다. 한국에서 만들고 세계로 수출하는 개인용 공기살균기 컴투게더.
노인층의 백신 접종이 시작되었지만 노인 치명률은 해결되지 않아 집단 면역이 형성되기 전까진 개인 방역에 더욱 철저히.
여보세요?
여보. 이번에 우리 어버이날 선물 공기살균기로 할까?
코로나 시대 가장 좋은 효도 선물은 방역입니다. 부모님께 방역을 선물하세요. 컴투게더 V.
Dr. Yongju Jang will now be presenting on the importance of dorsal augmentation and deviated nose correction. He is the head of the Department of Otolaryngology, University of Ulsan College of Medicine, Asan Medical Center. He is also the professor at the Department of Otolaryngology, University of Ulsan College of Medicine, Asan Medical Center.
Thank you for invitation. This is Yongju Jang from Asan Medical Center, Seoul, Korea. I'm working as a professor and department chair of the Department of Otolaryngology in Asan Medical Center. Today I'm going to talk about the importance of dose augmentation in deviated nose correction. Correction of deviated nose is one of the most difficult area in rhinoplasty because we have to pursue the complete correction of the function, and also we have to pursue to achieve to make the beautiful nose as possible. Several anatomical components are responsible for deviated nose. Nasal bone, upper lateral cartilage, quadrangular cartilage, and lower lateral cartilage, and maxillary spine, all nasal anatomical components contribute to form a deviated nose. I strongly believe that the correction of the deviation is basically a destructive surgery because we have to perform osteotomy, and in almost all cases we need to divide the upper lateral cartilage from the septum, and when the patient has combined hump, we have to reduce the hump, which can result in a weakening of the keystone area, and patient has septal deviation. In that case, we have to resect the deviated cartilage and bone. I think all these procedures can result in the loss of the intrinsic support of the nose. So that's why the correction of deviated nose has a destructive nature. First, we can think about osteotomy. Yeah, this is essential procedure for correction of bony axis deviation. As you can easily imagine, this osteotomy is destructive. It can cause unpredictable healing, and it can cause secondary deformity. And to correct the axis deviation, what I do mostly is medial osteotomy first, and then I usually make lateral osteotomy. And then if there's a persisting axis deviation in the middle part, I try to make a controlled fracture line right here. But in some cases, it's very difficult to make the controlled fracture line exactly at the point I want to make. So in that case, I perform a percutaneous root osteotomy. This is also a destructive procedure which can increase the risk of unpredictable healing. And so usually the bony axis deviation is corrected with osteotomy, but the more difficult part of deviated nose correction is correction of cartilaginous deviation, as shown in these cases. To correct the cartilaginous deviation, the technique I use most is placement of the spreader graft. In order to place spreader grafts, we have to separate the upper lateral cartilage from the septal cartilage, and this should be reconnected. I think this procedure is quite a destructive procedure which can alter the original anatomy of the cartilaginous dosum. This is another technique I publish it. I call this as dorsal L-strut cutting and suture technique. This technique is quite useful for straightening the badly deviated dorsal L-strut as shown here. So briefly, I can explain this. I cut right here at the convex most part, and then I make a little bit of overlap, then I suture it, then you can easily straighten this deviated dorsal L-strut. So by combining this bone work and cartilage work, we can make the nose, the deviated nose like this, into much more straight one. And lateral view, three-quarter view also show improved dorsal height and This is another case who has a linear deviation like this. To correct this, I had to perform osteotomy right here, and then I placed the spreader graft on the right side. And as you can see, his dorsal line is much more smoother and well balanced compared to pre-op. In this patient, I performed osteotomy right here, and the spreader graft was placed on the right side, and a little bit of camouflage graft was placed on the right side. And as shown here, her dorsal line is much more smoother and natural looking and a little more augmented. Let me show with you this case who has deviation to this way and mild dorsal convexity. So I opened her nose and I exposed the caudal septum and nasal bone. Septal bone was used to straighten the caudal septum, and caudal septal extension graft and extended spreader graft with septal cartilage was placed to straighten her entire nose. So as you can see by this effort, her nose looks much more straighter compared to pre-op. This is post-op. Her nose looks much more straighter now. And the base shows balanced look, and hump is gone, and mild augmentation was done, and tip augmentation was performed. In patient who has quite severe, very severe deviation, I perform modified extracorporeal septoplasty, which I published in 2009. In this technique, I remove the badly deviated cartilage and bone with preservation of little bit of cartilage at the keystone area right here. This is a new anstrut which was formed extracorporeally with septal cartilage, and then I reinsert this new anstrut. This was fixed at the preserved cartilage and fixed at the soft tissue around the anterior nasal spine. So this patient visited me with severe nasal obstruction and badly deviated nose like this. So I opened his nose and I harvested his septal cartilage, and I formed a new anstrut, and I re-implanted this new anstrut, and additional tip grafting was done using septal cartilage. As a result, now his nose looks much more straighter compared to pre-op photo, and profile view shows increased tip height and increased dorsal height. This is another case who also came to me with severe deviation in this way, so I chose modified extracorporeal septoplasty to correct her deviation. Frontal view shows a nice result, and three-quarter view shows well augmented nasal dorsum and well projected nasal tip. But you have to know that very often we encounter the patients who are not satisfied with the surgical result. The common reasons for this aesthetic dissatisfaction after deviated nose correction is, first, many patients complain dorsal irregularity occurring later on. This can be early complication or the delayed complication. Secondly, many patients complain that inadequate degree of dorsal augmentation because most Asian patients want correction of deviation and simultaneous augmentation of the nasal dorsum and nasal tip. If this was not successful, they complain. And the difficult part of the deviated nose correction is that the deviated nose is prone to recur because cartilage has elastic memory. If we fail to overcome this elastic memory, there is a high risk of recurrence of deviated nose. Dosal irregularity is a common complication after deviated nostril correction. The predisposing factor for dosal irregularities, first, the thin-skinned patient has high risk of dosal irregularity. And secondly, there's a phenomenon called the shrink wrap phenomenon. This is shrinkage of the skeleton and nasal skin soft tissue envelope happening after rhinoplasty, and this can increase the chance of the dosal irregularity. As I mentioned earlier, osteotomy is a destructive procedure, and this can increase the possibility of dosal irregularity. We place spread the grafts and reapproximate the upper cartilage during deviated nostril correction, and this can underlie the dosal irregularity formation. And we reconnect the apparatus from operator cartilage to the septum, and with the spread graft is fixed with the sutures. Sometimes the loosening of a suture can cause displacement of the spread grafts and cause the dosal irregularity. In some patients, we intentionally place camouflage grafts for the concave area, but this can also be the reason for the dosal irregularity. So let me share with you some cases. This patient underwent correction of deviated nose. This is a 6 months post result, 1 year post result. As you can see, there is a recurrence of deviation in 1 year post result. And in the profile view, the 6 months post result and 1 year post result is a little bit different. There is a recurrence of the dosal irregularity, as you can see here. This is another patient. This patient has a severe facial asymmetry. As you can see, the deviation correction was not that successful. Also, the 1 year post result shows dosal irregularity right here. So this was typical unsatisfactory patient after deviated nostril correction. So this is very important aspect, important message I want to deliver to you. I think the dosal augmentation is important in correction of deviated nose because this maneuver can cover up the minor imperfection caused by bone and cartilage works, and dosal augmentation can prevent the shrink deformity caused by shrink wrap phenomenon. And when we do hump reduction, when there is a secondary keystone damage, this augmentation can compensate the damage at the keystone area. And dosal augmentation also help to form a shape or ideal broad tip aesthetic line. And so ultimately, augmentation is important for satisfying the patient's wish. When it comes to dosal augmentation materials, the materials I prefer includes Gore-Tex, fascia, crushed cartilage, and diced cartilage. I prefer the Gore-Tex over silicone because this Gore-Tex is much more softer than the silicone. So I like to use the 2mm thickness Gore-Tex patch. The problem is now it's not in good supply. So recently I don't use this Gore-Tex because it's very hard to get. This is my early experience. After correction of the deviated nasal bone and cartilage, I placed the Gore-Tex right here, and she has much more straighter looking nose as shown here. And those was well augmented. The dorsal radix side is augmented as shown here. Another case, I conducted osteotomy and I placed the spirograft and I augmented here with Gore-Tex, soft Gore-Tex patch. As you can see, his nose looks much more straighter. And let me show with you one case with the video. This patient has deviation, C-shaped deviation like this. He also wanted augmentation and functional correction. So I opened his nose via open approach and septum is exposed and septal cartilage and bone was harvested, and I did osteotomy and I also performed percutaneous osteotomy. I drilled the bone and I used this as bony batting graft and I placed coronal septal extension graft and I reapproximated the opercular cartilage and I found that I need to perform dorsal augmentation and tip work, so I harvested ear cartilage and crushed ear diced cartilage was used for cartilaginous dorsal augmentation, and finally I placed Gore-Tex one layer. As a result, I could make his nose look much more straighter like this, and there was a slight degree of dorsal augmentation, not that much, but this is what this patient wanted to have. Another technique I use is using diced ear cartilage with perichondrial attachment, which I published in 6 years ago in PRS. As you know, the ear cartilage has intrinsic curvature, so if I dice it with the surrounding perichondrium, intact perichondrium, I can handle it very easily with the forceps. The other technique I use is the combined use of crushed cartilage with processed fascia. And this is my 2009 publication. So this technique is useful when there are not enough amount of cartilage. When we have just some pieces of leftover septal cartilage, in that case, we crush the cartilage, and then this is covered with fascia. So let me show with you one case, who is illustrative case of the combined use of fascia and crushed cartilage. She came to me with a complaint of deviated nose like this, and I opened her nose. Inverted V-shape incision was made, and I divided a platter from the septal cartilage, and I'm doing septal work for functional purpose and correction of deviated nose. Septal bone and septal cartilage was used as extended spreader graft and septal extension graft, and I crushed the leftover septal cartilage and I'm designing the fascia. The crushed septal cartilage was placed at the supratip cartilaginous dorsum, and the dorsum was covered with fascia. As you can see by this effort, her nose looks straighter, and there's a gentle augmentation was done, not that much, but this was what she wanted to have. And recently, my preferred technique is using cartilage mold to shape the glued diced cartilage. In this technique, I harvested the costal cartilage and I diced this cartilage with blade, and I disassembled this mold, this cartilage mold, which I invented, got patented, and I placed the fascia first, and then I paint this fascia with tissue glue. This is fibrin glue. It's commercially available, and then I place a little more diced cartilage, and I painted this little more glue, and then finally I compress this with cap. Here I have a dorsal implant which has convex outer surface covered with fascia and concave inner surface, and this is good material for dorsal augmentation. And I designed different lengths and thickness mold from which you can choose the right one, conforming the patient's wish and patient anatomy. And this is the final shape of glued diced cartilage shaped with my mold. In this case, the outer surface was covered with costal cartilage perichondrium. My technique is recently accepted at PRS, so I look forward to have the printed version of my paper. And this patient complained about his deviated appearance and low net dorsal height. So after correction of his deviation, I augmented his nasal dorsum with glued diced costal cartilage shaped with my mold. As you can see, T was projected and dorsum was augmented. Another case, deviation, low radix height is noticeable, and he has quite severe facial asymmetry. So in his case, I'm straightening his septum with septal bone and septal cartilage, and I decided to harvest costal cartilage for a little more straightening and augmentation of the cartilaginous septum, cartilaginous framework, and tip grafting was done, and dorsal augmentation was done with this diced cartilage shaped with my mold and covered with perichondrium. As a result, as you can see, his nose looked much more straighter, and dorsal augmentation was successfully done. And as you can see, radix height and dorsal height was significantly elevated. So it's good result. And another case, mild deviation and under projected nasal tip. So I used costal cartilage for tip projection, and dorsum was augmented with glued diced cartilage shaped with my mold. As you can see, he has well augmented nasal dorsum right here. Yes. Another case with deviation and mild hump. In her case, I performed a segmental augmentation using small, relatively short mold. So I designed the short piece of mold, and I augment the dorsum right here. I spared this hump area. Now, as you can see, nasal tip is significantly projected with septal extension graft, and dorsum looks quite balanced appearance, has a balanced appearance because of the hump reduction and augmentation at the radix and supratip. This is another case who came to me wanting the correction of deviation like this. I opened her nose and I found a silicone implant which was placed previously by a previous surgeon. I straightened her coral septum and I harvested costal cartilage, and I placed the bilateral extended spread graft. I placed caudal septal extension graft with costal cartilage, and I'm designing a dorsal implant using my mold. And this is the final shape of the mold. I'm trimming the margin, and I augmented the dorsum with this glued diced cartilage shaped with my mold. As a result, her nose looks much more straighter, much more balanced. Tip projection was achieved. Dorsal augmentation was nicely done. This was exactly what she wanted to have. When there are leftover diced cartilage, we can fill this diced cartilage into syringe, and then we can inject the free diced cartilage before or after closure of the transcolumnar incision. This is quite a easy technique to perform. And in this patient, after correction of his the deviation using the osteotomy and spreadograph, I augmented here by the injection of the free diced cartilage, and those was augmented from here to here, and tip augmentation was achieved with the coronal septal extension graft with costal cartilage. In summary, for a successful correction of deviated nose, you should be able to completely correct the bony and cartilaginous deviation by using osteotomy and spreadograph and many other techniques. But the problem is, these corrective procedures are easily associated with dorsal irregularity and dorsal concavity. So, if you perform a good dorsal augmentation, you can prevent these complications. So I would conclude that dorsal augmentation has critically important role, particularly in Asian patients, in achieving long-term good aesthetic success. Yeah, it was pleasure to share my thought on correction of deviated nose. Thank you for your attention. I hope to see you again in person very soon. Thank you.
나 떠나고만 싶어 별이 기대 쉬어져 바람은 날 반겨 날 따라 심장이 뛰어
이상이 방송합니다. 오늘 한산된 할머니 100번째 생일을 축하해 주시기 바랍니다.
지금 너랑 함께 난 빠지고픈데 저 아름다운 뷰에 지금 너 어디야 baby give me the edit 지금 바로 내가 출발할 테니 아무거나 고쳐도 티가 나 여보 너 챙겨도 날씨도 완벽해 사진도 찍어줄게 같이 걸어갈래 시원한 바람은 우리를 반겨 너도 느끼길 바래 지금 내 앞에 앉아 하고 싶은 거는 다 해도 되니 없잖아 type 너를 따라갈게 걱정 말고 둘이 보이기는 완전 리리야 아름다운 적용 바로 네 뒤에
Dr. Kun-Ik Chang will now be presenting on the revision rhinoplasty for tip and columnar problems. He is the Chief Educational Director of KCCS and KSKCS. He is a Teaching Fellow of KCCS and KSKCS. He is also the Director of Hanabi Rhinoplasty Clinic.
Hello, ladies and gentlemen. I am Dr. Jang from Hanabi Clinic, Korea. Today, my topic is revision rhinoplasty for tip and columella problem. We made revision tipplasty due to many reasons. Today, I will talk about common causes of revision tipplasty and proper surgical procedure. Firstly, columella problem. Columella deviation. We need to consider possible causes of columella deviation, deformed medial crus, tilted strut graft, caudal septal deviation. We can correct deformed medial crus using strong columella strut graft. We can use septal cartilage, ear cartilage, or rib cartilage. Sometimes we can make opposite curved strut graft with ear cartilage. Before and after correction. If the previously applied strut graft was deviated, we have to make it straight. Sometimes we need to apply new stronger strut graft or do overcorrection. If previously applied strut graft was deviated like this, we have to check skin tension and strut graft size. If strut graft is too long, we can shorten strut graft height to reduce skin tension and apply additional cap graft to keep tip projection. This is after correction. Severe caudal septal deviation should be corrected before applying strut graft. The photos after correction. Next, columella retraction. This patient has retracted columella. We can correct columella retraction with lower positioned caudal septal extension graft. Before and after surgery, columella retraction was corrected and the nasolabial angle was also corrected. Shield graft can be used for mild retraction before and after correction. Side view. Next, columella scar. Repeated columella incision may remain the obvious columella scar. We can improve columella scar using G-plasty. After G-plasty, depressed scar became flat. The side view before and after correction. Another case before and after correction. This patient has a severe depressed scar due to columella necrosis. She had revision tip surgery with a columella strut and shield graft and the delicate suture, but still remained columella scar. So I did the scar revision with a double G-plasty. After suturing, after G-plasty following cartilage graft, severe columella scar improved a lot. Next topic is a tip problem. Tip drooping. Sometimes tip drooping may occur after tip projection due to cartilage absorption or weak tip support. There are two choices. Simply add additional cap graft, or total revision tip surgery. We need to check tip support before surgery. If tip support is still strong, we can just apply additional cap graft before and after surgery. If columnar support is very weak, we have to apply new strong strut graft before and after surgery. Another case, before and after surgery. Transparent tip graft. If cartilage graft is too obvious through the skin because of very thin skin, we can remove causative cartilage or apply soft tissue to cover the cartilage. We can use temporalis fascia, dermal fat, acellular dermis, any soft tissue is okay. Before and after correction. Another case, after correction. Next, pinch to nasal tip. Excessive transdermal suture or tissue excision may make the pinch to nasal tip like this. We can correct this problem using baton graft or the camouflage. Before and after correction. This patient has a right side pinched tip and the alar depression. I designed baton graft with ear cartilage and inserted via endonasal approach. After correction, pinch to nasal tip and alar depression improved a lot. Bilateral severe pinch to nose. I designed big baton graft with septal cartilage. The after correction. Another severe pinch to nose. I used the ear cartilage as a baton graft. The after surgery, the pinched nose was corrected a lot. Next topic is alar problem. Alar retraction. For mild alar retraction, we can use cartilage graft like this. It calls alar projection graft. This cartilage portion pushes out the retracted skin. Before, after correction. Another case, it looks severe, but it was corrected using the alar projection graft. The second surgical option of mild alar retraction is a composite graft. Harvest ear cartilage and skin from ear, then suture layer by layer at retracted area. Before and after correction. Another case, moderate alar retraction. This patient had skin graft after alar skin cancer. Then right side alar skin was pulled outside due to scar contracture. For correction, I applied two grafts together, baton graft and composite graft together. And I did alar reduction and columella shortening. After correction, right alar retraction was corrected and the nostrils became quite even. In the side view, lateral nostril show was improved a lot. Basal view, severe alar retraction is often accompanied by nasal contracture. We need to consider direct skin excision for severe alar retraction. Excise deformed skin and suture in the front before and after correction. Another case, he had infection after rhinoplasty. Then left nostril and alar was deformed, like this. I applied baton graft and alar projection graft and performed alar rotation flap. Even the nostrils and the alar became quite even, but the severe skin scar was remained. I did scar revision surgery with multiple G-plasty in 6 months. You can compare before and after the result. Basal view, alar widening. This patient had alar reduction before, but alar skin was oversected, so she wanted to make alar base wider again. This picture is showing surgical design. The excise alar base first, then remove designed lateral alar skin. This alar skin is fixed at the lateral margin, and medial skin defect can be covered with skin graft, which is from excised lateral skin. Left alar can be done with the same method. After suturing, after correction, her alar base became wider. Before and after view, surgical scar is very clear. Another case, after alar widening. The last topic is skin problem, skin dimpling. Dislike skin dimpling is mostly due to dead space under the skin or tissue absorption. For correction, if the skin, epidermis and dermis are intact, we can try to apply camouflage with cartilage or dermal fat. If skin epidermis and dermis are injured, we need to consider flap surgery. These photos are showing camouflage with soft tissue under the skin and external fixation. Before and after correction. Another case, this side, the skin, the dimpling. After correction with camouflage. Another case, after correction with camouflage. This patient has the silicone extrusion. Tip skin was perforated. We can try rotational flap like this design. Before and after correction. Another case, this skin dimpling is due to silicone extrusion too. This is a rotation flap design. Ear cartridge can be inserted under the flap for nasal tip projection and tip volume. Before and after correction. She had many rhinoplasty and got infection, then very severe depressed scar was remained. I did rhinoplasty with rib cartilage and remnant depressed scar were corrected with double rotational flap. Before and after correction, the side view, before and after correction. Skin necrosis. Skin necrosis is common around the columella incision area because of poor blood supply and too much skin tension. For correction, if possible, we can try the primary closure. And another method, we can try to apply composite graft for the dislike small and round skin defect. Donor site of composite graft and after grafting and after suturing, before and after correction. Upper columella skin defect can be corrected by lower columella skin flap and the subnasal flap. If the skin defect, including the nasal tip like this, we can design by lobed flap like this photo. After the flap suture. Today, I introduced many useful surgical procedures according to each problem. I hope that my lecture will be helpful for your better result. Thank you so much for your attention.
It is 1 p.m. now. Everyone please be seated. We will be resuming session 1. Dr. Dai Chuan Chang will be presenting on an influence on nasal ventilation function of different nasal support grafts. He is the past chairman of the First Precision Rhinoplasty Professional Committee of the Precision and Digital Medicine branch of the Chinese Plastic Surgery Association, Vice Chairman of the Rhinoplasty Committee of the Medical Aesthetic Professional Committee of the Chinese Integrated Medicine Association, Deputy Chairman of the Ear Plastic Surgery Committee of the Medical Aesthetic Professional Committee of the Chinese Integrative Medicine Association, and the Vice Chairman of the Continuing Education Committee of the Chinese Medical Doctor Association Cosmetology and Plastic Surgery Branch.
Hello, everyone. I'm Dr. Dai. I'm from Shanghai Nice People's Hospital. Thank you very much for Professor Zheng's second invitation, which gave me opportunity to communicate with fellow Koreans about rhinoplasty. 2 years ago, at the invitation of Professor Zheng, I attended an exchange meeting in South Korea and was warmly received by Professor Zheng, which impressed me deeply. This year, due to the pandemic, we can only communicate online. Today, my speech topic is influence nasal breathing function of different nasal support gravity. Starting November 2019. We often meet this case clinically. This is cleft lip rhinoplasty. She complain nasal obstruction. On CT, we see the internal nervous valve is narrow. This another patient is ear cartilage SEG to take up the space, the nasal cavity, a narrow internal nasal valve. Is another patient. Is cast collagen lateral clear stratigraphed. You see the cast collagen is into the protrude in the nasal cavity. So she complain a nasal obstruction. Other it is too stiff. We call it Latin nose. I do need support grafts in the axial nose. Most axial nose simply local tip support the nose compared to the western. The midline is on middle of the nose, the tip flap and too broad. It's too short. The series is hairy bone nose. 3, there's no sharp tip. So we must refinement. Do all cases need a tip graft? The answer is no. This girl like this tip. When we give her a long tip, he hate this. This is a large nose. We only need to reductive rhinoplasty. So this is he likely. We don't need a tip support graft is 3 objective. One is short nose lancing or long nose shorten. More than is obtain a typical definition. What structure a different type of nose? Long nose we need a structure is to formal structure. Short nose we need a formal SEG. Most of nose is normal length. Normal length. You need a weak supporter, or you can elastic supporter. Support structure classification. Most of Western is an indoor in the generous extension. A graphic there. We in Asian in East Asian the need is axing extension. Internal extension graphics display is suitable for Western and high-ness dorsal and good septum cartilage development structure. Structure stability is a wide range of applications such as long time, short time, or tip refinement. Disadvantage of individual extension. It take up a nasal space may be that to function problem, resulting in cartilage sulfate and incepted. Operation is rarely complete. Also, East Asian now taking the Dallas method. Because we can see interneural valve angular is too short to narrow. So it's a function problem. The Anderson's tripod I can see is wrong for East Asian with serious short noses. East Asian nose serial nose need a four leg. No tripod. Not a tripod. According the concept is 这个 supported is this to come Richard can prevent the people not rapidly and affect validity. Like this. We choose our structure is be by direct T supporter and a stable balance in each level. Each assume short no you skin not college and strong retractive force. Natural state conform the trade concept. However, extension of the nerve tipo and cartilage are markers member become a limited force, retractive force, so to speaking, and when building and rebuilding the chapter is so difficult to support the serrated short nose. We only interpret integrated graft installation. The septa colored a red color. Long nose shortened. Exogenous bracket. Independent septal cartilage support is especially suitable for serial contraction of short nose. Because its septum is weakened, it's best not to dissect, and the secondary phase of repair will be simple. The wider septal division can be also retracted. Eastern nose bridge is very long, often need onlay graft on the nasal back. So we needed to build a support in the nasal cavity. Nasal valve compromise is a major cause of nasal obstruction. On the ventricular supporter structure, we use the EPTFE, the air-shaped EPTFE on donor nasal back, a nasal dorsal, and is a ear cartilage. This is precisely is aesthetic surgery in 2019. Venous table structure. So this is a lateral cartilage is to here. Fine shaped cover auricular. We can sway your nasal tip. The stress point is at the nasal dormal and the anterior nasal spine to here. Deeper force to here. The suture is the face of the hair. Post operation, we can see the nasal valve, internal nasal valve is article. It becomes is open. This structure is suitable for short nose extension below moderate and long nose shorten. Nasal tip refinement. Advantage: no function problem, stable function, and effector. You can sway nasal tip. The little damage. Modify easily. Disadvantage: nasal tip is still quite hard. Cannot rotation up and down freely. This case is complaint nasal obstruction. This nasal airway obstruction after auricular cartilage support rhinoplasty. We remove the ear cartilage in septum septum, and the tension release the direct septal cartilage. This is the air cartilage. Remove the silicone and add a air ship the EPTFE and a bracket. The fine ship and the fine ship called the cortical. The tensor puncture packet. CT is the contractor before operation. Front and right internal valve is closed. 2 weeks after surgery is open. Shoulder nose lengthening revision. Shoulder nose lengthening. 1 year post operation. Long nose shortening. Before the septal cartilage. That's a typical refinement. The 3 months of post-operation. That's a typical refinement. And due to her aesthetic change, 4 years 4 years post operation, next table is modified. Later surgery, minor surgery. If is upper rotation. Upper rotation type. Cartilage. Serious short nose, we must use costly cartilage. We use master like costly cartilage in general bracket. Is most like strata and F-shaped SEG. Exact surgery 2020. Like a teeth chart and F-shaped SEG tendril structure supported grafts. The low lateral cartilage is sutured the cartilage. So to balance. Larger is simple and suitable structure. No dissection of nasal septal. No nasal air obstruction. The septum is not stressed. You suitable patient for serious short nose and a contracted nose and a septal defect perforation. The next table is hard, lacquer for genetic nature. This one is 3 years post operation. You can say that The net tipple is structure and the low level remain rounded. The 3 years post-operation. This one is 9 years post-operation. You can nasal tipple structure and the low level rounder remains rounded. It's another one. Nasal contractor after disocartilage or rhinoplasty. 3 months post-operation. It's another contractor's nose. Laser nose causal exact quality. The serial contractor with short nose. Compared to it's infection contractor, infectious contractor nose. Serial contractor is muscle. It's a muscle. Infection contractor nose another. It's 3 months. It's another infection contractor nose with parietal septum. You can see is a perforate. This is most of the cartilage. The 2 years post-operation. Building taper support from inside the nasal cavity may cause nasal airway obstruction, and is not the best choice for installation with long nasal bridge. Internal nasal support structure constructed by us is more suitable for installation short, more lengthen, and nose lengthening. Thank you for your attention.
Dr. Fasil Lapida will now be presenting on the middle wall and functional rhinoplasty, spreader flap, graft, or preservation. He is the professor of otorhinolaryngology at the Ege University, Turkey. He was the immediate past president of the European Academy of Facial Plastic Surgery. He is the treasurer of the International Federation of Facial Plastic Surgery Societies. He is also the executive board member of the Turkish Society of Facial Plastic Surgery.
Hello, My name is Fazıl Apaydın. I'm from Izmir, Turkey. It's a great honor and privilege to be with you in this meeting. I hope I could be there with you for the whole Congress, but unfortunately, because of the Corona, I will not be able to be with you. Let me share my screen with you. I'm asked to speak on middle wall in functional rhinoplasty, spare graft, flap, or preservation. I have many international connections with European Academy, past president, International Federation, currently the treasurer. I'm also a board member in the International Board for Certification, and I work as a professor in this hospital, AA University Hospital. I came here as a student in 1979 and still going on as a professor. This is our clock tower, and I came to Seoul in 2012 for the 10th ASEAN Rhinoplasty Symposium, where I had a chance to meet wonderful surgeons and friends from Seoul, Korea. This time I'm invited by Dr. Dongkang Chung. It's a great honor to be invited one more time. Hope to see them soon, because Seoul is a very nice city with wonderful history and nature. When we speak about middle fold, we have three options actually. I started using spectrographs 22 years ago, and this is the broad prosthetic line in which we all try to achieve in our cases. Cartilaginous wall can be normal, narrow, or wide. And this is how I learned rhinoplasty almost 30 years ago from my master's. This is a Joseph School, trying to get the whole hump with one piece. And when we do that, we destroy the T or Y-shaped articulation of septal cartilage with the upper layer cartilages. And these are the three things that Joseph unblock hump removal is commented on. One can have dorsal aesthetic irregularities, which can look like an operated look. The patient can have a neurogenic pain due to open deformity, and the breathing dysfunction can happen secondary to a narrow nasal airway. Actually, in structural rhinoplasty techniques, all these problems are addressed. And if you are very sharp, very severe in taking the hump, you can end up with an inverted V deformity. And because of that, the last 22 years, I have been using spectrographs to reconstitute the normality, to lower the incidence of middle wall collapse, to maintain and reconstruct the dorsal nasal roof, restore or maintain the internal valves, recreate the dorsal aesthetic lines, straighten and buttress a dorsally deviated septum. Spectrographs are put between the upper lateral cartilages and the septum. The graft material is preferably septal cartilage, but costal cartilage and conchoid cartilage can be used in revision cases. This is a menu of me how I use spectrografts. Traditionally, they're rectangular grafts. The way I learned from my mentor in Toriumi 22 years ago is to bevel the edges, keeping 2 to 3 millimeter thick area, 1 to 2 millimeter close to the valve, internal valve angle. Depending on the situation, they can be asymmetric in thickness, or we can use double layer on one side. I allow different types of beveling, as you can see here, to increase support to the nasal septum. This is the usual way if I have a longer graft, to prevent open roof, to support the upper third of the septum as well. This is one of the typical cases. As you see, this beveling, the stair step goes under the bony dorsum. When you put it in place, it stops at the key area, and the lower part goes under the bony dorsum without causing open roof. I love to use spread grafts for splinting purposes as well. This is the traditional way. This is a case where we applied spread grafts together with lateral cross turning flap. And as you can see, if applied nicely, they are really very helpful to have a natural look for the middle vault. Spleen spread grafts can be cartilaginous, bony cartilaginous, and very rarely bony. In this crooked nose, for example, and after cross-hatching the concave side deeply, I usually put this ethmoid plate to the concave side, but in this case, we put it like an L-strut graft to the convex side, which also helps because the idea is to splint the deviated portion of the L-strut framework in place. Then after this, the dorsal segment is additionally splinted by two spread grafts, so to end up with a much straighter dorsum. And the caudal excess portion help us to suture the caudal septal extension graft, as we can see in this case. First of all, it is sutured to the spread graft, then to the caudal septum, as we can see here. So this is after surgery. In another case, when we crooked nose, when we take the hump, you can see how badly the septum is deviated. After the hump is removed, we harvest cartilage. These are splinting spread grafts. They are thicker than normal, as you can see. When I try to bring the L-strut framework straighter, I end up seeing a dog ear. In recent years, I almost always reject this dog ear. This is a better option than cross-hatching because I have seen recurrences with cross-hatching. This is why I'm a bit more aggressive, but I don't need to cut the whole of it, just the dog ear. And when you put spreader grafts in a splinting fashion, you end up with a straight L-strut. Sometimes spreader grafts can be used to augment the dorsum. And when the cartilage is not in ample amounts, in those cases, I like using hybrid grafts. These hybrid grafts are really wonderful. You can use powered instruments or osteotomes to create them. And these hybrid grafts can be sutured very nicely inside. In this case, the thin bony part goes all the way up under the bony dorsum. And because it's a high septal deviation, and this high septal deviation can be corrected by using a longer splinting spreader grafts. Sometimes these spreader grafts are used to reconstruct the middle vault, as in this case. In this case, the caudal portion is fine, but when we remove the fracture line, I didn't touch the caudal septum because it's straight. And then I harvested cartilage from the posterior part, and I could get rid of the deviation as well. So these are, I'm still trying to obtain splinting spreader grafts in a hybrid fashion, osteocartilaginous fashion. And as you see, I'm using scissors now. They're about 5 centimeters in length. They're very long. And with these two spreader grafts, I'm making my new dorsum. It goes all the way to the upper third. It makes the new middle third, and it's connected to the caudal septum, as you can see. Ideally, these spreader grafts must be thicker than normal, preferably 7 or 8 millimeters if you can. The patient is much straighter and much happier with the nose. I can sometimes use spreader grafts together with L-strut grafts. When we come to spreader flaps, I've been using these about 12 to 13 years. This is my classification, how I've been using them. So when this is a revision case, there is only small hump. When I remove this hump, I do not need to put any spatter grafts or flaps. Simply suture the upper lateral cartilages to the septum will be more than enough. In some cases where the hump is close to the key area and internal valve area is normal, I simply make a wet resection at the keystone area and then suture the upper lateral cartilages at the top of the septum. It works perfectly well as if the dorsum is not touched at all. So this is a very nice technique to narrow the middle wall and also to get rid of the hump. This is the traditional way, turn-in flaps, spatter flaps. So when I don't need any incision, I simply turn them in and then suture. Second option is to make partial incisions cephalically, and sometimes reshaping partial incisions are done. And when I do it endonasally, I make total incisions. So this is type A, turn it in, suture them together. I usually make 2 sutures, 1 caudal more cephalic, and then they are sutured to the septum. When I started, I was doing this all the time. In this case, for example, the same thing. I saw a small open roof because the part closer to the key area started expanding the roof. Then I started making partial incision at the key area so I could turn these spatter flaps much easily at this point. But this is the usual way. I usually divide the pericondium in the midline, make the upper lateral cartilages visible, detach them from the nasal septum, resect the septal hump, as you can see here, take the bony hump as well. And when we're good with that, in very big humps, I dissect the mucopericondium under the upper lateral cartilage to turn it easily and to get rid of any risk of mucosal cysts, because mucosa can be strangulated in between. So when you do so, it is easy to turn them in by using a hemostat, and by a long dental needle, you can fix the upper lateral cartilages in place easily. You turn in as required, and when you're done with this turn in and fix the upper lateral cartilages in place, you remove the hemostats and then use 4 PDA sutures passing from the upper lateral cartilages. Because when you turn them in and when you dissect the pericondium, you don't need to make any cuts because it's very pliable and you can turn it in very easily. And the good thing about spatter flaps is you do not sacrifice any tissue and you can expand the valve area very nicely. And if you know how to suture them, the dorsum looks as if you have not touched it all. So in my mind, spatter flaps are dorsum preservation technique in a very controlled fashion. So for those who doesn't have much experience with spatter flaps, it's not easy to understand what I'm telling you, but believe me, I have a huge experience with spatter flaps and I'm very happy in using it, because when you do so, it's a very controlled way of dorsum. The dorsum is going to stay where you put it. And depending on the situation, you can use 2, 3, 4 sutures. The one that you put close to the key area is very important because it prevents open roof too. In some cases, when the middle wall is very narrow, I use spatter grafts and flaps at the same time. This is a case where I used spatter grafts, but it was not enough, so I use both of them together. Sometimes when I need slight augmentation of the dorsum, after suturing the spatter grafts, I put the flaps over this construct. This is a deviated nose. For example, in this case, we did that. We did augmentation with the spatter flaps. This is a crooked nose, another case. In this case, I needed to splint the dorsum, but I didn't want to widen the middle wall. That's why I kept the spreader grafts 2 millimeters lower than the dorsal margin. I could splint the dorsum very nicely. I end up with a straight dorsum, and the extra upper lateral cuts is shaved off, and then upper lateral cuts are sutured directly to the nasal septum from both sides, cephalically and coidally. If you need more suturing, you can do so. So this is 7 months after surgery. This is a thick skin too. Sometimes, without understanding how, the key area can get disrupted accidentally. In those cases, I love keystone area stabilization suture. I name it like this. I open a hole by using an 18-gauge needle over the nasal bone, and then I pass my first 4 PDS suture from this hole. Then I grab the disrupted cartilage. Then I make another hole on the nasal bone on the right side. I pass from that hole. Then what I do is I make a spreader flap partial cut cephalically. It is easy to turn it in, and then I pass the suture from this spreader flap and then the septum. Another spreader flap is formed on the left side, turned in, and then the suture passes from here. And then you simply tie this mattress suture. It is a very stable and strong suture. You can fix the septum in place without narrowing the passage from the bone to the up at the middle third. And if I'm going to use spreader flaps, if I keep 3 layers, which is the mucopericardium over the capillary cartilage and the mucopericardium under it, I can widen the valve area as much as possible. If I detach the pericardium at the top of the upper lateral cartilage and keep the mucopericardium intact, I end up with a narrower dorsum, narrower valve area. If I detach the mucopericardium under and over the upper lateral cartilage, I have the narrowest middle wall and narrowest angle. So I can use these data to my advantage depending on the situation. So this is my spreader flap and graft classification. Spreader flaps are more tricky because you have to know how much to turn in. Are you going to use it with spreader grafts or not? How many layers to turn in? So it means there's a learning curve like all techniques. Spreader grafts are much more straightforward, much easier for beginners. When we come to preservation, rhinoplasty, Daniel described as subpericondyal subperiosteal dissection, in other words, soft tissue preservation, ligament preservation or reconstruction, and dorsal preservation. We're going to deal here with dorsal preservation, which is our topic. Dorsal preservation is not a new idea. It was first brought to the literature by Goodale in 1899, almost more than 120 years ago. Then, about 100 years ago, Lothrop came up with the first letdown. He even came up with a Ronchar. Very recently, Ferreira and Turyumi made a simple classification for dorsal preservation, foundation techniques and surface techniques. And when it comes to the way it was applied for the septum, it can be high strip, low strip, or intermediate strip. And there are 2 types of bony hams. If you deal with preservation techniques, it can be V-shaped, which is a favorable shape because it's much easier to straighten the dorsal profile. It can be S-shaped, curved configuration where you may need to rasp the bone. In push down, you make lateral and transverse and root osteotomies, and the bony and cartilaginous dorsum is depressed downward into the piriform aperture. This is called push-down techniques. A lot of people use it. I love this technique very much too, because it gives additional support. But before doing this, I love removing a wedge of bone at the Webster triangle. I also like lateral procedures, which a wedge resection of the ascending process of the maxilla is done, in addition to transverse and root osteotomies. If you want to flatten the hump in a secure way, you should remove some bone from bony hump, do a limited lateral keystone release, and fixate the cartilage vault down to the underlying septum. So this is partial removal of bony hump. This is limited dissection of the lateral keystone, and this is how you suture it to the underlying septum in high strip. It's been described by actually Lothrop and others, then resurrected, revitalized by Yves Saban. He is now one of the main names in preservation rhinoplasty. And in high strip, you remove a high strip of cartilage under the bony dorsum. In this case, for example, dorsum is relatively nice. It's not a big hump. We go inside, we dissect the mucopericardium on both sides. Then I remove a high strip of cartilage under the dorsum, dorsal hump, as you can see here. When you remove this, you need to push the dorsum down. And if you do so, you may have a defect at the radix area where you may need to put very cartilage dust or finalized cartilage. And then this is sutured to the sepal cartilage by a fixation suture. You can use a 18-gauge needle to pass the suture through. And when you do this, you go up without going out of the skin, go to the other side, as you can see here, and then push the tip of the needle, passing to the inside of the nose. And when you tie the suture, what you do is you fixate the dorsum to the remaining cartilage. This is a tricky suture, but when you do a few of those, you're going to see it's not that difficult actually. When you are applying an external approach, this is of course much more easier because we can suture under direct vision. So this is how we end up. Actually, the dorsum widened a bit, and in these cases, when you see this, you should make some small refinements, such as trimming the lateral parts of the dorsum. So this is one of my first cases. Actually, there's a learning curve for it too. In the intermediate strip, you remove this piece of cartilage a bit lower than the part, and the most famous one is now the Tetris one described by Carlos Neves. This is one of those cases with the hump. So after we do dissection and open the dorsum, we remove a piece of bony hump and dissect the lateral keystone area, and then we go inside to create the Tetris. We're using number 15. This is about 7 to 8 millimeter high Tetris segment. And when we do so, we are going to simply resect some part of it. And when we resect this 3 or 4 millimeter, depending on the situation, we're going to bring this part down and then suture it down. This is the resect area, as you can see here. We remove a piece of cartilage under the bony dorsum. We removed a bit more, and then we are removing wedge of bones from both sides and complete the osteotomies. These are lateral osteotomies are completed. The same thing is done on the other side, remove edge of bone, transverse osteotomies, and then root osteotomies. Then we are suturing back, and this tetris part is sutured to the remaining cartilage, as you can see here. And when we are done, this is, the dorsum looks fine, but this is again my first case with it, and as you see, it's not a very good result. When you're going to make a low strip, in those cases, you may need to do other things and suture the caudal septum to the anterior nasal spine and make wedge resections or asymmetric osteotomies on both sides. For example, this is a cricket nose. As you can see, very nice young lady. So what we did in this case, a high septal strip. So we go with a hemitransfixion incision here. We dissect the dorsum. We went subpercondyal, we harvest cartilage, remove a piece of cartilage close to the area. Then we are trying to open space because we're going to remove wedge of bone on both sides. We can do it by a ronger, by osteotomes. And here I'm using a ronger. It's very easy with ronger, but actually it is less predictable, I can say, because you can remove more than you need. Then we are going to create impaction, which is pushed down partially closer to the upper part. The same thing is done on the other side. If you want to push the whole dorsum down, you need to remove a wedge of bone, as you can see here. When you remove this wedge of bone, then by staying perpendicular to the cheek, you complete the osteotomies. These are transfers and root osteotomies are done. And when you're done with this, you're going to suture the caudal part into the spine simply by pulling it downward. So you're going to make the dorsum flat. And like this is a very important suture. Actually, this is the most important suture. If you're not successful with this suture, everything goes away. So this is one of the bad things with cuttle, because you rely on one suture, and this is this suture. And if you're not happy with this suture, you're not going to get a good result. Well, I have friends using this technique for 30 years, and they are very happy with that. And then we do the tip surgery. I'm not going to go into details with that. This is 4 months after surgery, and the patient is very happy. The result is really very nice, and I'm a very happy surgeon too. So in selected cases, I allow cuttle, especially in high septal deviations, very much. To preserve or not to preserve, this is the thing. Dorsum preservation, you work like this, under the dorsum. When you're a structural rhinoplasty surgeon, you are going to make middle wall reconstruction. Should I use revitalized techniques of dorsum preservation? If so, what for? This is the question we all ask to ourselves. Well, actually, it seems appealing because technically it's easier. This is honest. You're not touching a nice dorsum. This is a very good thing too. You're not even opening the dorsum in patients with thin skin when it's a straight dorsum. In high septal deviations, it works perfectly well. It's much easier than traditional techniques. And in some crooked noses where overlap can solve the dorsal flexion, this is also appealing. When you overlap, you solve the problem. And it's a shorter operation, I can tell you that too. But still, I'm sure you all have concerns. There's a learning curve. You're going to ask yourself, do I need to risk it at this time of my career? For younger surgeons, it's easier to say yes. For senior surgeons, it's much more difficult to say yes. It is not easy to have full control of all the maneuvers. Predictability is an important concern in these. In high strip, you can have more full control if you do open rhinoplasty, but in others, no. Recurrence of humps is an issue in intermediate and cuttle type of preservation, but not in high strip. One of the concerns is overmobility of the bony pyramid, which makes me nervous. Actually, it didn't cause a lot of problems in the case I applied. Detaching the piriform aperture ligaments seemed annoying to me, but all my friends using it for years, they say it doesn't cause a problem. So I didn't have any problems until now with that either. Relying only on one suture in cuddle technique makes me feel nervous because it's a risky thing. In one case, I had to revise because of this suture, and it's good. What about difficult stable deviations? You cannot use it. So we have three options at the end for the middle wall. I love using all of them. Preservation, I use 25 to 30% of my cases. If you're not a member of European Academy, please do so. We are in Zagreb for a course in November 11th, 12th. And in May 2022, I have my own small course in Izmir, Turkey. And next year, our meeting will be in Poland. Thank you very much for your attention.
Dr. Chi Wen-tu will now be presenting a step-by-step guide to reconstruct the deformed septum. He is the president of the International Federation of Facial Plastic Surgery Societies, director of Pan-Asia Academy of Facial Plastic and Reconstructive Surgery, director of Taiwan Rhinology Society and Taiwan Pediatric Otolaryngology Society, and chair and board certificate committee of the Taiwan Society of Otolaryngology Head and Neck Surgery.
Good day, ladies and gentlemen. I'm Chi Wen-tu from Taiwan. I want to thank Professor Dong-Hak Zhang and the organizing committee of Korean College of Cosmetic Surgery and Medicine for inviting me to be a part of this great meeting. In the next few minutes, I'm going to talk about a step-by-step guide to reconstruct the deformed septum. We all know that Dr. Kato said, "As the septum goes, so goes the nose." The deformed septum can be related to the crooked nose, the tension nose, the saddle nose, and all the deformities among the tip and the columella. So, knowing how to reconstruct the deformed septum is very important. Usually, those patients with septal deformities will complain about difficult breathing through the nose, or snoring, or repeated sinus infection, or even frequent nosebleeds. When dealing with these septal deformities, we have to change the structures in order to achieve our aesthetic and functional goals. I usually obtain objective measurement before the operations, for example, like the acoustic rhinometry, or the measurement of the airflow and the cross sections. If there exists discrepancies between the subjective complaint and the objective measurement, we have to be very careful, because some of them might have psychological issues, and we have to know that poor patient selection will lead in unhappy patients and surgeon. And we must know that the septal pathology may contribute to almost all nasal deformities like deviated pyramid, the saddle nose, the tension nose, and humps. So when we see a patient with a twisted nose, we have to know that they have physiological and also anatomical problems. By dealing with this kind of anatomical deformities and physiological deformities, we can set a complete surgical plan to correct their functional and aesthetic problems. We can divide the nasal deformities into the upper third, and the middle third, and the lower third. Then we can do complete analysis regarding the alignment, the curvature, and the function. For example, for the pyramidal deformities, we have to consider if there is any twisted or crooked nose, and we have to know that if there is any hump or sagging nose, or if there is any septal problems or valve stenosis. When dealing with the septal deformities, we can complete the septoplasty through 6 phases, from the anaesthesia to the incisions and to complete flap elevations, and then we can do excision of the deformities, and then we do septal sutures and complete it with nasal packing. The first step is to do proper anaesthesia, for example, blocking the nasopalatine nerve and the anterior ethmoidal nerve. The second step is to make a proper incision. The keloid incision is most popular, but when dealing with the caudal septums, we need hemitransfixion incisions. Or when we deal with those inferior septal deformities, we need modified keloid incisions with extension. The third step is to do flap elevation. You can either do small conservative elevations, or you can do large complete elevations in purpose of making the septal flap for reconstruction. While elevating the flaps, we have to keep in mind that there are 4 tunnels that we have to dissect the septal mucosa away from the septal cartilage and bony framework. And do remember that the anterior superior tunnel and the anterior inferior tunnel are divided by the tight fibrotic band that we have to dissect very carefully in order to prevent septal perforation. The fourth step is to do excision of the deformed bone and cartilage. Remember to keep the dorsal and caudal strut after removal of the cartilage during submucosal resection. Or we can do precise removal of the bone and cartilage through endoscopy. The fifth step is to do septal sutures. It decreases the risk of septal hematoma and also offers extra support of the nasal septum. The last step is to do proper nasal packing or using the Doyle's implant to do intranasal fixation. Although there are various kinds of septal deformities, we can apply these 6 procedures into our daily practice. We do anesthesia, we do incisions, we do flap ablations, we do removal of the deformed bone and cartilage, and we do sutures and we do packings. We can also do this kind of precise corrections under endoscopy. So we identify the deformity first, and we do incisions and we elevate the flaps away from the nasal septal cartilage, and then we remove all the deformed septal cartilage and bones, and then we put the flap back and do sutures and packings. By sophisticated extrusion, we can do minimal dissections, we can elevate the flap carefully, and we do minimal stripping and removal of the deformed cartilage or bones. By doing this, we can do as much preservation as we could. By using the unilateral or bilateral spreader graft, we can achieve better cosmetic results while doing the septal correction. Or you can use spreader graft with septal rotational sutures. By doing this, we can correct the deviated septums and we can achieve better cosmetic result. Sometimes additional deformities might occur after correction of the deviated septums, and we can combine the usage of the spreader graft as well as the camouflage graft. For those dorsal or caudal septal deviations, we might use 3-and-3 cut so that we can restabilize the outstrut, or we can do some trimmings after complete mobilization of the septum. For those septal deformities with hypertrophic quadrangular cartilage, we might do some cuttings among the inferior caudal septums, and then we use the swing door techniques to make the septal structures in the midlines, and we can fix it according to the deformities with proper suturing. For the cases with septal deformities and valvular stenosis, we can do flap elevations after separating the mucosa away from the cartilage, and then we do some cuttings to remove the excessive cartilaginous structures. And also we have to correct the deformities among the nasal spine, the maxillary crest, and also for those with inferior caudal septal deviations, we have to do cuttings in order to remove the excessive quadrangular cartilage. For those complicated cases, we might have to combine all the resections, scoring, and suturing, and also the splinting techniques in order to correct the septal deformities. Sometimes we have to do modified septoplasty mimicking the extracorporeal modifications, but we'd better design the directions of the cutting according to the directions of the deviations to the dorsum. In some selected cases, we might not have to remove all the deformed septal cartilage and bones. We can use just the modified swing door techniques so that we can move the hypertrophic septal cartilage, move it to the other side so that it will become an overlapping status. And after doing this, we can do proper fixations and we smoothen the flap overlying it, and then we can correct the deformity. We have to be aware that modifying the tip is changing the relationship between lower layer cartilage, the septum, the upper layer cartilage, covered by the soft tissue envelope as well as the skin. In some cases, we might have to release the upper layer cartilage from the dorsal septums in order to correct the lower layer cartilage and septal complex. If the deformities comes from the combination of the septum and lower cartilage, we have to do modification of the septal cartilage by cutting the inferior caudal septums and also cutting of the excessive lower cartilage. And after proper fixations, we can get a better structural support. Sometimes the deformities might come from the underdevelopment of the lower cartilage, and in these cases we can do some cuttings and further splintings by using our graft, and also strengthen the weakened lower cartilage so that we can get better corrections. And we can correct the septal deformities along with the upward rotated noses by using the floating columinous rod or the extended columinous rod or the caudal extension graft or the designed caudal replacement graft. Sometimes we will lose the nasal tip projection if we use strut only, but fixation of septum and the strut graft through septal auto-extension provided satisfactory stabilization of the tip projection and rotation without stiffness or rigidity. For example, in this case, we do the septal extension graft as well as the columinous rod at the same times, and after proper fixations, we get better mechanical support. In some traumatic cases, we might find that septums are just missing. In these cases, we have to use a whole piece of cartilage to create the outstrut and then do some proper fixations with the help of some splintings. Usually, we combine all these procedures together. We use scorings, we do resections, and we do extended spreader graft, we do caudal septal extensions, and we do columinous rod. And by proper fixations of all these structures, we can get good support and to resolve the functional and aesthetic problems. And always keep in mind that in some difficult cases, the extracorporeal septoplasty is necessary in order to correct all the deformities. After all these procedures, we have to do good post-operative cares. For example, take rest, and do not lift heavy objects, do not do vigorous exercising, do not blow your nose vigorously. Even with meticulous execution of the procedures and good postoperative cares, we still have to face possible complications like septal perforations, scarrings, abscess formations, hematoma formations, cyst formations. And for all of these complications, we have to correct it properly in order to prevent further trauma to the patient. Usually, the patient will be satisfied with our procedures, and we can know that the quality of life was improved according to the result of the questionnaires and some objective measurement. To sum up, this is my personal philosophy that I divided the nasal deformities into the functional ones and the aesthetic ones. And if the aesthetic problems came from the pyramidal disorders, then we can correct the too wide pyramid with osteotomies. And also we can correct the deviated ones with septoplasty, with osteotomies, and with those grafts and some suture techniques. And if the pyramid is too high, we can do reductions like hump removal and smoothing of the nasal profiles. And if the pyramid is too low, then we do augmentations. And this lady suffered from irregularity among the pyramid, and also a little drooping of the tip, and the bridge is too wide. And from the athletic views, we can see there is a bony and cartilaginous hump and a little bit drooping of the tip, and under projection of the tip also. And we can see the total obstruction of the nasal valve through the endoscopy. And I do endonasal correction of the deformities by dividing all the cartilaginous structures away from the surrounding tissues. So I dissect the lower cartilage and I put it out of the nasal cavities, and I also do septal corrections. We divided the deformed septums away from the septal mucosa. And we do septal extension graft and as well as the columinous rod, and then we fix the new septums to the modified lower cartilage, and also we correct the deformities among the bony vault by using osteotomies. I also do augmentations with the auricular cartilage, and here comes the pre-op and the post-op. We can see the irregularity among the dorsum are corrected, and we can see more protruding of the tip and more beautiful effect lines, and also narrowed nasal bridge. And from the three color views, we can see the corrected bony and cartilaginous hump, and we can see the projections were increased. and very good definitions among the dorsum and the tip. And from the lateral views, we can see the corrected dorsal hump, and we can see the proper projection of the tip, and we can get better nasolabial angles. And also I do some glabella graftings so that we can get a better nasofrontal angle. This is an example of pyramidal deformities. From the front views, we can see tortuous pyramid with twisted bony and collagenous vault. And from the oblique views, we can see there's a hump and also drooping tip and also a symmetry of the nasal side wall. During the operations, we can see the tortuous spiral septal cartilage, which prevented him from normal breathing. So we remove the deformed septal cartilage, and we correct the lower cartilage and upper cartilage, and we also do osteotomies to remove the bony hump, and we use auricular cartilage for autologous graft. Here comes the pre-op and the post-op. From the front views, we can see the tortuous twisted dorsum were corrected, and we can achieve very good symmetry of the nasal alignment, and also symmetry of the nasal side walls, and also very beautiful light reflex of the tip. From the oblique views, we can see the tortuous nasal bony and cartilaginous hump were removed. And we also increase the projections with auricular cartilage, and we also do dorsal and leg graft of the auricular cartilage and septal cartilage. So you can see a very smooth nasal profile and very good projections, very good nasofrontal angles, very good nasolabial angles. From the base views, we can see the corrected bony and cartilaginous pyramid, and we can see very good alignment, and we can see very beautiful light reflex among the nasal tip and the infratip lobule. This Canadian male patient suffered from sports injury during childhood. And from the basal views, we can see the asymmetry of the nasal tip, and also the tortuous dorsal affected line. And from the lateral views, we can see the hump and improper projections of the tip. So I do open reconstructed rhinoplasty, and you can see the tortuous loreal cartilage, and we do separations of the loreal cartilage and get through the septums, and we separate the perichondriums from the septums, and we can see the tortuous structures among the septal cartilage, which causes breathing problems throughout these years. And the excess inferior caudal septums was resected, and I do septal extension graft, I do strut, and with suture techniques we reconstructed the caudal septums. And also for the hypertrophic loreal cartilage, I do some cephalic trims, and I approximate the modified loreal cartilage to the neoseptums. So here's the before and after. You can see the twisted dorsum, the dorsal hump, and the deformities among the tip and columella were corrected. And we can see restoration of the nasal dorsum with proper projections and light reflex among the nasal tip. So here's the three-quarter views. We can see the deformity among the dorsum, the hump, and the crooked nose, and also the asymmetric tip and columella were corrected. And we can see the lateral profile was good, and we got proper projections and downward rotations of the tip. And also, the patient was smiling. He was satisfied with the surgical result. So from the lateral view, before and after, we can see the dorsal hump, the hanging tip, the improper projections and rotations, and also the concavity among the subtriangle. But after all the reconstructive procedures, we can get proper projections, proper rotations, and also much better lateral profile with nasofrontal angle, with nasolabial angle. So to sum up, we have to keep in mind that whenever we are facing a patient with nasal trauma, we have to take all the functional problems and aesthetic problems into considerations. By doing this, we can set up proper surgical goals, and we have to discuss with the patients, and we do reconstructions for restoration of the function and the cosmetic result of the nose. So this patient came from the States, and he's a professor in Taiwan. And we can see from the front views the tortuous pyramid, including the bony part and the cartilaginous part, and also a little bubbles of the tip. And from the base view, we can see the concavity and asymmetry of the nasal subtriangle and the infratip lobules, as well as the columella and also the nostrils. And also we can see the deformities among the dorsum, including the bony and cartilaginous dorsum. I do open rhinoplasty for this patient. We can see the asymmetry and tortuous lower cartilage, and I divided bilateral lower cartilages to find the caudal septums, and we can see the deviated caudal septums that we prevented him from normal breathing. And I removed the deformed septal cartilage, and I also cut the deformed maxillary crest with the osteotoms. And also I use knife to correct the cartilaginous dorsum, and I use power instrument Renbird made by the Medtronic. I use it to correct the nasal bony vault, and also I do some suture techniques to correct the nasal tip deformity. So here's the front views. We can see the pre-op and the post-op, and the tortuous deformed bony and cartilaginous pyramid were corrected, and we can see very good alignment among the dorsums, and so also the asymmetric tip were corrected, and the concavities among the bilateral subtriangles were corrected, and also the patient was smiling, so means that he was satisfied with the surgical result. From the oblique views, we can see the deformities among the bony vault and the cartilaginous vaults were corrected, and I corrected also the lower cartilage, and I increased the projections. I do reapproximations of the lower cartilage to the reconstructed septal end, and I do dorsal augmentations to the patients, and we can see we got a very good nasal frontal angle and the nasal labial angles, and very good alignment among the dorsum. And here is the lateral views. We can see the hump was gone, and we do dorsal augmentations, and we also do radix grafts, and make it profile much better than before. So here's the pre-op and the post-op. We can see the deformed bony and cartilaginous vault were corrected, and we also do correction of the nasal profiles. We do hump removals, and we do dorsal augmentations. We do radix augmentations, and we can increase the projections, and also I correct the deformities among the tip and the subtriangles. Again, I want to thank Professor Dong-Hak Jang and the organizing committee of Korean College of Cosmetic Surgery and Medicines for inviting me to be a part of this great meeting. It is a pity that we cannot gather together because of the pandemic, but I do cordially invite all of you to visit beautiful Taiwan, and hope we can have fun together in the near future. Thank you very much for your attention.
Dr. Stephen S. Park will now be presenting on the functional revision surgery for devastating outcomes after rhinoplasty. He is the chairman of the Department of Otolaryngology Head and Neck Surgery at the University of Virginia, USA, clinical medical director of Otolaryngology Head and Neck Surgery at the University of Virginia, director of the Facial Plastic and Reconstructive Surgery Division at University of Virginia.
Hello, my name is Stephen Park, and I am from the University of Virginia. It is a pleasure and an honor to be a part of this esteemed rhinoplasty course that is truly world famous at this point. And a special word of gratitude to Dr. Jung for inviting me and including me in this renowned faculty. My task has been to speak on the devastated nose. It's a broad topic, but if we think about this, rhinoplasty patients come to us and they are not sick, and they are coming to be even less sick. So when a bad outcome happens in that frame of reference, it truly can be devastating to the patient's support system, and to us as the physician. It is our goal every day we go to work to ensure that these patients are never our outcomes. When I think of bad outcomes in rhinoplasty, and certainly if I reflect on my own experiences, I think these bad outcomes occur for a few specific reasons. At times there is an error in the diagnosis. So it is specifically in that initial encounter in our clinics where we are examining the patient and even getting their history. There's another set of errors that occur after that encounter before surgery, during that surgical planning phase. And then the third, and perhaps the most common, would be a surgical technique error. So we have the right diagnosis, we have the right plan, but we technically do something wrong in the operating room. And then there are certainly some patients where we actually do everything right and we still get a bad outcome. There is no question that to some degree, bad outcomes are the result of just bad luck. So diagnosis, thin skin. It is terrible to miss this because it makes your rhinoplasty very unforgiving. Every suture you place, every corner of every graft you place, and even the edges of our existing cartilage, as you can see in her in this primary rhinoplasty, are revealed. So every imperfection becomes a cutaneous irregularity. So we need to recognize this up front. And the reason why that's so important, because it can actually modify what we do. If overlooked, and it's easy to overlook this, very unpredictable things can happen. And as you see with this patient on the right, you can see the tip graft, the edges of the tip graft. And in fact, if you look closely, you can even see the blue proline suture that was placed there. The suture is visible through her very thin skin. Once we recognize this, it's not that difficult to rectify. So most of us get some autologous material. Temporalis fascia is what I usually use in a primary rhinoplasty. It has very low morbidity, even though it catches the patient by surprise initially when you describe it. If you're harvesting rib, then of course perichondrium from the rib is easily accessible. I think years ago, many people were using different types of alloplastic material or even alloderm, but my general sense is there's a little movement away from that at this point. And what we're after is a thickened soft tissue envelope that creates a tip that is smooth and inconspicuous. We just don't want to see or feel the edges of these cartilages. And that's what a fascia graft can do for us. Another error in diagnosis, and this is not an uncommon one. You know, at times patients like this will walk in, and what they will see and what they will say is that they have a hump. Right? A hump, in truth, is just relative, and so one of the things you never want to miss, the ultimate goal is to create balance in the nose. Balance within the nose and balance as the nose sits on the face. Right? So when the tip is underprojected, or if the radix is low, it will create the illusion that there is a dorsal hump. It will create a pseudo hump. And it is imperative that we recognize this, because if we don't, and we just start lowering her dorsum and we chase her underprojected tip and her low radix, when we're done, when we have a straight dorsum and we pull back and look at her whole face, there is not good balance. It doesn't fit. So much so that our eyes will even recognize that. So once we acknowledge that there is a low radix, then it's relatively straightforward to correct. There are any number of materials that people can use. I think most of us frequently use some crushed cartilage in a very precise and relatively small pocket right at the radix. And once again, the goal is just balance, right? So it is to perhaps lower the dorsum a little bit, but at the same time augment the radix area to create a natural appearing nose. There can be errors with surgical planning. So if you look at this patient, you can see that she has a pinched middle vault, and there is this classic inverted V deformity. And she had originally a dorsal hump reduction, and something went wrong with the planning of her procedure that led to this. The planning is an involved process. And if you think about how we go through this, it starts with a relatively simple layman's description of the problem. So the person may say, and along with you, well, the nose is too big, it's too small, too pointy, it's crooked, it's round, very simple terms. It is then incumbent upon us to look at this and determine what is precisely the anatomic etiology of this cutaneous deformity, right? And it's a very important exercise. What is the anatomic etiology of the deformity? Because once we define this, this then leads us to what our surgical plan would be, what the maneuvers are that we have to do in order to correct that anatomy. Every maneuver we do has a primary effect, and that's how we select that maneuver. However, every maneuver also has secondary effects. It has effects that happen long-term, even years later. And it creates illusions to the nose that we have to think about. For example, if we remove a dorsal hump, we create the illusion that we have created cephalic tip rotation. There are many such examples of that. Once we think of the primary and secondary effects, we think of how that impacts the cutaneous nose, the overall nose. And we can go around and around in this circle several times until we have a very airtight plan for our rhinoplasty. If we make an error with our planning, then it could lead to problems. So in the case of a dorsal hump, that was this previous patient. What do we do with our planning to ensure that doesn't happen? And for me, there are very specific things that we think of. What we want to make sure is that this never happens. This is devastating. I'm always with residents and students in my clinic. One of the beauties of that, of having a learner with you all the time, is that it forces us in an attempt to teach them, it forces us to reflect on why we do things and how we avoid certain pitfalls. In the case of a dorsal hump reduction, these are the 4 questions I ask myself, the 4 questions I ask of the learner and how I teach it. And the very first question is, what is the hump made of? And it seems silly at first, but it is it made of bone? Is it made of cartilage, or both? Is there an occult high dorsal septal deviation? Occult meaning asymptomatic, but deviated. And then always, what is the status of the chin and the radix, as I've just mentioned? And this is why it's important. This is our hump reduction, and I think there are subtle nuances that people do differently, but basically, in this case, it's the cartilaginous hump reduction. We come in with the Rubin osteotome and tap, 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 and basically remove this bony cartilaginous hump. And we can inspect that. And in the case of an endonasal rhinoplasty, we would have the nose redraped. We'd look at the profile if we're happy. Perhaps we would do lateral osteotomies to close the open roof deformity, and we'd be done. we would wrap up. But what's important is not necessarily what we remove, it is what we leave behind. And this is what we have left behind that you don't see very well in an endonasal rhinoplasty, but in an external approach, it's very clear. And this is not normal, right? The upper lateral cartilages have been disarticulated off the dorsal septum. Those cartilages are now unstable. And the existing dorsal septum now is new. It's very narrow, much narrower than a normal one. And it isn't always straight. In this case, it is. But there may be times where this new dorsal septum is actually twisted. And when we redrape the skin, you actually reveal a new twisted dorsal, twisted nose. And it's helpful to anticipate that. If you leave that alone, invariably those upper lateral cartilages will slowly collapse and they will dunk intranasally, create nasal obstruction, and create this deformity. Even when the dorsal septum is very wide, as you see here, after you resect the dorsal hump, this new dorsum is narrow. And the answer, which many of us know, are prophylactic spreadografts. So you may not have thought you needed spreadografts during your preoperative analysis, but after an aggressive hump reduction, not infrequently you do. And the goal is to restore width to the middle vault. Very important. This is an example, and it's sometimes easy to create a dramatic change with a hump reduction as evidence on a profile view. I would challenge you on your reading, on your presentations that you see, and perhaps most importantly, on your own practice. When you see your own follow-up patients after a hump reduction, take special note to the width of the middle vault. And if you have the luxury of following your patient for years, not infrequently, you will see that get progressively more narrow. I actually like, at the 3-month visit for the patient to think, and for myself as well, that middle vault is actually a little bit wide. I love that because I know it will narrow. If it's perfect at 3 months, at 1 year and at 3 years, it will probably be a little bit too narrow. Earlier, we talked about this very thin skin problem. What actually scares me more is very thick skin. This I'm not referring to a rhinophyma, obviously, but generally speaking, very thick skin concerns me because I find it very difficult to create a significant change. So of course, the very thick soft tissue envelope camouflages many of the maneuvers that we do, but it limits the amount of change that can take place. So there's a woman with thick skin, and her complaint is that her nose was too big for her face, too rounded, lacked definition. And I would suspect that many of you would look at her and agree. I certainly did, and agree to do her rhinoplasty. I did. The only problem is, this is her post-op view. This is her after my rhinoplasty, and she was not completely satisfied. And this is really how I learned this so well. This is her pre-op. So it is a little wider. And if you put the pictures side by side, we can see that there was some change, but it is not dramatic. There's a very finite ability for very thick skin to contract. You can only make the nose so much smaller in the case of a reduction rhinoplasty with very thick skin. So the answer many times is to augment the big nose with thick skin. And that's very counterintuitive, but very important. In other words, the soft tissue envelope will not contract enough. So in order to create more definition and to create the illusion that we have made the nose smaller, many times we actually need to augment and push definition through that soft tissue envelope. And that can be accomplished with something like this cap graft, which is aimed at increasing tip projection and thereby increasing tip definition. This is a woman, she has a young woman, she has a hump, a big hump. And this is probably what she focuses on. And if we just focus on her hump, and it is easy to make that smaller, and we overlook the bulbosity of her tip, when we're done, her tip will not match the rest of her nose. So we actually need to view each portion of the nose independently. So of course, yes, her nose is too wide. It has a big dorsal hump. But if you look at her tip, I think we can recognize that it also is a little amorphous, right? So the surgical plan for her is to do a dorsal hump reduction, bony and cartilaginous, lateral osteotomies to narrow the nose, of course, but very importantly, a strong cap graft from septal cartilage aimed at increasing projection through that very thick soft tissue envelope. And when we look at her, this is 3 months later, you can start to see some definition coming out. And she almost looks like a different person. It is dramatic, the impact that a rhinoplasty can have on the first impression of a person's face. Interestingly, 2 years later, with continued contraction, you can see her nose improves in definition, and it really just blends in with her face. And I think if you looked at her today, if you met her, your eyes would go to her eyes and they would not drift down to her nose, whereas they probably would have earlier. That is what we want. She has beautiful eyes, and that's where we should focus. We should make the nose inconspicuous. On occasion, we see something like this, and this is almost a rosacea, much thicker skin. And I do this very selectively, but of course, we recognize the skin. We're going to need to put a cap graft in there. But in addition, we come along and very selectively thin the soft tissue envelope. Okay? So we are actually debulking some of the nasal smass. And you have to be careful with this because, recognizing that the nasal smass, of course, is the blood supply to the nasal skin. and it will scar down sometimes in little unpredictable ways, but very selectively we can thin some of the soft tissue envelope. And once again, there is a limit to the result. He will never have a nose that is too small or too narrow. But increasing projection and narrowing or debulking some of that soft tissue envelope can just make his nose look a little less conspicuous. And he was 100% satisfied with that. The key step for that is not the maneuver, it's actually the preoperative counseling. It is critical for patients to have a sense of what they will get in this particular situation, because it is very easy to under-deliver, for the patient to have expectations that exceed what is physically possible. Okay. Technique. This patient walked in, and it was a good lesson. She had a rhinoplasty somewhere. She complains of nasal obstruction, and if you look at that, those are her lower lateral cartilages. And it's not exactly recurvature. That's I think that's the lower lateral cartilages that fell in and remucosalized, but basically during the repair, I think they neglected to close the marginal incision well, and this is what happened. Another technical error, this woman had a dorsal augmentation with a rib graft. That's pretty dramatic twisting. And I don't, those of us who do rib grafts know one of the things that's always on our mind and that we're struggling with is warping that occurs. And I consider that a technical error because, one, you have to slow down, you have to give it time for the graft to take its final shape. And as we know, we have to be very precise in utilizing only the central core of the rib. So, I don't think that's something that can be fixed subtly. In my hands, the only way I can really correct the situation is to take that rib out and start all over. And that's exactly what we did. And she looks better. This is a patient of mine who is a model. And she brings in these pictures of when she was modeling. You can tell they're professional photographs. And someone told her that she could probably be a little more successful if she had a rhinoplasty. You don't have to say that too many times to a young woman that she's going to get one. And she did. And I think one of the most common mistakes that are being made in rhinoplasty in general is excessive resection of cartilage. And we know that back in the 50s and 60s, that was the operation, right? A complete strip operation, very aggressive resection of cartilage in an attempt to refine the nose. While there is much said today that that's probably not exactly the right way to go, and it's more reshaping, I think it still occurs, and I see it. We have to be careful. This is her after her rhinoplasty. She's coming to me now. You can tell she's several years older, and her nose just doesn't work, right? When you look at her, your eyes go to the middle of her face. They drift away from her eyes very quickly. And that's because her nose appears so unnatural now. And it's unnatural because of excessive resection of cartilage. Another example, a young woman had a reduction rhinoplasty, and you can tell. I mean, if she walked into the room or you met her somewhere, you would know immediately that she's had an overly aggressive rhinoplasty. Her tip is way rotated up. It's too narrow. You can see how much alar retraction there is. And now she's coming in with new onset iatrogenic nasal obstruction. And she didn't have it before her primary rhinoplasty. So, it's a interesting analysis to do, because on the one hand, you might think that actually her nose is too big. And if you actually look at her nasolabial angle here, it is probably about 90 degrees. It's really the rotation of her tip and tip defining point that throws her whole nose out of whack. And if we look at it from a different view, you can see how that, particularly on the right side, how that lateral wall is collapsing intranasally. And you can see the edges of her cartilage. So the surgical plan for this is to undo what was done. It's to put back cartilage, even in a non-anatomic way, to restore things. So this is her nose degloved, and you can get the sense that her lateral curl, because they've been so aggressively resected, they are now really vertically oriented. And that created all the problem. That pulled up the tip, that pulled up the alar rim, and that allowed the lateral wall to collapse. So while this is obviously, this is not her, this is the general solution in my hands for something like that. It is very strong grafts, and it's sort of a hybrid between batten grafts that we place for functional rhinoplasty and alar rim grafts that are sometimes more like a toothpick, very small grafts. This is, as you can see, very strong, it's wide, it's long, and it goes down to the bony piriform aperture, and it is given incredible rigidity to that portion of the nose in an attempt to push the alar rim down. And this is her after that maneuver, and we've done several things, but I would say that her nose is now just a little more natural appearing, particularly with the correction of the alar columellar ratios. And sometimes we just have bad luck, right? I mean, we can do things right, but Mother Nature has a big hand in our rhinoplasty outcomes. And even in the early decision-making of our patients. So this is a young woman from Hong Kong. She was working very hard, was going to treat herself with a rhinoplasty. A little unclear how she found her doctor, but she went to a doctor for a rhinoplasty. And in my long discussions with her, I have the sense that this physician was actually a dermatologist. And dermatologists do what they're trained to do. And so they injected filler into her nose. So it's, I guess, bad luck that that's who she happened to see out of the box. And it's bad luck because the filler embolized into the vessel and it killed the overlying skin. So then she went back, and again, the same doctor did what he was trained to do. And so we put more filler in, and you're just chasing yourself at that point. And if you look at her closely, she has full thickness necrosis, and the alar rim has retracted up. And that happens because of the amount of scarring that has happened in the area above it. And her tip has started to drift to her right? So there's the obvious cutaneous deformity from the scarring, but also alar base asymmetry, alar retraction, deviation of her tip, all because of this. So what are we going to do about it? There's an American saying that says, sometimes go big or go home. What it means is sometimes you got to do the big operation, or don't do anything at all. Don't even look for shortcuts. So to my way of thinking, all that scarred needs to be excised. I mean, the dermabrasion is not an option. More fillers is not an option. So if we're going to cut out that scar, then we're going to have a defect. And then we need a flap to cover that defect that we create. The edge of the defect is the edge of our flap. The edge of the flap is your scar. So you give a little thought to where do you want your scar to be, right? And if we cut this scar out right across here and put our flap there, this is where our scar would be. And I will tell you that a scar across this dorsum of her nose will never be inconspicuous, particularly in a young person. So the question is, where do you want your scars to be? And let's strategically place them somewhere where it can be as inconspicuous as possible. And that is why we cut out this much skin. It's cutting out the whole lesion, the whole scar, but it's also placing the scars where we want them to be so they'll be inconspicuous. You can see she has some cartilage grafts. So what we actually did is roll some of the epithelial skin inwards as a turn-in flap so that this skin will now provide internal lining to the right alar rim, to the vestibule. And then conchoid cartilage grafts, which are serving as non-anatomic framework battens to hold the structure in place. And then she needs a forehead flap, which is a big hit for a young woman, as you can imagine. Selectively thin this flap to best match the thickness of the native skin in different areas. And then she sits like this for 3 weeks, and then we go back and divide the pedicle. And in the end, I think it came out okay. And it's certainly by no means perfect, but certainly less conspicuous than her original scarred nose. So that's just an example of, I think a devastating outcome, really from bad luck. We see a number of these kinds of patients, and most of us probably think something like Wagner's or cocaine or drugs, and we test them, but I think more often than not, in my practice, it's some kind of an autoimmune disorder. It has destroyed so much of the framework of her nose, but we're never able to really pinpoint a definitive diagnosis. And I enlist the help of people smarter than myself, certainly all our rheumatologists, and give her trials of steroids and different medicines. But ultimately, many times it burns out, and this is what they end up with. It's not only a deformity, but complete nasal obstruction. And the solution at this point is basically she has enough skin and she has enough lining. It is to rebuild framework. And I think the only way to do this is I believe, with autogenous material, and she really buys a full rib graft, recreating a new dorsal strut. Basically, it resembles an L strut, and this is not her, but this is what they look like. And what's very important, and sometimes overlooked, is the absolute need to put some cartilage graft in the lateral nasal wall. If you only project the nose and create improved dorsal projection, the lateral walls will be flail, and they will not be rigid and supported, and they will definitely get retraction and obstruction. So it is imperative to put some cartilage grafts not only in the alar lobule, but also in the middle vault sidewall area. So in this case, we put small thin slivers of rib cartilage in the lateral nasal wall. And I don't think anyone would say she has a beautiful nose, but very, very importantly, she has a functioning nose. And that's, of course, a critical step for this kind of a rhinoplasty. But it was a devastating outcome. So in summary, I think if we're honest with ourselves and we reflect on our rhinoplasty experience, I think many times we will find that we have made errors in each of these categories. And as we are forever students and forever learning, I think it is good to have the opportunity to reflect and actually see where your errors were and what we can do to prevent them. And then, of course, what we need to do to correct them. But generally speaking, I think some errors are made when we are in the clinic exam room and making an error in diagnosis, which is more often an omission in a diagnosis. We definitely have a very deliberate surgical planning phase, but errors can be made in there. There certainly can be technical errors, and that is why for rhinoplasties are very rarely a 30-minute operation. I mean, they take hours if we're going to give it proper attention. But sometimes bad things happen that are out of our control, and we ought to recognize that as well. So, Dr. Jung, and on behalf of the organizing committee, I am very grateful for the opportunity to be a part of this terrific course. Thank you so much.
We will now be starting Session 2, the 7th International Choson Aging Phase Symposium. Dr. Andrew Giacono will now be presenting on deep plane facelift. He is the director of the New York Center for Facial, Plastic, and Laser Surgery in New York. He is also the Associate Clinical Professor of the Division of Facial Plastic Surgery at the New York Eye and Ear Infirmary and Albert Einstein College of Medicine. He is the Section Head of Facial Plastic and Reconstructive Surgery at North Shore University Hospital, Manhasset. He was the past National Chairman and Senior Advisor of the Face-to-Face Committee for the American Academy of Facial Plastic and Reconstructive Surgery.
And the title of this lecture is What I've Learned on Over 2,000 Extended Deep Plane Facelifts. So I wanted to first mention that there's a bunch of articles that you can refer to that can help you understand some of the concepts I'll be discussing. And most have been published in the Aesthetic Surgery Journal. There have been about 6 that have dealt with the topics that come with extended deep plane dissection of the mid-face, the jawline, and in the neck. But there was an article in the Clinics of Plastic Surgery we published back in September of 2018, which really focuses more on a rudimentary but still comprehensive approach to the extended deep plane facelift in 2018. But I just published my book in 2021 this March. The name of the book is The Extended Deep Plane Facelift. That's published by QMP. You can also obtain videos through QMP and through the AFPRS if you'd like to see some more extensive footage of the intraoperative procedure. So these are my observations after having performed over 2,000 deep plane facelifts. So what I want to do is I want to discuss with you first how I approach the mid-face and the jawline, how I think it differs from when I performed SMAS facelifts. And I did perform SMAS facelifts up until about 2007, and I performed probably somewhere around 700 of them at that point. But when I look at the face, and specifically the mid-face, the biomechanics of the SMAS and the tissues in the mid-face are important for us to take note. When we look at a face, and you should look at your patients preoperatively, and you'll see that in this picture, is that there's a lateral SMAS that's quite fixed to the pre-parotid tissues and the pre-parotid fascia, which never descends. And then there's a more mobile medial SMAS that does. And we can see that when we look at this intraoperative patient where we've lifted the skin back, and we can see that the lateral SMAS overlying the pre-parotid and preauricular tissues is quite fixed. But when we grab more medially without even elevating the SMAS at all, and we grab that area, the mobile SMAS, which is the more anterior SMAS that's fallen, we can see how much more readily the face moves. And when we think about it biomechanically, most SMAS flap techniques come from a very far lateral approach. And in the face, the SMAS is quite tenuous and very, very tight laterally. But as you approach the more medial SMAS, and specifically the lateral border of the zygomaticus major muscle, there have been studies specifically published by one of my friends, Holger Gassner from Germany, that shows that the SMAS actually peters out and doesn't even exist more medially than the lateral border of the zygomaticus. So we're not going to get much of a midfacial effect, no matter how big of a SMAS flap we create. And obviously, we're lifting the tissues from a flap that's quite far distal away from what we're trying to lift. So whether we're a low or a high SMAS, even a high lateral SMAS technique is going to be lifting and suspending the tissues from a point even further away from the midfacial ptosis that we're trying to correct. Very different than this in the deep plane facelift, what we're doing is we're lifting a subcutaneous flap that bypasses the fixed SMAS. We're then entering the subSMAS plane, the deep tissue plane, creating a composite flap at the junction of where the medial mobile SMAS and the fixed SMAS exists. And then we're lifting the deep tissues underneath the cheek and the jawline. So we're releasing the flap. We're elevating what is actually fallen, which is not something we do in lateral SMAS surgery because we lift the SMAS laterally, but we don't dissect further medially. And it's interesting because in plastic surgery, we always talk about the importance when we're doing a flap, and a facelift is simply a flap, of making sure we do adequate flap mobilization and advancement. And really in a facelift, we're only mobilizing many times half the face and not the entire face, and specifically the area where the tissues have fallen. So, and additionally, we're suspending that mobile SMAS much closer to the ptosis, so we're going to get a biomechanical benefit from that. So when we look at the flap undermining in most high lateral SMAS techniques versus a deep plane, this is the yellow area, identifies the tissues that are usually mobilized in a high lateral SMAS, releasing some of the midface and a little bit of the zygomatic cutaneous ligaments. But in a deep plane, we're lifting much more further medially, and we're able to release more of the fibrous attachments along the zygomaticus major muscle and the zygomatic cutaneous ligaments, so we get more adequate flap mobilization. So here's an example of a patient that was 1.5 years post-op that came to see me for a revision who had a high lateral SMAS facelift. And when we look at the face, and on the right picture, you'll see it, the green line is the area where the SMAS was lifted to. And we can see that the area on the left, more medial to that green line, is actually still ptotic. So the jowl, the midface is still ptotic, but the tissues lateral to that are actually quite lifted. So the point simply being that flap undermining is important, tissue advancement is important, and we want to get under those more medial areas if we can do so safely, because we'll get a better outcome. More specifically in the midface, what's interesting is that the malar fat compartments, which have been studied by Roerich and Pessa, it's important to understand these septations, but they're all, the midfacial fat is tethered by the zygomatic cutaneous ligaments, and in their paper, Roerich specifically stated that the malar fat pad is densely adherent to the zygomatic cutaneous ligaments and zygomaticus major muscle, and redraping and elevation of that malar fat pad requires release, which occurs superficial to the zygomaticus major muscle, which is the T-plane. So in a traditional SMAS facelift, we're not dissecting medially over the surface of the zygomaticus, but in a D-plane facelift, as you will see, we do. So in a traditional SMAS facelift, whether it's a plication or not, we're releasing the tissues and leaving the malar fat pin down, bound by the zygomatic cutaneous ligaments. But what we're doing is we're dissecting on the surface of the zygomaticus major muscle, which releases the midfacial fat and lets us redrape it. And you'll see that in this intraoperative photo. What you're seeing here is the zygomatic cutaneous ligament that's tethering the cheek fat. We release that, and then the fat is up in the flap, that deeply mobilized flap, and you'll see that in the intraoperative photo video in just a minute. So in this paradigm, what we're doing is we're volumizing the midface by repositioning that medial mobile tissue and moving it to more vertical position. So we see it in this patient. We're entering the SMAS at the junction of the fixed and the mobile SMAS, and then we're getting under that medial mobile SMAS, that thick ropey tissue, and we're going to move it back up over the cheek. Interestingly, when you look at patient's outcomes, and this is a patient that was a year post-surgery, we didn't add any facial fat to her face, but arguably, I think if you look at her midface, her upper midface is volumized because we've sourced that ptotic medial mobile SMAS and that midfacial tissue and repurposed it and moved it up vertically. This helps prevent the need for autologous fat grafting in many cases. Even though I do autologous fat frequently, probably in greater than a third of my patients, that's beyond the scope of this talk. So when we talk about deep plane facelifts, the biggest concern most people have is with facial nerve injury. So deep plane facelifts avoid injury to the facial nerve specifically, and I'll show you how we do that. So first, we raise a subcutaneous flap to the deep plane entry point, which is from the gonial angle to the lateral canthus. We're bypassing the tissues where the frontal branch comes. It's deep. We're in the subcutaneous plane. We bypass the frontal branch. And then once we enter the deep plane, we're lifting the tissues over the parotid-mesenteric fascia, which leaves the nerves down in the fascia. And that's as long as we don't violate the parotid-mesenteric fascia, the nerves are safe. And then we're dissecting in the way that I perform this operation in the preabicularis plane. So we're on top of the abicularis muscle. We dissect down on the surface of the muscle into the midface, and that avoids any injury to the zygomatic branches, which are coming from the deep surface of the abicularis muscle. That is very different than the composite flap that was described both by Hamra and by Dr. Brian Mendelsohn, where they're dissecting in the prezygomatic plane, which is underneath the abicularis muscle, which puts specifically the zygomatic branches at risk. So this avoids that risk to the zygomatic branches because we're on top of the zygomatics, on top of the abicularis, unlike in here with the prezygomatic dissection. So here's the dissection, and here's an intraoperative video. First, we're going to elevate the subcutaneous flap to the deep plane entry point. Once we do that, and I use a backlighted flap technique to make sure that I'm keeping the skin flap appropriate thickness, we're going to enter the deep plane from the angle of the mandible to the lateral canthus. I enter the deep plane sharply with a 10 blade. As you can see here, I score the deep tissues from that gonial angle all the way up to the lateral canthus. And we're going to keep taking that up. Then we're going to do a dissection and creation of the SMAS composite flap. So we're leaving the skin and the SMAS and the subcutaneous tissue attached. And you can see as I press there, you can see that fascia, we use vertical blunt dissection with the facelift scissor, and we stay on top of the parietal mesenteric fascia. And you can see now that I've elevated that flap under the jowl. So you can see I'm all the way anterior under the jowl. Superiorly, what I do is I dissect bluntly on top of the orbicularis muscle, and you can see I'm just touching it down. The orbicularis is down, and as long as I'm on top of the orbicularis, I can then push my finger forward, and I'll be under the malar fat pad on top of the mimetic musculature. When I push down, you'll see the zygomatic cutaneous ligaments, and if I put my fingers above and below that ligament, we can see how the midface and the more medial jowl will not move much. Next, and here's that ligament. I'm going to dissect sharply on top of the ligament from superior to inferior. I'm on top of the mimetic musculature, on top of the zygomaticus and the orbicularis, so I can dissect sharply. This is very fibrous and hard to dissect with blunt dissection more laterally, but as we go medially, we're on top of the zygomaticus major muscle, and I'm all the way to the nasolabial fold, and I'm under that malar fat pad. So what we see here is an intraoperative photo. We're on top of the zygomaticus major muscle, and you can see a nerve coming up underneath the zygomaticus. This is the zygomatic branch coming up from the parietal mesenteric fascia that's pointed out by the green arrow, the zygomaticus by the white arrow, and we're leaving the orbicularis down. So what we're doing is we're defining the preorbicularis plane, and we're continuing it down to the medialis. And here's an intraoperative photo that we can see, and I'm pointing to it. And what we're doing is we're elevating all the deep tissues to the confluence of the mimetic musculature at the oral commissure. So I put my fingers always underneath all the way to the nasolabial fold to demonstrate the midfacial release, and I call this a Turkish test because I had a colleague that visited me and saw me do about 10 facelifts in a week, and every time that I finished the midface dissection, he asked me to place my fingers underneath the flap to show him the more medial anterior extent of the dissection. So that's why I call this the Turkish test. So once we have this flap elevated, we want to redrape the tissues more vertically because we're trying to source the midfacial fat and bring it back up over the malar prominences. So I'm going to suspend that to the zygomatic arch and periosteum, the deep temporal fascia. So the suture points for the fixation are along the deep plane entry point, and we're going to be suspending more high and lateral, just like a high lateral SMAS facelift. So the vector is high and lateral. But more medially, we're going to be suspending the tissues closer to the ptosis. I place usually a 4 PDS suture back and forth through the flap along those 5 or 6 points, and I work it all the way up to the area of the superior extent by the orbicularis superiorly. So once all those flaps are in place, we're going to vertically redrape the flap, and you can see when that comes up, the nasolabial fold smooths out. The tissues have all been elevated with that flap, and it brings the corner of the mouth up. The vector of the flap is essentially perpendicular to the nasolabial fold, and I don't have the time in this talk to discuss with you all the nuances of vectoring. But once we do that, we're going to suspend to the periosteum over the zygomatic arch, as well as the deep temporal fascia. The more superior suspension sutures that we place in the flap will actually help support the lower eyelid, and you'll see that here, the most superior flap, when I pull on that suspension suture, the superior aspect of the flap, it helps support the lower eyelid, which actually gives us a margin of protection when we're doing lower blepharoplasty. It supports the lower lid. So you can see I'm marking out the zygomatic arch here. And what we're going to do is suspend that most superior flap above the zygomatic arch, so it's a high and lateral suspension about 2 centimeters above the zygomatic arch. So even though we're entering the deep plane more medially, we're suspending it high and lateral and vertically, as you can see here. So this is some examples. This is a patient who had a vertical vector, deep plane facelift. We can see how the nasolabial fold has been smooth, the cheeks are up. There's more volume in the upper third of the face and a decrement of volume in the lower inferior midface. Another example of the same with somebody with a very heavy midface. I also did a lip lift at the same time on this patient. Another patient with a very, very heavy midface, and you can see how the cheeks were repositioned up high. The lower midface has been elevated, the nasolabial fold smooth, and the jowl corrected. The face takes on a more heart shape. Another patient, this patient had a vertical vector extended deep plane facelift like we discussed, and a lip lift at the same time. But again, you can see how we're sourcing that heavy tissue and bringing it up, which is helping efface the nasolabial folds and bringing the cheek volume up high. Another patient with a very, very heavy midface after an extended deep plane facelift. I also performed a lip lift on this patient at the same time. Same thing here. Again, look at the mid-face correction and improvement of the jowls as a result of mobilizing that mobile SMAS. People will often say that deep plane surgery doesn't sustain an effect in the mid-face. I disagree. This is a 3-year post-operative outcome for a gentleman who I did an extended deep plane facelift who was in his early 70s. You can see the big, thick, ropey nasolabial folds. You can see how the mid-face improvement in nasolabial fold effacement has been sustained at 3 years. Just some fun pictures of patients with very, very heavy midface who sent me their post-operative photos and selfies. Well, you can see how we're resourcing that midfacial fat and jowl fat, repositioning it vertically. You can see that the patient's acne scarring is still visible post-operatively, but it almost doesn't look like the same patient. Another example of the same thing, midface correction in the selfie series. And a gentleman with a very, very heavy nasolabial fold and midface and 9 months post-op, you can see the softening of the midface. As a result, the patient goes from a more square rectangular appearance to a heart-shaped appearance. So let's talk about the neck. The neck is always, for me, and I think for most surgeons, the biggest concern because patients often come primarily for their neck. And when necks fail, it's frustrating and often requires secondary surgery. So with necks and with how I approach the platysma, I know that more significant release of the medial platysma and suspension from a more medial point, just like we're doing in the deep plane, when we extend the deep plane into the neck, it creates a better and longer lasting result. So in the key here is medial release. It's flap mobilization of that more medial platysma that I think becomes much more redundant. I originally described releasing the cervical retaining ligaments that bind the platysma and extending that flap more medially at the same, in 2011, the same time that Thomas Musto did so. I did it in the ASJ and he in PRS in the same year. But we followed up studies looking at the extent of these cervical retaining ligaments that bind the platysma, and we published this in the Aesthetic Surgery Journal in 2017. And what we found is that those ligaments bind the platysma and extend for approximately 1.5 centimeters medial to the anterior aspect of the SEM, and that in order to be able to get more extensive mobilization of the platysma and reduce its redundancy, we need to perform a more medial platysmal elevation than a simple platysmal window or application of the platysma laterally. So this is what really defines the extended deep plane facelift. So in the traditional deep plane technique described by Hamra, the deep plane dissection really stops at the jawline and dissection doesn't continue inferiorly for fear of the marginal branch of the facial nerve. What we do is we extend the platysmal dissection for 5 centimeters inferior to the jawline and for, on average, 4 or 5 centimeters anteriorly in order to be able to redrape the platysma. And we also incorporate a platysmal myotomy. This is very, very different in its biomechanics from a SMAS transposition flap, which is traditionally performed with extended SMAS surgery, whether it's high or low SMAS. In a high or low SMAS, you see in the illustration on the left, what you wind up having is a minimal amount of mobilization of the platysma around the jawline gonial angle, and you transpose the SMAS platysmal flap behind the ear, which is the SMAS transposition. To the right is the extended deep plane facelift. And what we do is we mobilize the platysma. We perform a significant myotomy along the inferior aspect of the jawline so we can reposition the platysma and create a hammock underneath the neck. And what's nice is that cervical retaining ligaments that are part of that platysma laterally give us a dense fascial repair for us to be able to suspend the flap to the mastoid periosteum instead of simple SMAS tissue that's in the preauricular area. So people are always worried about the marginal branch of the facial nerve. The truth is that when we lift We're leaving the deep cervical fascia down with the parotid fascia. Similarly, as the nerves course within the parotid fascia, they course within the deep cervical fascia. So when we're dissecting, if we're directly under this mass, and similarly in the neck, directly under the platysma, which are contiguous, then the nerves will be down in the deep cervical fascia. So here's an example of that dissection. And what we see here is I'm going to be going, and you can do this from a submass approach as well, but with me, with the D-plane, I'm using some blunt vertical spreading inferior to the jawline, and then I'm going to make an incision along the platysma, right at the anterior border of the SCM. After I do that with the 15 blade, I elevate for approximately a centimeter from the anterior border of the SCM, and then I use vertical blunt dissection to help release it. Now you see all of these little ligaments. These get confused for cervical branches, which they're not, and that's what confuses people and makes them concerned about doing this dissection. But if we stay right on the platysma, we can dissect all the way far anteriorly, and now we have this thick, robust platysmal flap that we can redrape as part of our procedure. You don't want to dissect more anterior than the facial artery. The white that you see here, the arrow points out the facial artery, and we can see the marginal branch of the nerve coming up and coursing just anterior and superficial to the facial artery. So we don't want to dissect anterior to that point because the nerve becomes more superficial and can be damaged. But what I do is, since I have this platysmal flap up and the nerves are down, I perform a platysmal myotomy all the way to the submandibular gland to create what I call a platysmal hammock. And it places the point of suspension of the muscular flap, which is a muscular flap repair, right under the submandibular gland, which gives us a much more medial supportive effect on the neck and on the platysmal bands. What's nice is that this big platysmal flap also interrupts with a high platysmal transection which prevents flexion of the platysmal muscle and cording at the same time. So it will prevent your recurrence of cording. So the neck platysmal hammock, you can see it here in this example. What I'm going to do is I'm going to place that myotomy right below the angle of the mandible, and I'm feeling for it. And then what I do is I'm going to place a suture back and forth through and through that platysmal flap and suture back to the mastoid periosteum. But you can see that when I tighten the suture, it socks the platysma because the flap and platysmyotomy allows the muscle to lift up under the submandibular line. You can see how crisp that jawline is. Here's an example with somebody who has a ptotic submandibular gland, and you can see we're on top of the cervical fascia, the platysmal muscle is up, and then you can see that when I tighten that flap, it suspends the area underneath where the platysma is. In this case, with the patient has a ptotic submandibular gland that we see. Again, we put the suture back and forth through the flap and tighten it to the mastoid periosteum. And then when we do so, we can see how it socks that muscle up under the jawline. You can see that here. Supporting that's a muscular floor repair that helps suspend the submandibular gland. This is not a suture suspension. Those, in my experience, fail when you try to suspend the submandibular gland in its fascia. This is a muscular repair. That's the floor of that space that holds it up. But you can see it here. The submandibular gland in this patient is elevated. You can see it here again on the 3/4 view. You can see how the submandibular area is suspended. Same thing here. And it's a sustained effect. Here's that same patient at 1 year and now 4 years after her procedure. This is without opening the neck, and on the 3/4 view, you can see how there's a crisp definition of the submandibular contour as a result of this platysmal hammock. Again, a long-term outcome. Here's the same patient at 1 year and now 7 years after her surgery. You can see the platysmal redraping is sustainable, as well as that submandibular hollow and contour where the submandibular gland was starting to become somewhat ptotic. Another patient, same, a longer term outcome at 1 year and 2 years with a very, very heavy ropey platysma. The neck was not open. This is somebody today that I would open their neck, and I can't go into the details of when I do and don't open the neck in this kind of a lecture because we don't have the time for it. Another patient seeing at 1 year, and then here's the patient 7 years after surgery, and we see the sustained effect of the platysmal hammock repair. So let's talk about longevity in the midface and jowl. So Dr. Sherrill Aston did a paper in 96 where he did a SMAS plication on one side and then a D-plane on the other. And he said that there was no discernible change in the midface and nasolabial fold immediately after the first 24 hours and at 6 months and a year. I don't see that with this technique. Here's a patient pre-op 4 years and 11 years after her surgery, and I think her midface is still more lifted at 11 years, and for sure at 4 years after surgery, how the midfacial effect, even though it's gravitated back to things at 11 years, but at 4 years, the midface effect is sustained. Another patient at 1 year and 7 year, look at the nasolabial fold correction, still at 7 years, much better than it was in the preoperative condition. You saw this patient before with a nasolabial improvement at 3 years. Another patient, 1 year and 5 years, showing a sustained jowl and nasolabial fold improvement at 5 years. Another patient at 7 years, 1 year and 7 years, and we can see how the cheeks are still elevated, higher than the preoperative condition. And a gentleman at 2 and 8 years, and look at his nasolabial folds, they still haven't returned back to their preoperative condition at 8 years. So for me, I've had a lot of longevity with this approach. And lastly, I want to leave with you, deep plane surgery is safe. We published a meta-analysis of complication rates amongst all the different facelifting techniques. And this was published in the Aesthetic Surgery Journal. We reviewed 4,300 papers essentially, and we broke the patients down into types: SMAS plication, imbrication, SMAS flap, high lateral SMAS, deep plane, and composite, which is the technique that Hammer described. And what we found was the temporary facial nerve or injury rate was no different for SMAS plication and the deep plane that I'm describing. The highest rate of facial nerve injury were high lateral SMAS and composite facelifts. But these are temporary facial nerve injuries, and they came in at 1.5 to 1.8%, but they go away. So at the end of the day, I think it's super important when we're thinking about these things to think about the practicality if we can get patients better outcomes. There was no statistical difference with permanent facial nerve injuries in our review in the meta-analysis, but I think that when I look at my cases in 1,108 facelifts, what I find is that my temporary facial nerve injury hovers around 1%, and the tuck-up rate is between 3 and 5%, which is what's important to me. But I think what we need to consider are these are temporary nerve injuries. The rate is even though slightly different, they all resolve. So in my practice, the techniques that I choose in the deep plane are those that give me the best outcomes and the longest lasting results. And I want to thank you for your attention. I wish I could be there with you in Istanbul, and I hope to be there next year when things are back to a little bit more normalcy.
Dr. Neil Gordon will now be presenting on deep plane rhytidectomy, from novice to expert. He is the director of Head and Neck Aesthetic Surgery Department at Yale School of Medicine. He is also the clinical assistant professor of Plastic Surgery Department at Yale School of Medicine. He is the director of Split Rock Surgical Associates, New York, USA.
Hi, my name is Neil Gordon, and I'm honored to be part of the Global Summit of Facial Plastic Surgery. And my topic is the deep plane rhytidectomy from novice to expert. So my practice is mainly surgical facial rejuvenation here at the Retreat Split Rock in lovely Connecticut in the United States. So my first concept is understanding youth is not necessarily about an appearance, it's about an anatomy, and that anatomy changes. So if we look with somebody with significant changes and we look at their anatomy, well, what do we see? The most obvious thing is soft tissue redundancy. So I don't think there's any argument that this is the predominant factor of aging. So the technique or the concept that best mobilizes and repositions all the soft tissue, resects the excesses without producing skin tension, is going to best reproduce the anatomy we had when we were younger. And it'll explain how we can take people with significant changes of aging, reverse it in a manner that's both predictable, natural, long-lasting, and consistent. And it's not necessarily easy because even the President of the United States couldn't figure this out, as we see evidenced by his pixie ear deformity likely from a SMAS rhytidectomy. Well, embryology backs up our concepts of the deep plane. And if we go back and understand the pharyngeal arches, so each one's associated with the cranial nerve, with the first pharyngeal arch being the trigeminal, the second pharyngeal arch being the facial nerve, and they're separated by a pharyngeal cleft. Well, that pharyngeal cleft is actually the primordial deep plane, and it's evidenced on a 6-week-old embryo. If we look at the first pharyngeal arch, which is the superficial soft tissue envelope, it has a biomechanical behavior because there's fibrous septae that attach from the skin to the dermis, causing it to act very similar to a sandwich in that we can essentially put traction on its underbelly and move the whole unit. The problem is that SMAS procedures break this apart, and the minute that they break this apart, they do not behave the same as deep plane procedures, even if the dissection is similar. Horizontal anatomy also supports our deep plane approach, because if you notice in looking at the midface, the majority of the aging changes are actually in the middle or medial aspects of the midface, because laterally the superficial cervical fascia is fixated to the parotid fascia. And the problem is SMAS procedures are accomplished laterally. What we need to do is access the medial aspects of the tonic and this gravity-affected soft tissue, which a deep plane does. The original description in 1990 by Sam Hammer was actually fairly limited, with the inferior aspects of the dissection being the angle of the mandible. And really two key points that he made was that you can release the zygomatic cutaneous ligament, and you can put excessive traction on the underbelly of the soft tissue unit and not have it show to the surface. Well, I've been one of the people that have advanced the deep plane technique over the last 25 years to what I call the vertical platysmal advances, which allows us to approach some of the deeper structures of the face, and most importantly, do an anatomically accurate dissection and repositioning, as well as take the advantages of the soft tissue and further do ligament release for further and greater mobilization based on this premise. Well, here's essentially a figure of the original dissection. In our procedure, we use more lateral marking, which we're going to get to later. And the first landmark for the basic technique is going to be the orbicularis muscle, which is easy to define, and we're going to be superficial to it. And where we're going to enter the deep plane is going to be just superior to the angle of the mandible. Well, 2 centimeters superior is a very safe place. There's no nerve. There is a floor of a masseter muscle, a ceiling of platysma, and a very obvious fibroareolar plane. This will allow us to continue the dissection, isolate the zygomaticus cutaneous ligaments, which we will have to sharply dissect, and essentially deglove the face that's showing the root of the zygomaticus major muscle, and incorporate all of the facial soft tissue into the flap. If we look at some of the differences from the basic technique to the advanced technique, one of the differences illustrated in these two diagrams or these two photos is the extensive cervical ligament release, which allows further soft tissue incorporation into our flap, with the Q-tip on the edge of the regular or the basic dissection at the angle of the mandible. We have control over the facial ligaments, and allows us to release specific ligaments specifically based on the facial anatomy and our goals. Well, let's look at why we need to release the zygomaticus cutaneous ligament. So since the basic procedure requires that release, what that does is allows us to mobilize the entire midface, as evidenced by the volumization that's occurring in the malar area secondary to the ligament release. In a second case, we see that volume depletion effect caused by aging that's reversed, not by addition, but by essentially zygomaticus cutaneous ligament release and a movement or mobilization of the entire cheek pad, which when we don't release, does not occur in the frontal view. Whereas as we become more lateral, and a modified procedure where we don't release the ligament essentially behaves as a neck lift. We can approach the buccal fat pad and make an in vivo diagnosis. And the keys were accessing the anterior buccal fat pad, which can contribute to jowling. And if it's not treated, it will leave persistent jowling, and we could not reach this intraorally. It's a basic and conservative procedure that's an adjuvant, and we don't want to be aggressive because we don't want to create creasing, which we couldn't fix or correct. As evidenced in this 59-year-old patient, we see pseudoherniation of the buccal fat pad in the supine position. We can make a nick in the fascia. We can deliver the fat. We can tease it out safely and produce a contour in the medial aspects of the lower part of the midface. So we have control over it and its contribution to jowling. Well, let's look at the basic technique. So since this lecture is both for basic and advanced, I'm using an older video that we had done about a decade ago when we were still doing more of the basic type of technique. We have very significant soft tissue mobilization, so we have to use triclophytal or hairline incisions. How we're going to enter posteriorly is not based on an anatomical landmark, but it's getting to know by feeling faces where the tissue is going to move and the vectors involved. A subcutaneous dissection is standard. It's going to continue preauricularly, postauricularly, and into the neck. And this is going to get us to our first landmark, which is the orbicularis muscle. And we're not going to do a significant dissection there to prevent prolonged edema. Now we're going to enter the D plane just where we had stated before, just superior to the angle of the mandible, about 2 centimeters. There's no nerve there. There's an obvious floor of the masseter muscle, a ceiling of platysma, and a fibroareolar plane. Blunt dissection, which I'm doing with my finger, also allows me to feel the thickness of my flap. And by feeling the thickness of my flap, it's going to allow me to be accurate in areas such as here, the zygomaticus cutaneous ligaments, because there aren't as many landmarks here. So the way you know you're in the right place is by feeling the thickness both inferiorly and superiorly, because if the soft tissue gets too thick or too thin, you may be off plane. Once you release the ligament, which you must do sharply, you can then dissect along the zygomaticus major muscle. Now we see the buccal fat pad, we see it's pseudoherniated. We can treat it based on the in vivo diagnosis, deliver it as we showed before, and safely resect it, and thus do an anatomically correct approach. This also allows us access to the parotid gland in the preauricular fat area and control facial shape, which is very important, especially in these heavy faces. So a heavy face anatomically shows a thickening of the preauricular tissue, but not only is it subcutaneous fat, which we can resect sharply, but that's also going to expose hypertrophic parotid glands, which are much more common than people realize. And we've published on this and showed that parotid hypertrophy is a common issue in the aged face. We can bring this down. We can approach the buccal fat pad in vivo, as we decided showed before, and look at the difference by contouring that preauricular area, how much we'll be able to bring this down. This is going to create facial shape, both medially and laterally in the inferior aspect of the midface, based on the case and based on the patient's intraoperative anatomy. We can also apply it to younger patients where it's more of a congenital issue and use facelift technology to create facial shape in a similar manner. Well, if we look at a video of this, what we can see is look at that thick, copious tissue. And surprisingly, there's not a lot of subcutaneous fat. The technique is a filleting technique, and the key reason is that we do not want to violate or take down the parotid fascia. We need the parotid fascia in order to fixate the flap. Now, right where I was right there, so in the preauricular area in front of the tragus, that area has to be contoured down for multiple reasons. One, we need to put the flap in and essentially layer in that flap, and we don't want that area to be thicker and create a step off, which would be an obvious facelift. We want to take it down to the parotid fascia, but not through it. And now we can do further contouring, and then we're going to approach the parotid gland with the fascia intact with bipolar cautery. The bipolar choroidal will shrink down the parotid fairly significantly. It's very safe because the facial nerve is fairly deep to it. And remember, you're only using it when the parotid gland is hypertrophic. So thus means there's a great distance between that and the nerve itself. We can shrink it, and we want to shrink it essentially from the tragus inferiorly. We want to create a groove. Now we can extend the deep plane inferiorly into the neck. We can release cervical ligaments. And again, we're controlling facial shape. So now let's discuss the neck. What we essentially want to do is differentiate the superficial neck from the deep neck because it's managed differently. The superficial neck is from the platysma to the skin. The deep neck is deep to the platysma. The superficial neck is mainly the superficial soft tissue envelope stretching out and hanging in the neck, as well as preplatysmal fat, where the deep neck is going to be subplatysmal fat, digastric muscle, submandibular gland. This is going to be more accessed through essentially deep platysmal work through any technique, as well as some of the advanced deep plane. Well, why is this important? Is because the superficial neck is very easy to access, it's often overtreated. And whereas the deep neck, which is not medial, is paramedian, is often difficult, and most surgeons don't want to necessarily access, so it gets undertreated. The imbalance between treatment aggressively of the superficial neck and not addressing the deep neck creates cobra deformities. So how can we assess preoperatively? How can we assess intraoperatively? Well, one of the biggest changes in my practice over the last 15 years is how minimal I treat the preplatysmal fat, just essentially in the submental area. We do resect redundant platysma, we do fixate the platysma in the midline, but only to the hyoid. And if the fixation starts to bowstring a little, we'll do a minor cutback medially on the platysma. I find this view helpful in differentiating what's essentially superficial from deep neck. The blue arrow, which is medial or midline, is going to be superficial neck, mainly platysma. The yellow arrows is going to be deep neck, which is going to necessitate subplatysmal work, whether it's fat, digastric, or even submandibular gland, which inherently we are going to be conservative with, as well as combining both mandibular and cervical ligament release. Well, let's use a case with a significantly aged face to illustrate. I find this maneuver both intraoperatively and even not in the operating room helpful. If you lift the face in the midface, and I'm doing it in an exaggerated way for this video, and the neck flattens out in this manner, that means mobilization of the entire superficial soft tissue envelope through the flap dissection is going to essentially treat the majority of the neck, and it's not going to need significant neck work. And if there's bulges there, then that's going to be more indicative that adjuvant, both preplatysmal and subplatysmal work will be done. Well, the deep plane mobilized this face so well. Look at the redundancy. This is essentially the outcome that was created in this case. But here's the key. Look at the amount of soft tissue that was resected in this case. But this is about 80% of what was actually removed from the neck. So that outcome was achieved by mobilizing the flap, which again is consistent that the majority of the neck was due to ptosis of the superficial soft tissue envelope. I'm not aggressive in mandibular ligament release. What I find is I don't find it necessary, and it's a superficial release. It's essentially a subcutaneous release, which is very different from the zygomaticus cutaneous ligament, which is a deep release. We will use it, but the point is it's a vascular area. I find the only bruising I'll get is from release of the ligament. And this is a case where we did not release the ligament. So if we can produce this amount of soft tissue redundancy and a smooth jawline contour without releasing it, we don't. But this is a case that you need to. So in a revision where it's not just a pixie ear, but if you notice the earlobe is both anteriorly displaced also, that means there's going to be a significant soft tissue deficit that you're going to have to approach. And there you want to recruit as much skin as possible. Well, some of the advances that I've helped to pioneer in deep plane procedures have been cervical ligament release. We first applied it in the difficult, stiff, and non-compliant faces or revisions. I use a graduated approach where the amount that I'll release is based on the issues particular in the case. The red arrow is the angle of the mandible. The yellow arrow is the inferior extent of the cervical ligament release in this case. And the blue arrow is if we did a platysma myotomy. So as far as a back cutter myotomy, I don't actually find that necessary in a lot of cases. The reason why I don't always use it is I find we can actually create a significant lateral neck contour that's long lasting. And when you cut any muscle, whether it's the platysma muscle medially or laterally or forehead muscles, you have the issues of ridging of the muscle that can occur, as well as odd reanimation or animation that you can't really fix. Where I do find this is very helpful is if you want to treat the neck without aggressively moving the midface. So I do think there's value in keeping the flap intact. So if we look at this 58-year-old case, we see intraoperatively, look at all the soft tissue redundancy that's not always evident in the photograph. The point is get used to feeling faces. You're going to learn a lot about the soft tissue and thus how it's going to behave. Well, this is our dissection. So we're going to mark, we're going to enter the deep plane. We want a nice sharp edge, but look as I go superior, look how far lateral I am. This is very different than the hammer dissection. I think this is one of the most significant advances in the technique, was entering the deep plane much more laterally, superiorly, as I'll show in some videos coming up later in this talk. Now, because I've tented up the platysma, I'm already doing some of my cervical ligament release by essentially outlining. Now I'm entering the deep plane, essentially superior to the angle of the mandible, where we said it's safe and well-defined. And then I see the plane, I put my finger in, and then you can see with a couple of swipes of my finger, look how much of the plane I've dissected. Again, I like using my finger because I'm constantly feeling the thickness of my flap, because look at all that I've dissected. It's a nice even flap, but I know the thickness. So now when I go to the zygomaticus cutaneous ligament, I know how thick that soft tissue should be. It's a good way to judge if you're too steep or too superficial. Now releasing the ligament, if you notice it's white and it's strong, you need to do it by sharp dissection. And again, what I'm a believer in is keeping this whole flap intact. I find it heals more predictably, it heals quicker, and it doesn't require necessarily breaking this flap in half with a platysma myotomy to achieve the neck contour, as long as you're willing to aggressively mobilize and move and fixate the midface of your flap. Well, this is going to show as I finish this dissection where the angle of the mandible was, and my degree of dissection and release is going to be based on the case. So I don't predetermine it in a sense more than looking and feeling the face, and the Q-tip shows where the original deep plane would have entered, and that's my release. Now, as far as the fixation of the flap, now we're getting into more advanced concepts. We're going to bury our 3-O-proline underneath the flap, and we're going to advance the flap, and we're going to use more laterally based sutures, but we're going to advance the flap aggressively. I think it's very important that you just don't try to pull the flap up with a suture. Here, by advancing the flap to the point of dermal dimpling. Now, if dermal dimpling does not occur, you can actually put a little more tension on it, because this is your lift. Notice the technique where we're sliding the flap. Now we're going to do our cervical ligament release reapproximation. So we got to resuspend. Now this is all part of a flap, but if you notice that if you release a ligament, the ligament is holding things up, the platysma will move forward. So if you release, you must resuspend. And we're going to now move that back, but it's all part of the flap, and we're going to fixate it to the mastoid area. And that's going to produce our lateral jawline. Again, we're using a 3-O-proline suture. We're going to now slide this back to the mastoid, but not as a separate myotomy, but as part of this contiguous flap and you'll see that the flap will have essentially a much more predictable contour, and you'll never end up with platysma issues that can occur from cutting the muscle. So this is the outcome, but the key point here is right this view. Look at the lateral jawline that's created without cutting the platysma, but still doing release. Well, the focus on most of these talks is on the dissection of the deep plane, but the majority of suboptimal outcomes is actually due to flap management. The greater the amount of soft tissue, the more complicated the flap management. And the better you move the soft tissue, the better the outcome. Well, there's nuances that have to do with the type of face it is and where you enter the deep plane, place your sutures, vectors used, and some of it depends on whether it's a primary or a secondary case. But here's the reason why. If we look at this video, this was done by an outstanding surgeon, but notice the temporal area. Notice the pleating that's occurring. There's three reasons, there's a couple reasons for this. One, the suture fixation is too far medial, creating anchor points, and the incision ended too far inferior, not allowing the soft tissue to layer out. Soft tissue bunching does not always layer away and actually can create a lot of dissatisfaction because it's visible in the mirror, and this can be avoided. How we enter the deep plane in general, we enter it more medial with the thicker faces with excessive soft tissue redundancy, and more lateral with thin faces, revisions, or smokers, or we want to volumize the face. So what I mean by volumizing is when you enter the deep plane more lateral in the superior part of the midface, look at this cuff of fat that will act like a fat graft in the sense that you thicken the flap and double layered the fat in the malar area, creating even more malar widening if you choose to do it. So this gives you control of the midface and expanding it where in other areas we contracted it. But the key to that cuff is really here. That soft tissue cup we're going to utilize right now, because what we want to do is the superior aspect of our flap, we want to anchor it under the temporal hair tuft. I think the biggest issue in advanced deep plane facelifting is not anchoring that flap in the right place. And if you anchor it underneath the temporal hair tuft, you're not going to run into problems. Any extra soft tissue redundancy, meaning any extra cuff that you don't need, you can just simply tailor away. And this is what happens when you end your incision too far inferiorly. So don't be afraid of extending your incision and layering out the tissue. Well, this is also going to be evident in the complexities of the temporal area, because it's not only extending the incisions, bearing or essentially lateralizing your sutures, but also dealing with the way the relaxed skin tension lines will rotate. So around the lateral canthus, the relaxed skin tension lines will actually rotate. And so how you manage the flap so you don't have too much soft tissue, you see how that skin is going to rotate, and you're going to have an arc or a sweep of that flap if you actually get too aggressive. So I spend more time in the temporal area than any other area of the case. So let's look at a couple of cases. The power of the procedure is really revealed in older patients with poor hairlines, heavy, thick faces that were difficult to mobilize in the past. But here you can move all that soft tissue with no evidence of any skin tension. I love approaching younger faces. By the way, all these faces have brow lifts and also have eye work. I rarely do a facelift alone on a female, non-tension closures, the typical 64-year-old, the power of a balanced procedure and the amount of soft tissue that you can move. But if you notice the transitions to the temporal area, they're nice and smooth, they're homogeneous, and the power of creating that neckline without any signs of skin tension. Revisions give it away. This woman had a pixie ear and bad scars, but look how we reversed the pixie ear, gave her a new facelift, and also fixed her essentially suboptimal scarring. And again, in a similar manner, this woman had a chin implant, the typical face, and this is why we don't do parts of faces. We tend to do the face as a unit for these reasons. These last couple of cases are specifically looking at older cases. This is when I was doing basic technique. And the reason why is I don't want anybody who's listening feel that if you don't do an advanced deep plane, you shouldn't do deep plane. The basic technique is creating these last couple of cases. So look how powerful the basic technique is. This case I did 20 years ago. And again, she's got good anatomy, but we didn't do back cuts. We didn't do extensive releases of ligaments. And the basic procedure done here in 1998 still held up when this patient was 13 years out. And what I like to say is if you do a good job on one, you get all their friends. So in conclusion, the deep plane is just an anatomically correct procedure that allows us to do in vivo diagnosis, mobilize soft tissue. Novices can perform this safely. Experts, the challenges of the dissection, don't underestimate the flap issues. And I want to thank everybody for inviting me and having me as part of our global camaraderie. And I look forward to doing more things in the future. Thank you.
Dr. Özkan Kagmak will be presenting on the modified composite facelift with extended neck dissection for harmonious rejuvenation. He is the group chair of the Rejuvenation Focus and fellowship program director of European Academy of Facial Plastic Surgery. He is the credentialing committee co-chair of European Examination Board on Facial Plastic Reconstructive Surgery. He is the director of FACE at Istanbul Hospital, Turkey.
Hello, this is Dr. Özcan Çakmak from Istanbul, Turkey. I would like to talk about modified composite plane facelift with extended neck dissection. These are my references. I will start with the essential anatomy. SMES is a continuous fibromuscular layer enveloping the face and neck, invests and connects superficial mimetic muscles, and forms a single anatomic and functional unit. At the face, SMES invests the superficial mimetic muscles, and at the neck, it's continuous with the platysma. Facial nerve branches are deep both to the SMES and the paratomesenteric fascia. Malar fat is a subcutaneous fat located superficial to the SMES, which invests the mimetic muscles. Retaining ligaments anchor the dermis, subcutaneous fat, and SMES to the bony periosteum or deep fascia. These ligaments support facial soft tissues against the forces of gravity, and the attenuation of these retaining ligaments with aging leads downward displacement of facial fat compartments and responsible for many of the stigmata that occur with aging. Most prominent aging changes occur anterior and inferior of these ligaments, and we call this area mobile SMES, and we try to just pull and fixate to the fixed SMES. These ligaments prevent the transmission of traction to the malar portion of the dissection during traditional low SMES facelift techniques. Specifically, releasing the zygomatic cutaneous ligaments is important for malar repositioning. Releasing the mesenteric cutaneous ligaments is important for effective correcting of jowling. Releasing of mandibular ligament is important for correction of prejaw sulcus and marionette lines. Releasing the cervical retaining ligament, which is located between the sternocleidomastoid and platysma, is important for maximum improvement of the neck and definition of the mandibular contours. Facial nerve branches travel deep to the paratomesenteric fascia, and they pass a more superficial plane just before reaching their respective target muscles. The exception is cervical branch. It becomes more just superficial after leaving the parotid. So maintaining the integrity of paratomesenteric fascia is important to protect the facial nerve injury. It's difficult to distinguish facial nerve branches from the ligaments during dissections, and complete release of the ligaments carry the risk of facial nerve injury. These are the danger zones, which the nerves become superficial in dissection, or where these nerves transfers between the retaining ligaments of the face. Facelift techniques, SMES techniques. There are two main SMES techniques. SMES imbrication, there is no cut on the SMES. SMES is just pulled and and folded in and fixed to the fixed mass. This is max lift, most popular implication technique. SMES implication technique, there is an incision on the SMES, and SMES is either removed or transposed with or without limited subSMES dissection. Lateral SMESectomy is the most popular implication technique. Theoretic SMES of the lower face and neck can be successfully pulled and suspended in superior direction. But if you want to improve the midfacial aging changes, since these techniques do not release these ligaments, it's not possible to improve that area by using these techniques. Inadequate release of these ligaments may lead unbalanced and unnatural appearance. Additional attempts, such as injecting fat to just make this area rejuvenated, may result with a stuffed look, operated appearance. Most facelift surgeons are hesitant to transect retaining ligaments because of nerve of injury. Extended facelift techniques involves releasing of these ligaments. And these are the zygomicutaneous and mesocutaneous ligaments. In all extended facelift techniques, SMES dissection is advanced towards the midface along the superficial surface of the zygomatic muscles, which allows repositioning of the malar fat. These are the main extended facelift techniques. James Tuzin's extended SMES lift, there is SMES and skin, two separate flap dissected separately. At high SMES lift, there is a horizontal SMES incision placed higher over the zygoma. Deep plane facelift, the skin, SMES, and malar fat dissected as a single unit. At the composite plane facelift, additional to the deep plane facelift, there is orbicularis oculi muscle elevation, which allows more harmonious result. When we compare single unit techniques with the skin and SMES elevated separately techniques, these are extended and high SMES lifts, and these are deep and composite plane facelifts. Undermining the flap as a single unit provides excellent blood supply to the overlying skin, and these operations are much more advantageous, especially for smokers. The other thing, at this deep and composite plane facelift, the fixed SMES area is not elevated, so it avoids unnecessary fixed SMES. These techniques avoid unnecessary fixed SMES dissection. As a summary, if a surgeon performs traditional facelift techniques, the lower face and neck changes will be rejuvenated. If performs extended facelift techniques, there will be additional improvement at the midface area. And if performs composite facelift and adds the orbicularis oculi muscle, there will be additional improvement at the upper nasal fold area. Recent comprehensive systematic review by Andrew Giacono showed that extended techniques, while identifying and preserving anatomy, often leads to lower complication rates than blind working around vital structures. It's very interesting finding, because usually the surgeons believe that just extend dissection causes more morbidity. Actually, just elevating the tissues and seeing the layers and nerves below you allows you working just safer. Otherwise, these blind bites of sutures would cause really more morbidity. As I mentioned, facial nerve located below the parotid mesenteric fascia, and how we will protect the nerve branches, I will talk about one by one from all. Zygomatic branch has close relation with zygomicutaneous ligaments. Distinguishing these ligaments with the zygomatic branch branches is not easy during the dissection. And zygomicutaneous ligament requires sharp dissection because it's very strong ligament. All extend techniques, the dissection just starts over the orbicularis oculi muscle, and we extend the dissection over the orbicularis oculi muscle and go inferiorly over the zygomatic muscles, because these zygomatic muscles are innervated from their undersurface. So we need to go superficial over zygomatic muscles for safe dissection. But how to succeed safe midface elevation during midface? Because this ligament requires sharp dissection and it's not easy to distinguish. My concept is doing this section below the orbicularis oculi muscle, because if you use prezygomatic space defined by Mendelssohn, as he defined, you will be releasing the ligament just under direct vision. You will be seeing this ligament as a body of the tree. And at that space, just superficially releasing this ligament just allows you to see the zygomatic muscles attaching to the bone. So this is the paper mentioning the details of this technique and how to release the zygomatic ligaments safely. I can summarize that orbicularis oculi muscle covers the zygomatic muscles, heads. And if you are going under this muscle, you will be seeing their attachment very just under direct vision. And releasing this ligament will be very safe. And staying on this correct plane will be much easier. So dissecting below the orbicularis oculi muscle will allow you to see the pivot point, which is a zygomatic ligament, and you'll be releasing superficially. And you will be seeing these zygomatic muscles just attaching to the bone. You will be easily dissecting inferiorly. But if you are doing deep plane facelift, you will be staying on the orbicularis muscle surface and maintaining your dissection inferiorly, staying just superficial to these muscles, but it's not always that easy to see the details. If you are doing your dissection or starting your dissection just below orbicularis oculi muscle, then it will be just much easier to see zygomatic cutaneous ligament as a main strong branch of the tree. And it will be very easy to just release it superficially, and you will be staying to the just putting on the right plane. And this is my letter expressing these details. And this is a commentary by Mendelssohn to my paper. As you can see here, if you are working in the real place, you will be seeing the ligament like that. And the dissection of this area is very easy because this is a real space. If you are just superficial to the orbicularis oculi muscle, you will be seeing the branching of these ligaments. It's not easy to distinguish these ligaments from the nerves, and this is not a real plane, and dissection is not that easy. So it will be much more harder, much harder for especially unexperienced surgeons to do dissection at that level. One more important thing, this dissection is first described by Aston below the orbicularis oculi muscle, and he said he defined this as a finger-rested malar elevation or FAME. But FAME dissection starts more superiorly. And if you do this dissection superiorly, you will be denervating the muscles frontal coming from frontal branches. So this will be denervated, and also some zygomatic branches will be denervated. With my modified approach, I just do limited dissection just at the inferior lateral portion of the orbicularis oculi muscle. Maybe I will be just denervating partially here to the zygomatic, some of the zygomatic branches. So this is just what I do, just to see the heads of the muscles and just to see the ligament and release safely. And I don't touch to the buccal branches. Actually, these branches are most important for the function of the orbicularis oculi muscle. So if you are not denervating buccal branches, just buccal branches here, and just to denervating the zygomatic branches and not the buccal branches at all, then orbicularis function will not be affected. So you can read for details this very nice article. So there will not be any morbidity if you will be just below the orbicularis oculi muscle here. If I compare my dissection below the orbicularis oculi muscle here with the original composite facelift technique by Hamra, he uses a blepharoplasty incision and makes this dissection through blepharoplasty approach. What I do is I just do this dissection through facelift approach, and he doesn't combine these sections, but I combine these dissections. Other modification, he pulls orbital isoclinic muscle in supramedial direction. His vector is different. What I do is I pull this flap, the part of the orbital isoclinic muscle, including this part, in a posterolateral direction. So I believe that this pull will really improve the upper nasolabial fourth area, which is the hardest area to correct. And let's see step by step. First, skin dissection, the extent of skin dissection. And then I just mark the line to enter the subsmess dissection. And I start my subsmess section. When I come to ligament, I stop and I do prezygomatic dissection with either scissor or finger. Very limited dissection is good enough to see the zygomatic cutaneous ligament. It will be the pivot point, just stopping your finger to go down, and you will be releasing this ligament superficially, and you will be seeing the zygomatic cutaneous zygomatic muscles just next to you under direct vision. And it will be easy to just follow the dissection and releasing the rest of the ligaments. And this is the video. Finger dissection. And then releasing the zygomatic cutaneous ligament with sharp dissection. And then maintaining the dissection anteriorly. And you are seeing the zygomatic muscle here, major muscle. And it will be very easy to combine this orbital section and suborbital section and the facelift section. And this is the facelift flap. And this is the rejuvenated flap after pull. And this is the result of a patient without any fat injection. You can get a nice improvement at the cheeks because of repositioning of the malar fat. Another patient, because of repositioning, you can get some additional improvement at the mid-face area. Another patient, not only lower face and neck improvement, there is also some improvement at the malar region. And a revision case, improvement at the malar region. Releasing these ligaments really improves this facial aging changes. Another patient, no any fat injection, just makes the cheeks fuller because of repositioning of the malar fat pad. Especially for thick skin patient, this is very important to reposition and decrease nasolabial fold prominence. Another patient. Buccal branch has a close relation with the masseter cutaneous ligaments. What I do, I do vertical spreading motions to locate the ligaments first, and then I just cut superficially these ligaments very safely. Marginal branch just leaves the parotid at the gonion and then becomes superficial around the fascial notch, just where crossing the fascial vessels. Because it becomes more vulnerable at the time of being more superficial, and there is no any ligament just anteriorly here, it's best to do just going inferiorly, just inferior to the angulus mandible to release zygomatic cutaneous ligaments. So since this area, nerve is very vulnerable, Hammer does not maintain his dissection, subsmess dissection inferiorly. What I do, I just continue my dissection inferiorly and release the cervicoarytenic ligaments, and I don't go too much anteriorly. By this way, I'm protecting the fascial nerve, which becomes superficial here, and I also protect the cervical branch, which innervates the platysma. Mandible ligament, releasing this ligament is important for prejaw sulcus and marionette lines, and we have to know that it's very close to the marginal nerve. So if you continue your subsmess section to release these ligaments, you can injure the marginal nerve. The best is doing subcutaneous dissection and releasing the mandibular retaining ligaments in subcutaneous plane is very safe. And I do that through midline incision. Cervical branch becomes superficial very early and innervates the platysma. And this cadaver section shows just its root is parallel to the sternocleidoid mastate muscle and then innervates the platysma. And if you want to release these ligaments, you can just go down inferiorly and release these ligaments under direct vision. So this is good enough. And this dissection will not cause any morbidity for either fascial, marginal or cervical branch. What I do is this is also important, I curve my incision posteriorly because all other deep plane and composite plane facelifts are defined as doing the incision from lateral canthus to angulus mandible. I curve the inferior part of incision to the posteriorly and I stay on the top of the parotid and I stay posterior to the gonion. So I just start my dissection posterior to the gonion and my vertical motions, scissor motions, will be just pushing down the both marginal and especially cervical branch. And I continue my dissection inferiorly. If you do your dissection just around the area of a gonion, you may easily cut the cervical branch because it becomes superficial very early, just after exit. So it's a kind of protection, additional protection, curving this incision a little posteriorly. And another modification of mine, when I compare with the Hamra's deep and composite plane facelifts, he just do not do any subplatysmal dissection at the neck. I do just exactly what Andrew Giacono does. He does dissect the platysma at the neck and make a horizontal cut and rotates the superior part to give additional volume to the jawline. And he also just repositions and pulls the inferior flap in posterior superior direction, and it gives extra tightening and nice contour at the jawline. So extended dissection inferior to the angulus mandible, horizontal myotomy, and pulling the inferior flap will really give additional improvement for cervical contouring. Temporal branch becomes superficial around the zygomatic arc. And if you just criticize extended SMES and high SMES techniques, there is a fixed SMES dissection, and this dissection is quite close to the temporal or frontal branch of the facial nerve. If you are doing deep or composite plane facelift, SMES entry point is more anterior to the Pitangui line, which follows the line of the root of the temporal branch. So if you are doing deep or composite plane facelift or modified composite facelift, you will be far away from the frontal nerve, and you will not be worried about this nerve at all. And another advantage is you will be closer to the falling tissues, and it will give you just additional benefit to pull more effectively the mobile SMES area. I also do quite often deep neck manipulations. I almost always open the neck and see the platysma and do platysmoplasty. And then in most of my cases, I do higher suspension, which also improves neck contours. And if I see any after dissecting the platysma, if I see any bulging part of the digastrix, I partially remove this part. And in some cases, I just duplicate the digastrix. And in most of the cases, after opening the neck and dissecting and elevating the platysma, if I see any excess of subplatysmal fat, I just remove this, and it really gives additional benefit to contouring the neck. And if there is bulging submandibular glands, I resect these glands through submandibular incision as well. I mean, it's partial removal. And some patients, this is a revision case, you can see neck contouring with midline work. This is another revision case. So modified composite flap reticulectomy with extent neck dissection allows safe release of zygomicronous ligament and safe entry into the right plane, leaving all malar fat bed attached to skin in the absence of transblepharoplat approach. Produces combined, balanced, and harmonious rejuvenation of the mid-face, cheek, lower face, and neck without requiring separate mid-face procedure. Extended dissection at the neck also gives additional benefit, and deep neck manipulations are also really effective and will be just added to the modified composite plain facelift technique. Thank you.
Dr. Tuan Pham will now be presenting on mini facelift with deep plane approach. He is the past president of the International Federation of Facial Plastic Surgery Societies, Board of Director, International Board for Certification in Facial Plastic and Reconstructive Surgery, Director of Perth Facial Plastic and Cosmetic Surgery.
Oh, good morning. My name is Tuan Pham. I'm from Perth, Western Australia, and thank you very much for invitation to this very prestigious meeting hosted by our Korean colleague. And this is my city. City of Perth, about 2.2 million people, and our beaches, our state emblem. And it's, I'm in many private practice. So there's no disclosure. So my talk today is on the minimum incision. So short incision, but utilizing a deep plane dissection. Okay, so what's it mean? It means the incision is confined to the face only. The treatment is mainly for the jowl, the lower half to 1/3 of the face. But with a deep plane or extended deep plane facelift through the same incision, you still get a very good rejuvenation of anterior upper neck, the nasal level fold, the malar eminence, and the mid face. So in terms of short incision, so limited skin dissection, but maximum deep plane or sub-smash dissection. You can combine this with forehead lift, brow lift, blepharoplasty, submental laparosculpture, lapectomy, and anterior plasty. The alternative like S-lift, the MAC lift or minimum excess cranial expression, which is mainly skin elevation and then plication sutures to the smash. And thread lift, which is suture only. So the assessment of the mini facelift. Well, ideally, the patients are younger age group, they're 40, 55, some of them older. The facial characteristics is favorable. There's gravitational migration of tissue downward. There's still mild to moderate of the nasal level fold. Mid face is adequate, and it's mainly the jowl is the sign of aging. There's mild, you can also do mild laxity of the submental anterior neck here. So it's mainly treatment here for the mini facelift. The skin is still elastic. There's not too much fat in the face, and there's the all facelift good skeletal framework. Strong chin, sharp angle of the cervical and the mandible give you a very good redraping of the skin. And of course, overlying skin is minimally further aging. So what are we talking about? So it's labial fold and a jowl. Bit of a ptosis in the mid face, middle level fold and jowl. This area here. Okay. She's ideally for some of this in fact the lower buccal fat prolapse. And unfavorable patient, they're more moderate severe neck laxity. So here they don't the mini face they treat here very well, not so much here. So yeah, hypoplastic manner, so mid face ptosis a fair bit, deep fold, and thin atrophic severe for the aging skin. Okay, so this patient unfavorable because the neck is too severe for us to address just a short incision facelift. It will improve, but not ideal. Same as later here, treat the face very well, but this neck laxity and piston is less so. But some patients do request it because they don't want a full operation. So you respect their request. So the advantage of mini facelift for obviously younger patient, less invasive, less skin desiccation, so equal less complication, less downtime, quicker recovery. Eventually, is less, it's a shorter procedure, and it's less surgical, and it's definitely more acceptable in a younger group and even older group. So my indication now, of course, there's patient preference. So if the patient wants a short incision, despite this, you have to buy a short incision, because not everyone wants the whole face done. Your perspective, whether you have inclination to mini facelift or just treat everyone the same, is your perspective. Mine is that I treat the patient what they request and what I can do. In primary, there's many indications. In primary cases, I discussed the ideal favorable patient. Patient thick-skinned, Asian especially, they're very good for mini facelift. Risk of skin ischemia or healing is great. So in smokers and diabetic and people who have medical mobility, you want a short incision, some improvement. Good for revision. When there's previous face and neck lift, they have very good lateral facelift done already, but there's laxity or recurrence of the medial part of the face, the lower part of the face. So you can address with a short incision facelift to get to just the mid face, the lower face area. And I use the reconstructive for skin cancer reconstruction, for SMAS reconstruction in a product defect, and of course for facial reanimation. So what types and techniques are there in facelift in general? Well, of course, the skin or subcutaneous only lift. There's a SMAS lift, which can be a short SMAS or long SMAS. Deep plane or extended deep plane. There's a composite where the deep plane plus the orbicularis been elevated at the same time. Subperiosteal, just as a mid facelift. And the description is a face on it, which I call mini facelift or short facelift. Mid facelift, we get access to the temple area, and a full rigidectomy, face and neck lift together, or just isolate neck lift by itself. So types: subcutaneous only, skin only, redrape. You can do some plication sutures, screw rigidectomy, so SMAS, and just skin and a bit of lower SMAS. This is these, with a SMAS, so you can elevate the skin separately, and then the SMAS elevation is separate, two biplanar flap. So separate skin, separate SMAS, can be short SMAS, could be long SMAS. So a long SMAS is really equal, the same dissection under the SMAS as a deep plane. A deep plane, obviously, there's skin, limited skin, and then they incorporate it's more composite, the SMAS and skin together. But of course, it's above the orbicularis, above the zygote major. So there are two deep planes here. This is more superficial, and including some fat pad as well. So the composite graph is composite lift is the deep plane plus the orbicularis, which I don't do. I think it's too morbidity, and I don't think many people do nowadays. So the short incision, mini face I'm talking about here, incision in the face, temple area. You can have this in the hairline, which has become deep to the superficial deep to reach the deep temple fascia, or superficial incision here. So incision here. If you go in the hairline, it must be deep around the ear, at the retrotracheal in female, pretracheal in male, and the stop usually in infralobular area. And the full face to continue with that. You can have additional neck management here. Okay, so I'm going to talk about just this incision here, or incision into here. Now, anatomy is important. There's 5 layers of the skin, which consists to the head, to the neck, and throughout the body, really. So the first is skin, subcutaneous, and there's the superficial fascia, which is the layer 3. That's from the forehead to galea down to the SMAS, down to platysma. So then below that is the loose area of space where the retaining ligament traverse. Some perforating vessel come through immediately, and deep to that level 5 is a peristome or deep fascia. Why it's important? Because deep to the deep fascia, which is mesenteric fascia, is the facial nerve vessel and deep fat layers. So, and the key to the deep plane is understand the layer 3. So, skin and subcutaneous, the dissection is sharp. Because now the blood supply to the skin is the subdermal area, so you need to go a bit subdermal, and you dissect sharp dissection here, the very minimum dissection. And then you have the superficial or the SMAS or galea. Then below that is the loose area tissue plane, subgaleal, subSMAS space, and there's loose. So this is the glide plane. So this area is a more blunt dissection. Of course, they're sharp when you lyse the ligament, but it's blunt dissection the rest of it. So this glide plane allow a maximum movement. And below that, the peristoma in the forehead and the scalp, and or deep fascia in the face. And below that deep fascia is the facial nerve, the masseter. So why is the SMAS important? You know, this distinct fibromuscular layer, let's say from the top of the head to the platysma, but the most important is the double attachment, the skin above and the muscle below. So when you pull on a SMAS, you pull the skin above with it as you lift off the muscle below. So that's the SMAS there, all the way from the front down to the face. I won't bore you with it. That's all the way through. Okay. And there's another diagram, the SMAS all the way from the face come to the neck. Now, so below the SMAS, there's loose aerospace, and below that is the deep protomasseteric fascia. And below that, obviously, is the facial nerve. Why? Because we need to protect that nerve. So the section above the deep fascia or protomasseteric fascia, then you are protected from the nerve. So important is to stay above the deep fascia. Then the zone, most common is really a greater auricular nerve here. That's the cutaneous, not the facial nerve, but greater auricular nerve is the sensation nerve. Then the next, not the facial nerve, the frontal branch, the marginal branch, and the rest of the branch. So, and the key of the frontal branch is always it's deep to the fascia, deep to deep fascia. You stay above the deep fascia, you're protected from the nerve. The next important is the ligament. The facial retaining either rise from bone, just a zygomatic cutaneous ligament, or from mandible. So you must lyse through those ligaments to get to access to the more medial face to get mobility. And then there's muscular ligament around the masseter muscle, and also along the SCM, the sternocleidomastoid muscle. Again, those need to be lysed to get more medially and get maximum movement of the SMAS. So those ligament lines almost in line really, zygomatic cutaneous, masseter cutaneous, they go down to cervical retaining or cervical ligament, and more medial. This here you release that subcutaneous rather than deep. Why is that? Well, there's a fixed and mobile part of the SMAS. We get the fixed and mobile part of the skin. So this part is more fixed. So by doing a lateral facelift, all you do is this. You don't get to this here. You pull the SMAS off, but this is fixed. So by only go through this ligament, the zygomatic cutaneous, masseter cutaneous, cervical cutaneous or cervical retaining, you get through this medial mobile area of the face, the buccal fat. So you fixed area, mobile, last is through this ligament. Again, those ligament to get through this part here, you maximum. So utilizing aesthetic principle, well, there's 5 things to do. There's of course the incision, the dissection plane, flap advancement, fixation, and wound closure. So the incision, you would place where the scar is least visible. You optimize the dissection plane, so not too thin in the skin, so reduce the bleeding and vascular to the skin. And then you, myself anyway, to do a sub-SMAS dissection. Why is that? Because you can recruit the skin because the sub-SMAS plane is more mobile. So you pull on a SMAS, you pull the skin with it, and it's more safer plane, less bleeding. You can improve the reposition of the skin by the vector of the SMAS. And because when you pull on the SMAS, you reduce the tension on the skin. So the good closure and good wounding and less complication. So improve scar. And again, this you stay on the SMAS, there's the minimum damage to neurovascular structure. So the donor where the SMAS is less morbid, tension-free. And of course, what you do is you try to protect the facial nerve. Now, my personal technique is, of course, you have to individualize everyone. Okay, there's no one facial fit all. The skin elevation, 2-part, where in the hairline, that's mean around the temple, then you have to go to through the temporal parafascia, and it's on to the deep temporal fascia. But if you use the hair tough incision, then of course it's subcutaneous only. The smash is still really is an imbrication technique. I rarely use plication, and the section is mounted to extended deep plane as required. I rarely do mastectomy or long short mask, and then you imbricate. I use the O vicryl to the deep fascia, and then running trio monocle at the edges of the smash. Then I close. Before close, I use excise the skin. Then I use RTs, which is a thrombotic antithrombotic spray, a thrombotic spray to help to coab the skin and reduce seroma, bleeding, and also quick recovery. Then I just close subcutaneous with trio monocle, and I use a viral repeat substicular or just running. So this RTs here is a frequent sealant. Okay, same as flow seal. It's just a spray form. So this one I'm talking about incision from here up to here. The full face is to the neck incision. There's a full face. So short incision, I use the temple. If that's the case, it's going to go through the temporal fascia. This is the deep temporal fascia or the temporal muscle fascia, and skin is here. So the deep plane, the key is to enter the smash from angular mandible to zygoma. Above the zygomatic muscle is superficial, and stay above the orbicularis. Then the transition from the superficial to deep. So anterior to the parotid gland, you go deep, and it's dissect on the parotomastotic fascia. And you see the fascia under the fascia, and they'll just depend how far extent depend on what you require. And the skin either go to the temple or along the hairline. Okay, so that's what I'm talking. Incision in the hairline is follow the hair and to that part. That is the marking here. This is the temporal incision to here. This is all surface marking. So this is the frontal branch of the facial nerve. This is the skin dissection here. There's the skin dissection right here. Okay, and then from then on, from angular mandible to lateral, enter the deep plane in that aspect. Now, if I've the deep plane dissection is right to the middle of the fold, and I call it extended deep plane. It's an arbitrary term, but if you don't reach the middle of the fold, things enough, then it's a typical deep plane. Then you go to the middle of the fold. You can dissect down the mandible. Usually, I can use like 2 centimeters down the mandible through this incision, the subsmash plane, and pull. Okay. So again, the marking, that's a trichotic incision, and the men is pre-tragal. It's got a good hairline, so there's no point putting it here. Put it back here. Extend the plane, you go right into here, right to here. Extend the plane. So the section is smashed right in the middle of the fold. Now, the skin incision, just a diagram. The skin is here only, unless you do on the temple, then this part is deep. So the skin incision, angular mandible, the lateral canthus. That's all the skin. Not too many the neck. The amount of smash dissection, I do a mastectomy, which is very limited, or deep plane here, just to go there and extend deep plane. So that's a sub-smash dissection. This is very limited smash dissection, and you suture together. And after that, you imbricate and you pull the smash up. Then you imbricate either. This is a lateral spectectomy. Then you just suture it up. But in a true deep plane, then you elevate the smash. Then you imbricate a couple of suture. I normally suture, this is the most critical here, but for the jowl, and that's about 65 degree, and to the deep temporal fascia. Whether you use this incision or this incision, doesn't matter. You dissect it out. And then this is go to the zygomatic arch. That's not injuring the nerve at all. And this is go to the pre-auricular smash, lubricate together. So once I've done that, I just, if it's smashed from here to here, I just run a trio monocle together just to give it better support. So this is a video of so incision. Okay, and this I use the hairline incision. See, that's what it is. So this is superficial here, deep here. So the skin, temporal fascia down the deep layer. So you can still dissect right to the lateral orbit here, and the skin incision from here to here. That's it. Okay, and then the smash is going to be all the way to here. You see a little bit of liposuction here, all the way to here. So that's. Then when you enter the smash, okay, this just a normal area of the skin and a smash a centimeter behind the skin elevation. I use that to enter the smash because I can grab that tissue there and elevate. I use the scissors mainly. So this is the endoscopic view, different patient. I'm not sure. You just go to them and you just vertically dissect that bluntly, and if there's that's the masseter cutis ligament, you just snip the ligament, and you see the muscle here. That's the zygomatic major muscle. So there's fissure here and then deep here. Okay. You pull. That's the ligament. The pull. Then you implicate to the deep temporal fascia here, and the first suture is that. When the jowl is about 60-65 degrees to the vertical. You can see the smash move from here down to almost the pre-auricular. And if found a lot of excess, you can trim it. So quite a good pull. Then once you implicate main, I just run a trio monocle to better lining of the smash. And then the skin resection. After the skin resection, I used RTs here, sprayed a bit. It's not very much a bit. The bit is from here down, it's just limited. That just helped to coap the skin, reduce aroma, bleeding, and also faster healing, in my opinion. You keep it 2 minutes, and you sew the skin again. Okay. So this is the same here. Firstly, there you go. The skin here. The subcutaneous here to connect the superficial with the deep. So here I enter the smash right here. And then you retract, try again, retract there, and then you elevate all the deep plane. So that's muscle here. So try to see it again. So this part here, you enter, that's a bit of malafat pad there. So you can, with a short incision, try to cut high in, right? So superficial, above the zygomatic major, and all this is the deep plane part. The masseter, the parieto-masseter fascia is here, the facial lips underneath there. So you can reach quite high. And then once you've done that, you move the smash from there, you advance the smash, quite there, and then skin. So the implication of the smash, one to here, one to there. And once it's done, you run over the trio monocle. So it's quite a good movement. Seal it with our teeth. So again, implicate or advance the smash, suture its expansion, implication, and then our teeth, what left of the skin flap, provide pressure. So because you resect the skin already, sometimes you maybe do a little bit refinement, but usually I don't, because it's, the tension is much less after the teeth. So again, just demonstration of the smash movement from there to there, there to there. Okay. So for the deep plane, you can see Asian lady here. You can reach quite far, right to the middle of the fold. My fingers in there to the middle of the fold, just extend the deep plane to the small incision, right there. Up here is the middle ligament. I don't divide the ligament from deep because the facial nerve margin front run there, and the facial artery. So if I need it, I make a small incision here and reach it subcutaneously to allow this to move. So that's the extent of deep plane you can get. And of course, you can see nerve, get a marginal branch, buccal branch, and extend there. And again, implication, suspension. And what you get? So there's a more mobile here. It's mobile. So after mini facelift, the skin is fixed. There's excess skin removed. Okay, so mobile medial face after deep plane is quite firm, and amount of skin removal. So right on the table, she's a revision facelift. So she's a previous facelift neck lift, but it's fell here and fell here. So see fell here and fell here. So just a pneumo facelift, that's still very good neck and middle face management. Neck, middle face through a short incision. So it's on the table. This is a few days later. This is 5 days later. So you can see that iodine as well, but that's a 5 days later. Yeah, so minimum swelling, neck is good, minimum swelling, minimum bruising, minimum swelling. That's 5 days. So you can put makeup on and go out, really. So that's 5 weeks now. She's a very happy lady. And she's 79 years old lady, right? Since now she said, look, I look, her face at least, and I look about 15 years younger because all her has improved. So a bit of fun here. That's the 5 weeks. She's smiling. That's her before and after. She's 79 after me 5 weeks. She's more than happy. Better jawline, better jawline, better neck, more incision, heal fast, minimum complication. That's a previous scar, by the way, so it's not mine. So what happens? 2 days, this is a lady have a mini facelift with a brow, 2 days. It's a small incision. She's there's incision here. I use temple incision in this case, but she's a young lady. She doesn't want an incision, which is fine. This is a couple weeks. Ptosis, more square face here, or rectangular, more oval face. Again, incision here, oval face, good line. Shower pictures, see a bit of buccal fat, immobilized buccal fat as well. There you go. Incisions in here, imperceptible. Improvement. She's very happy, and I think this before 3 months, they're about 3 years down the track. No, 6 months down the track. 3 years. So you can see this improvement now. Good jowl, she's iodine as well. Better neck, and it's maintained it. So better jawline, better jawline. Bit of oomph here because the midplane, so you have a malar improvement in her. Better neck, and to maintain the neck. So she's very happy, lady. And this is her a bit older. She's just one a mini facelift. She doesn't care. She doesn't want any incision, just mini facelift. She doesn't, do what you can, doctor. But I think we get a good result. Just a mini facelift on her. That's what she wants. She wants this. That's what you get. It's too a bit early, but okay. From there to there, with minimum bruising, minimum swelling, she's very happy, extremely happy. Okay. Maybe she don't want anything done. Just the mini face. Leave my eyes alone, leave the neck alone, just this part. Okay, it's fine. Asian ladies, I think it's great for Asian lady. Ptosis of the face, heavy neck, it just rejuvenates. Just mini facelift, improve a jowl, put a neck improvement. There with the liposuction. There, and it just all move up. She's got a lot of buccal fat pads, so I move to here. So it's going to more oomph here, more volume on that side. It's about 6 weeks of it. And she's happy. She's open eyes. She's, and the scar healed very well. She's well. Not overchange, but that's enough. I think. And most of these patients, I don't want a surgical look, it's a natural look. And I think mini facelift with deep plane give you a very nice natural look. So what's the practice I do? I don't do skin only. If you do skin cancer, then do plication with it. Mini facelift 30% because some patients are younger, some have revision, but still the bulk is to a typical deep plane face and neck lift. Neck lift very rare. Superior still I do it for facial animation in some cases. Complications like hematoma very rare. Skin slough, I haven't seen one. Earlobe, yes, if you put too tight, but it's usually over tight rather than under tight. Bunch in the skin, that is real, and that will settle down usually. Infection, again, very rare. Wine and scar, less common because your tension is very little. Hairline changes, not really. If there are hairline changes, I put incision in front of the hairline, at the trichophytic, not behind. Nerve injury, with the luck, I haven't had any. Sometimes it's just mild, but 24 hours because they're low anesthetic, and sometimes just been bruising. It takes a week or two to recover. Look, there's unsatisfied due to limitation. It is limitation mini facelift, so it's not a unsatisfied, but it's limitation. You can warn the patient how long lasts. I will tell the patient, look, you could be improved at least about 7 years. That's about more than that. I think it's about 5 to 7 years, and they're happy. Now, unfavorable mini facelift. She's very happy though, but good face here, but neck still. Okay, but she doesn't really mind that. She just wants a short incision, quick recovery, back to corporate world, corporate life, improve here, less here. So that's limitation. So you need a neck lift for that. And same as here, I'm flying out in to see my family overseas in a couple of weeks. I want a short, quick procedure. I just want improvement here. Okay. So it's not a failure, but it's just a limitation. Improvement, she's happy. Don't leave this alone. That's fine. She's happy. Happy patient. That's the whole thing. So what's the take home? So incisional face only. The primary area is the jowl, lower half face. But you can, with a deep plane, you can go with a bit down the neck as well. So short incision, limit the skin dissection, but maximum deep plane or smash dissection is possible with a mini facelift. Primary patient, those very patient, very good for Asian thick skin patient with skin ischemia and healing is poor, so smoking diabetic. Revisions, good for revision facelift, you reach more medial part of the face than the lateral, and for reconstructive. So thank you very much. I hope that was informative, and thank you again. Have a good day.
Session 3, the 6th Asian Meeting of Aesthetic Surgery and Medicine will now begin. Dr. Aldous Chan will be presenting on dermoscopy facilitates laser dermatological practice for Asian skin. He is the Honorary Clinical Assistant Professor in Family Medicine at the University of Hong Kong, Director of La Puro Clinic, Hong Kong.
Hi, I'm Dr. Aldous Chan from Hong Kong, and today my presentation topic is dermoscopy facilitates laser dermatological practice for Asian skin. And welcome you all to the Master's Symposium on Facial Rejuvenation and Korean Cosmetic Medicine. This is an observational review of 6 years' experience on how dermoscopy can assist laser dermatological practice for skin type 3 and 4 patients in a single laser dermatological practice in Asia. The instrument I used was a long contact polarized dermoscope, which with connection to the digital camera of a smartphone as shown here. Actually, the polarized dermoscope uses 2 polarizers lens aligned at different angles and allows our eyes to detect the scattered part of the light and enable us to see up to 100 micrometer deep into the skin. How dermoscopy can help us in laser skin practice. Actually, it helps me in heavy steps from initial diagnosis, treatment planning, procedural assistance, and treatment follow-up. Okay, how can a simple portable polarized dermoscope facilitate my practice? The main part of my speaking will be on dermoscopy's ability to differentiate non-melanocytic superficial from deep pigmentation so as to facilitate selection of laser. It can identify dermal vessels not seen by naked eyes and to avoid iatrogenic laser-induced PIH. It also helps us to visualize clearly the laser treatment endpoints and to monitor treatment progress. Finally, it can assure the benign nature of pigmented lesions before ablative laser, which is a very common procedure in Asia, and decrease the need of biopsy. Let's review something basic first before going into details. We need to know the 2-step dermoscopy algorithm. The first step is to differentiate melanocytic from non-melanocytic pigment lesions. Then the second step is to detect specific dermoscopic features to separate benign from malignant lesions. In this lecture, we will focus on the non-melanocytic pigmentation and the features of benign melanocytic lesions, which both can be managed by laser and light therapy. Let's get a grip on dermoscopy pattern for non-melanocytic pigment. This is a magnified view of an Asian normal skin which shows so-called pseudo-reticular pattern. It means the flattened dermal-epidermal junction of the facial skin is interrupted by numerous holes of non-pigment hair follicles and sweat gland openings. This is actually not true pigment network seen in melanocytic lesion, which result from pigment along the elongated wetty ridges. Some diffuse pigmentary conditions, such as melasma, deposit the pigment along this pseudo-verticular network patchily, and solitary conditions such as solar vertigo gives a localized homogeneous pseudo-verticular pattern. When melanin is present in skin, the color scheme will depend on the type, concentration, and anatomical position and depth of the melanin. Melanin in different skin layers gives different color under dermoscope. Epidermal pigment gives brown color and dermal pigment gives gray and blue colors. Apart from pigment and position and pattern, the edge of the pigment can give you hints to differentiate epidermal to dermal pigment. Epidermal pigment gets a more defined and clear border, as shown here is a small freckle, and fade border favors dermal pigmentation. Here it shows a hoary leafless pigment. So in summary, for dermoscopy for long melanocytic pigment, we should observe the pattern, color, border, and some specific characteristic of the pigment to differentiate epidermal from dermal pigment. Sometimes dermoscopy is histopathological correlation can help you understand more the dermoscopic findings of certain pigmentation, which will guide you on laser therapy. For example, histopathology of solar lentigo gets wetty ridges hyperplasia or elongation, whereas freckle does not. This explains the dermoscopic variation in color intensity of solar lentigo when compared with freckle. In theory, higher laser energy may be needed to treat abundant pigment in lentigo compared with freckle with same surface areas. And then other example is the melasma. The size of dermoscopic structures such as dots, goblins, or blotches, which are gray in color, correlates with the density of thermal melanocytes or melanocytes in melasma, and significant increase of melanin in all epidermal layers correlates with the patchy pseudo-verticular pattern. Okay, let's start with epidermal pigmentation first. Freckle dermoscopically present with pseudo-verticular pattern with quite specific moth-eaten edges. The appearance correlates well with the basal layer hyperpigmentation histologically. Solar lentigo has diffuse pigmentation without specific structural features described as amorphous area or blotches with also moth-eaten border. There are two patterns of solar lentigos in Asians. The first is the flattened epidermal type. The second is the budding of ridges type, which shows more thickened epidermis. The upper diagram shows 1 part of picosecond 532 laser energy may not necessarily remove all the pigment because of the budding of ridges type of solar lentigo, which may due to different melanosome density within the keratinocytes. Lower diagram show regressed region of the solar lentigo and gray granules seen in lichen planus-like keratosis. Less energy will be needed for them for treatment. Okay. Seborrheic keratosis is actually the progression form of solar lentigo and show additional features such as milia-like cysts, comedonal-like opening, and hairpin vessels. Here show the subtypes of seborrheic keratosis. This patient show a small This patient shows a small seborrheic keratosis and a large solar lenticle lesion on white face region. Higher picosecond 532 energy is required to remove the small SK lesion. Cafe or lay macules occur at birth or shortly after birth. Dermoscopically, it gets a homogeneous brown pigment with perifollicular hypopigmentation. The main differential diagnosis is the congenital melanocytic leafus, which gets a globular pattern. Picosecond 532 laser can be used to treat the cafe or lay macules completely in 3 to 4 sessions. Becker's leafus is a epidermal pigment. Dermoscopy shows thickened reticular network with focal or perifollicular hypopigmentation with localized hypertrichrosis. Considering the lengthening and cupping of the wetty ridges with epidermal melanocytic hyperplasia histologically and the ridge pigment clinically, long-ablative vaginal laser is used for melanin shuttle. 3 sessions of 1565 lasers gets a satisfactory result for lesional removal in this patient. Post-inflammatory hyperpigmentation. Dermoscopy shows diffuse brown pigment without network pattern and with hypopigmented furrow. In acute PIH, also notice brown globulins with erythematous background. This treatment regime use IPL and Q switch 1064 lasers gives satisfactory result in managing the acute PIH in this patient. Horace leafus or acquired binatural leafus of outer-like macules. Dermoscopy shows clusters of localized gray pigmentation with fading out border. Perifollicular hypopigmentation with arcade structures can also be seen. Capillary is closely associated with individual Horace leafus lesion which corresponds well to histology of dermal perivascular crusting of melanocytes. Indirect vessel injury could cause PIH after treatment in Horace leafus. Laser fluorescence should be adjusted to treat those Horace leafus lesions with capillaries seen under dermoscope, and a test spot can always be tried. Q switch 1064 second pulse were delivered until mild petechiae bleeding into this selected Horace leafus test spot, and decreased pigmentation was noticed after 1 session. Low PIH was noticed. Leafus of aorta shows gray structureless area with patchy distribution and scattered brown gray dots. Bluish to gray homogeneous pigmentation in some cases. Q switch 1064 laser was used to treat these patients in 3 sessions. For epidermal melasma, find homogeneous brownish pigmentary pseudoreticular network, i.e., structureless brown pattern intervened by follicular openings. For mixed melasma, heterogeneous brownish pigment with brown dots or globules or arcade structures. Unpatterned patchy brown pigmentation with superficial melasma finding. Dermal melasma cause brownish gray to dark brown, thick structureless pattern with dots and globules. There is significant correlation between the size of dermoscopic pigment structures and density of dermal melanophytes. This helps you to appreciate the difference among the three types of melasma. This patient presents with mixed melasma. Dermoscopic features show light brown pseudoverticular pigment suggests epidermal melasma. Patchy gray dots suggest dermal component. Picosecond laser 1064 with 1927 laser were used to treat whole face, and the result is quite good after 60 days. It is a suggested dermoscopic guide to energy-based device therapy for Asian patients. 1927 fractional thulium laser, 1064 kill switch, Nd:YAG lasers or picosecond or fractional picosecond lasers are safe for light, brown, and mixed melasma. 1064 is used for the dermal component of melasma also. Intense pulse light may be used for epidermal melasma with vascular component. And test spot is recommended for melasma treatment by laser and light because of the capacity of dermoscopic presentation. Second part. Dermoscopy can identify dermal vessels and pigmentation not seen by naked eyes, which otherwise, when stimulated by high laser fluence, may result in PIH. Here shows a light color facial solar lentigo before laser removal, and erythematous shade was noticed over the 12 o'clock position. Patient requests low PIH. Picosecond 1064 laser followed by 1927 fractional laser were used. Pigment was gradually removed and discovering a capillary situated under the original shade region. So erythematous shade of solar lentigo usually gets blood vessels underneath. Vessels can present as capillary network, erythematous shade, or darker brownish shade under dermoscopy, as in melasma. Sacking of kill switch laser energy should therefore be avoided over highly vascular area for melasma lesion under dermoscopic guidance to avoid trigger PIH. Okay, dermoscopy also helps us to visualize clearly the appropriate laser treatment endpoints such as frosting and darkening, and to monitor treatment progress. Dermoscopy can help us to achieve very mild frosting laser treatment endpoint for superficial pigment removal, which has been shown to avoid post-inflammatory hyperpigmentation in darker skin. When using ablative laser such as CO2 laser to treat seborrheic hyperplasia or syringoma, trick is to give more laser passes to the peripheral of the lesions, as shown here. Hemangioma endpoint is immediate coagulation of dermal vessels when you use laser such as long pulse 1064 laser. Similar treatment endpoint is also suitable in treating pyogenic granuloma. Finally, dermoscopy can assure the benign natures of pigmented lesions before performing ablative laser removal, which is a very common procedure in Asian patients, and it helps to decrease the need and weight of lesional biopsy. Let's touch on dermoscopy for pigmented network. It is formed by melanocytes, pigmented keratinocytes or melanocytic derived cells at the basal layer. These cells produce area of dense pigment due to projections of the wetty ridges and relatively little pigment due to projections of dermal papilla. And it is the unifying surface microscopic features of melanocytic-derived lesions and is found in many examples of junctional and compound nevus, and even melanoma. We usually call this reticular pattern. Benign nevus pattern can be globular, and globules correspond to variable large less of melanocytes at the dermal-epidermal junctions and in the papillary dermis. Here show common types of acquired nevus, including junctional, compound, dermal, spitz, and blue nevus, with symmetrical reticular or globular pattern, which are suitable for ablative laser removal. Some differential diagnoses for nevus-like pigmented lesions in darker skin types include angiokeratoma, etc. Pigmented basal cell carcinoma presents with central arborizing telangiectasia and multiple leaf-like blue globules dermoscopically, which you must identify in your differential diagnosis. There are 6 dermoscopic features that should raise suspicion in fat pigmented lesions that I will not go further detail here. Remember, we must restrict all fat pigmented lesions with the above features for laser and light treatment. Conclusion: dermoscopy helps laser physicians to diagnose different types of non-melanocytic pigmented lesions and to achieve better treatment efficacy, and at the same time avoid side effects such as post-inflammatory hyperpigmentation, especially for darker skin type patients. These are the weapons. Thank you so much.
Dr. Chang Fu Sheng will be presenting on the significance of subarch deep plane thread lifting. He is the founder and first chairman of the Taiwan Association of Aesthetic Plastic Surgery, 9th council member of the Chinese Society of Cosmetic Surgery and Anti-Aging Medicine, director of Sam and Lisa Angela Cosmetic Chain Group, China.
Hi everybody, today my topic is significance of subarch deep plane thread lifting. Thank you. If you have any question, please don't hesitate to contact me. Thank you. Let's discuss about this picture. In the left side, it is before operation. In the right side is post-operation. In the post-op, we can see the paraoral gel stacking got somewhat improved but not so perfect. It is by traditional thread lifting. Maybe it is in the subcutaneous fat layer to lift up. So we can see the effect here is partially effective but not so perfect. Usually this condition maybe we return back the gel stacking maybe in several weeks or several months. In this case, we hope to get much more better effect to stop the paraoral gel stacking. So maybe we lift the much more force. The lifting vector is only in the lateral upper because it is the traditional lifting is this vector. So yes, we get a much better effect, but we get a reverse triangle face and much wider in the mid face area because the lifting vector is only lateral upper. In this picture, let's see the left side. It means right face here. It's epizygomatic lifting. The thread is in the subcutaneous layer and then maybe go deep. So maybe thrust in from outside of SMAS. So you can lift the SMAS up and lateral the vector. So it's the lateral upward vector. In the picture right side, it is the left face. The zygomatic lifting here. The thread is go beneath the zygomatic arch. So it is subzygomatic plane. And then in the subSMAS plane, it is the layer 4 of the SMAS, and then the thread thrusts out from inside of SMAS. So you can lift the SMAS inward up. So it is different vector with the epizygomatic lifting, the traditional method. It is totally different lifting vector. That is the significance of subzygomatic lifting here. Let's see again the animation. You can see epizygomatic lifting. The face is lift up lateralward and become widened. But in the subzygomatic lifting, the dip effect is much more natural. Look natural because it is not lifting lateral upward. It is lift maybe directly upward or maybe a little inward up. So we can compare these two different methods. It causes two different shape change here. Okay, let's discuss about the facelift here. Maybe decades ago, long ago, doctors do facelift maybe only by skin lift, maybe skin resection or skin dissect subcutaneously and lift and a part of skin. But then doctor find maybe it result very unnatural shape and deep fascia, deep tissue do not get lift, so become unnatural outlook. So SMAS technique developed and doctor do maybe SMAS application or SMAS dissection and SMAS precision and lift, but both methods can lift up only lateral upward direction. The lift vector is only lateral upward. But the defect skin, majorly it is buccal fat, cannot get well repositioned to its original anatomical position when she was young. So I think we should do the SMAS medial upward lift. To lift SMAS medial upward, the direction is only could be done by subzygomatic thread lift to lift up the SMAS medial upward, and then to push the buccal fat back to its anatomical original position as she was young. Let's discuss with this picture. The yellow means skin, the orange bowl means soft tissue, maybe deep fat, buccal fat. If only skin lift, we cannot influence the deep soft tissue, but only skin, so it's unnatural. If with SMAS lift maybe a little, you can lift up some deep tissue by lifting and maybe compression. But if we use subzygomatic thread lift, we can get an effect of SMAS medial upward lift. So much better effect and much more natural. So let's see some before and after here. This immediately post-op, you can see parallel jaw skin improve well in the nature. This 1 day after, another case. This another case, 3 months post-op. This another case, half year post-op. So you can see this case is a young female, but it is maybe her face originally is widening. But after the subzygomatic thread lift, buccal fat and the SMAS got medial upward lift. So we got the result of the face maybe the smaller and much more natural. Why does second jaw occur? First, superficial fat deposit drooping. So it causes some contribution to the second jaw. Second, deep fat atrophy. Deep fat atrophy causes support system unstable, enhance worsen skin droopy. Third, skin loosening, especially in aging case. Skin loosening may be worsen parallel jaw sagging. Fourth, SMAS pulled down. Here you can see 2 circles. In the small circle area, there is only depressor. It is platysma and no any elevator or any support to prevent the defect sagging. And in the big circle, it includes only transverse muscle. This resource maybe a little help to prevent some sagging of defect. But again, there is no any elevator here. So I think this area is, we can call it as a droopy window of low face. Fifth, defect second herniate because here only had depressor and no any elevator. So maybe defect second and even herniated out of maybe to the more downward position, more superficial position, because here only has depressor, only pull down force, no any lift force here. Therefore, discuss about how to treat second jaws, because subzygomatic thread lifting has the major meaning in the second jaw treatments. Subzygomatic thread lift can let SMAS and buccal fat to go back to its anatomic original position. In the discussion I just talked about, the second jaws, there is many factors, including superficial fat deficit droop. So in this case, we can treat with superficial liposculpture. In case of defect and the SMAS droop, because no elevator here to antagonize platysma, its SMAS weak point here, low face droop window. I call it as low face droop window. In this case, we can treat it with subzygomatic lift and got a much better effect than traditional thread lift or traditional face lift. Even you do high SMAS, your traction direction, your traction vector is lateral upward. Impossible to do medial upward lift except you do subzygomatic lift. This is the direction of the zygomatic lift because the buccal fat is too soft to hook by the thread cock. So the target for us to lift is SMAS, the SMAS lift inward or medial upward to push back the buccal fat. In this animation, we can see the thread goes subzygomatic space and it makes platysma to go medial upward lift and push back the buccal fat back to its original anatomical position. Let's show you how to do subzygomatic lift. Usually I do the thread in the temple area near the hairline and go into the zygomatic space. So you should know here, your trocar should go out from the inside of platysma, inside of the SMAS. So you can hook SMAS and lift it to the medial upward direction. So you can see it goes through buccal fat and you should avoid into the oral space. So you can see it is under the masseter muscle and above the temporalis muscle, between the two muscle space. In my measure, I do the zygomatic thread lift and then U-turn to go in the subcutaneous layer. This U-turn, we can fix the thread well by zygomatic arch. And both the superficial layer and the deep layer, we can do effective lift. Review again. It is traditional epizygomatic lifting. Maybe you do straight, maybe you do face lift. You can only get lateral upward direction lift. And this is zygomatic lifting thrust out from inside SMAS. Thank you very much. If you have any question, please don't hesitate to contact me. Thank you. Thank you, everybody. Thank you.
Dr. Kyung-Jin King will be presenting on the unfolding and volumizing approach of S-Sor mesh thread and polyderm HA filler for correction of nasolabial folds. He is the director of Seoul Phase 21 Hospital, founder of KCCS and KSKCS, publisher and founding editor of Journal of Cosmetic Medicine, former professor of the Catholic University Medical School.
Hello everyone, I am Dr. Safi Gang, working at Seoul Phase 21 Hospital in Seoul, South Korea. I'd like to express my sincere gratitude to participants attending the 4th KCCS and 6th AMAS conference of the Master Symposium of the Facial Plastic and Cosmetic Medicine 2021. I'm going to talk about my experience of combination therapy for the correction of nasolabial folds using absorbed molded mesh thread and polyderm HA filler. As you know well, there's two major types of wrinkles on the face: dynamic wrinkle and static wrinkles. Dynamic wrinkles are directly related to the use of facial muscles when laugh, smile, eat, or frown, right? Frequently folded skin and subcutaneous tissue naturally lose their volume and elasticity. So the area where the volume is lost will be depressed and fold up easily. Additionally, in order to compensate this volume loss, basic tone of facial muscles will be increased, and it makes deep wrinkles and folds. Together with loss of elasticity of the soft tissue, eventually surrounding tissue would be sagged. In my point of this view, I think that such dynamic wrinkles can be divided into two parts: a folded part and a depressed part. Fillers are the most commonly and safely used material to restore soft tissue volume deficiency. However, either spreading or migration as complications is quite common because of fluidity of the filler itself and habitual movement of facial expression muscles. Especially facial muscle expressions not only shorten the duration of the filler but also result in an unnatural facial contour. Today, I'd like to introduce Pine BM Company's Folidom MDM HA filler. This HA filler has applied state-of-the-art MDM technology to the entire manufacturing process, which now use HA gel single-phase microbead manufacturing technology. MDM filler is named after these three abbreviations. And divinyl sulfone, DVS, is used as a cross-linking material, which means that it is cutting-edge filler made with multi-layer refining technology. By utilizing the two structures of the hydrophilicity and hydrophobicity of the filler itself. The difference between this filler and the other HA fillers is that BBDE is used as a cross-linking material for the biphasic filler that we use. But this cross-linking method is in form of a pendant and it is unstable. However, Folidom MDM filler, which is monophasic product through microbead processing, also use DVS as a cross-linking material, so it has a perfect cross-linking structure. That's why the molding power is very good, as see the left picture, when you put all the HA fillers on the glass plate on which they stand, all other fillers flow down. But this MDM filler does not flow down. Like the right picture, when the MDM filler is stacked like a mountain, they form like a gel mass, boasting great cohesion. When you watch this video to compare the viscosity, you can see the MDM filler between first and second fingers has stronger and higher viscosity compared to the BDDE biphasic filler. In addition, MDM HA filler is its ability to absorb the surrounding water, and it shows the degree of absorbing surrounding water is very excellent compared to the other fillers. I can say this is a relatively safe filler that Folidom MDM HA filler is easily hydrolyzed by hyaluronidase. Next is PDO thread, which has been used for the purpose of facial lifting and tightening. In general, PDO thread has developed for the face lifting. By the way, how do we create volume with thread? Practically, this absorb volume PDO mesh tube is developed for increasing soft tissue volume. I will briefly explain Pine BM's absorb volume PDO mesh tube. It is 18 threads around one center core thread as the form of a tube surrounding perimeter. After insert into the body soft tissue, surrounding tissue cells enter the space between the thread and the tube. It causes new tissue formations, especially collagen fibers. Eventually, together with the rigidity of the mesh tube itself, a soft tissue foundation of the soft tissue itself would get stronger and it can contribute to support the surrounding tissue. This is a table showing the resources of this thread. Usually, it is a tube type with 1 core thread and 8 peripheral threads wrapped in the switch type in a 19-gauge needle. The core thread in the center is 0.2 mm thick and the circumference is 0.095 mm thick. And the spacing between these threads is about 0.23 and 0.285 mm respectively. Two different lengths of 3.5 cm and 6.0 cm long lengths are produced respectively. I was skeptical of how long the volume effect would last with only this thread and the mesh tube. So I insert it into the mid-cheek furrow in the unfold and the labiomandibular fold. Let's watch the video first. Yes, I am putting a 6 cm mesh tube in the mid-cheek furrow now. When inserting, you should touch the maxillary bone and place the tube just under bone. At the very bottom, the 5 fishes was placed on the supraperiosteal layer, and then 3 or 4 fishes was placed in the middle layer at submuscular level. And then I put 2 or 3 fishes to the superficial layer. Basic concept is that the deeper you approach, the more number of threads you add, and the more you approach superficially, the smaller the number is. You may ask, how many threads should I insert? You can decide it from the thickness and volume differences by touching and comparing the depressed area with the surrounding area of the face. When you feel the same or similar feeling from these two areas, you should stop the inserting thread. I think this tip will be helpful to decide how many threads to be inserted. Here I am inserting 3 fishes, 3.5 cm absorbed mesh thread into the deep fan layer of labiomandibular folds. This area is relatively thin, so inserting 3 pieces into the deep layer will be enough. If it comes out, you can put it back like this. This area moves a lot, so it is relatively thin with a little fat layers. Therefore, we can place PDO smooth thread in cross-linked form into the subdermal layer. Let's see the result. For mid-face cheek furrow, I put 13 pieces of thread, and for Marriott fold, I inject 3 pieces. I insert 3 pieces of 3.8 cm mesh thread together with PDO smooth thread. This is a before and after picture. You can see the volume increase with the skin tightening. This is a picture after 3 weeks. You can see there's still some swelling. This is 3 months after. The swelling is almost all gone, but there's still some volume increase in mid-cheek furrow and labiomandibular fold. This picture is 1 year after, and we can see a significant volume improvement, and effect has been still maintained. As you see, attempt to restore volume only mesh thread seems to have some limitation in the mid-cheek furrow. As such, it shows that thread insertion alone cannot bring about a perfect rejuvenation result. Conversely, like the labiomandibular fold, without large volume defect, almost perfect result were obtained by combined insert of mesh tube deeply and smooth PDO superficially. So I tried the combination on the mandibular fold with mesh tube insertion and HA filler injection. So I mentioned earlier, the natural fold is a good example of dynamic fold, and many facial movements also involve this area. I divide the natural fold into three parts. The folded part is green color, depressed part is red here, and the crease is in the middle. After designing like this, filler is injected into the folded part first, and then we inject filler into depressed part, and lastly, the crease is filled with filler. My concept of filler injections for the correction of deep natural fold is unfolding by thickening of the folding part, restoring the depressed part by volume increase, and then erasing the middle crease with a small amount of filler lastly. In each part, filler should be sequentially injected from the deep layer to the superficial layer. Mesh tube insertion is performed in order to strengthen natural fold and to prevent migration of filler inject. The thread insertion method is similar to that of filler injection in the point of view of effective sequence. So thread placed into deep layer first, and the middle layer second, and then superficial layer, following my sequential augmentation of filler injection, SAFI technique. However, there's a difference. When inserting, you should make sure not to place the thread too close to the dermis. If it is placed like that, it would be seen through the even can out later. So now let's watch the video and see how filler and thread can be placed into natural fold. This is a video about the improvement of dynamic natural fold by combination of sub-volume mesh tube insertion and polymer HA filler injection. Here I am making the design. The design by drawing crease in the center. Indeed, part I am designing now isn't actual natural fold, but it is the area which the extension of the natural fold and submolar depression get connected. I inject a little bit of tumescent and starting place the thread. Here I am putting a 6.0 millimeter absorbed volume mesh tube volume tube thread. And of course, I placed it deeply into the submolar depression, very near or contact to the maxillary bone in order to increase soft tissue foundation. After doing that, I start putting mesh tube thread in the folding area of natural fold. I start placing thread in the deep layer and the middle layer, and then finished in the superficial layer. While placing the thread, I keep touching the area by check how much volume we made and compress its thickness with the adjunct non-thread inserted area. This is how I did it with central crease line over natural fold. The sequence of injection, location and depth of filler should be also similar to thread insertion. Then I start injecting filler in the same way. First inject the filler into deep layer, move to the middle layer and then superficial layer. You can finish the injection when we feel it from our finger that the injected area has almost the same thickness as the surrounding non-injecting area. As you can see here, I am injecting the filler into the folded part and gradually moving from the deep layer to the middle layer and then to the superficial layer. I inject a certain amount of filler so that the folded part becomes thick and does not fold easily. And then I inject the filler into the depressed part of the fold for the volume restoration. Finally, I add the volume to the bottom of the crease so that the area fully has equal thickness. This is before and immediately after pictures in the state of non-smiling. At the before picture, the increased basic tone of a constriction of lip elevator and the resolute muscle is seen in the natural fold and parietal wrinkles. This happens by muscular compensation against aging due to sagging of mid-face. followed by the decreased rigidity from the natural fold and volume loss from the midface. Generally, this muscle tone is not increased in young people without deep natural fold. This is 1 hour after the procedure. Dramatic change of softening of natural fold and volume increase in the mid-cheek furrow are seen. At the 3 months after the picture, you can see the folded part is changed to unfolded and flattened, and the depressed part is nicely volumized. Especially the midface appears to be lifted and volumized. I think the mesh thread tube strengthening the structure of the mid-fold itself together with injected H filler through the restoring volume and firmness. Additionally, it supports the midface soft tissue. Eventually, the midface is volumized and lifted. In addition, a very comfortable look and less wrinkle around the mouth is seen. It caused by decreased contraction of parallel muscle I mentioned earlier. Then you will see a smiling face. The most noticeable feature is the softened natural fold. However, apart from this, there's very interesting results also are seen, such as a change in smile figure and the change in the mid-facial contour. This picture is 1 hour after the procedure. The folding part of the natural fold is unfolded, and the volume recovery of the depressed part of the fold is also successful. A smile looks more natural than immediately after the procedure. This is a picture of 3 weeks after. The most noticeable change is that the teeth exposure has decreased and gives natural and charming smile with volumizing mid-face as a useful appearance. The patient may say that she doesn't smile properly and may say it's awkward, but in reality we can see her smile is changed to a much more charming style. This will naturally result in fluid to be caused by suppression of lateral movement through the restoring volume and firmness of natural folds. Is it possible to create such a natural change in lateral by using Botox? It seems that it's not easy to control the concentration of Botox. In this combination procedure, it shows not only softening the natural fold, but also improvement of facial expression and the mid-facial volumizing as well. In this procedure, we have seen how to inject the combination of thread and filler. We have achieved not only the improvement of natural fold itself, but also got a complex improvement of reducing wrinkles in the peripheral area, lifting and contouring of the mid-face, and the refining improvement of the facial expression. So from the result of these 2 cases, it suggests that combination treatment both volumizing by filler and increasing the rigidity through the support the surrounding soft tissue by mesh tube thread would be a reliable approach for not only correction of the dynamic natural fold, but also additional improvement of mid-face contour, parallel wrinkle, and smiling. Thank you for your attention.
Dr. Sang-Yoon Lee will be presenting on needle lifting using Courage. He is the director of Aino Clinic, Busan, Korea, former Secretary General for the KCCS, judge for Mrs. Best Model Contest, year 2019.
Hello, I'm Dr. Lee, working in Aino Clinic in Busan. First of all, I would like to thank the staff of the Korean Society of Korean Cosmetic Surgery and Medicine for providing such a great opportunity. Also, I would like to thank the many conductors who attended this lecture despite the difficult times due to the coronavirus. Today, what I'm going to tell you is about the needle lifting using Courage. Now, many doctors are already doing their own lifting procedures. I would like to introduce an easy and simple lifting method that can be easily applied to that and can be used just like the existing lifting method. I've been thinking a bit about where to put the points of this lecture. Since time is limited, the many other uses of courage are kept very brief, I would like to focus on the needle lifting method using courage this time. Looking at the components of this machine, there is a roller called resonant plasma, and there is a glove, and there is rubbing ceramic like a LDM handpiece. The roller called resonance plasma is shaped like the circular MTS, but the tip is not sharp. Rubbing ceramic rubs skin after applying gel or oil on the skin. Skin gloves are conductive. Put a neutral or latex glove on it and rub it on your skin. Take a look at first. I'd like it that put on the gloves, stick the needle in and push, and then pull. That's it. It's easy, right? I'm going to talk about this today. Has anyone seen the device called needle shaping? Doctors who have seen the procedure of needle shaping will say that this is the same as the needle shaping. The procedure is almost the same. Instead of glove, use a ring for needle shaping. Instead of electroplate, hold a metal stick for needle shaping. At first, I thought it was the same thing. However, the results of procedure are slightly different. I will talk about the difference later. As you all know, a lot of changes come to the front cheekbone over the years. The malar pipette will gradually move downward, then the nasolabial port appears at some point. A lot of patients come to the doctors this time. When they come, most of them say that they want to put the pillars in the nasolabial port. As the pen moves downward, there are many people who think that it will be solved by filling only the lower inner part of the nasolabial port. What do you do when that happens? Well, it will depend on the patient's compliance, economic circumstance, and wants. But I think that when the only pillar is filled in that part, it will be difficult for the patient and doctors to achieve the desired result. Other parts of the pad also start to sag downward. As a result, we also see sagging jaw, malar and eyelid pipette start to be bulging, and the temporal atrophy begins to come. Another thing to pay attention to here is the change of zygoma. If you look at it, it says skeletonization, right? Skeletonization means becoming a skeleton. As the bone absorption occurs, the front cheekbone are lowered, and the lower zygoma also start to be lowered gradually. So you can see the hollow part called submalar hollow. This is the part where you can expect a lifting effect if you inject pillar to the bone under the periosteum. Many methods are currently being tried to stand against aging, such as facial sagging. Fillers and Botox will be used basically. Of course, you will do thread lifting. In addition, you will use various equipment according to the circumstance of each clinic. Some doctors use HIFU or RF equipment. Sometimes they use laser such as a long pulse or pico, and others use a combination in their own style. Whatever mechanism or process is used, the focus is on increasing the synthesis of new collagen. Here I would like to introduce you to other lifting weapons that use needle. As mentioned earlier, needle lifting uses equipment called courage. To know courage, you need to understand a little what QMR is. If you don't know this, Codec is just one of the common high-frequency equipment. You need to know this even a little to see the difference from other high-frequency equipment. What is QMR? Doesn't it sound like a difficult physics term that gives you a headache when you went to school? Most of doctors who are watching this lecture are also clinicians like me. Talking about complex physics here will be rude to those of you who take your precious time on Sunday, so I will omit it a lot. When we shine a light with a flashlight, it goes out like this. When the light energy is divided, it is made up of particles called photons. If the photon is subdivided, it consists of an aggregation called quanta. The constituents that make up the quanta is the quantum. In QMR, you will only need to know that Q, quantum, is the smallest unit that actually transfers energy. M is the molecule you all know when it comes to atoms and molecules. What you need to pay attention to is R, the resonance. It's invisible, so it's a part that can sound like a flight of fancy, or matter is in constant motion, and this motion gives it its own frequency. When you see photos are turning fork experiment, which are often used to explain resonance. If you put a turning fork with the same frequency and hit one side, the other side will vibrate as well. But you put a turning fork a different frequency, the other side will not vibrate even if you hit one. Because the frequencies are different, there is no resonance phenomena. I mentioned earlier that all objects are in constant motion. This also occurs at the molecular and atomic level within the cell. Some of you may remember memorizing the periodic table in high school. If I recall that a little bit, as electron continues to spin around the nucleus of atom composed of protons and neutrons, they have their own vibration and have a corresponding frequency. At this time, if a wavelength matching this frequency is given, it may cause a change in atomic properties or the dissolution of molecular bonds. The same principle applies to the human body. When you look back on biochemistry classes a long time ago, when you were in medical school, do you remember how it went down like this? Organ, tissue, cell, molecule, atom. In this way, it is further subdivided into a lower stage, and conversely, when collectively ascending to the higher stage, each organ of the human body has a corresponding natural frequency. This frequency may change at any time depending on external stimulation or condition, but usually has a frequency in the unit of megahertz within a certain range. Let's summarize. Quantum physics is a study that explains the physical and mechanical phenomena of atoms, molecules, and various particles and energies that exist, the bonding relationship between these molecules. QMR is a phenomenon related to the molecular bonding or dissociation through resonance and inherent vibration or frequencies of each molecule in particular. Therefore, it can be summarized as follows that QMR focuses on the frequency of the human body and aims at cell activation and generation through resonance in each part. Are you using a lot of RF equipment now? Whether it is monopolar, bipolar, or little RF, all generate heat. Whereas present RFs are to synthesize collagen by inducing the inflammation process through heat, QMR aims to achieve cell metabolism through resonance rather than heat to promote cell proliferation and regeneration. In most of the monopolar type RF equipment, RF penetrates through the epidermis. In this case, it is primarily reflected between the epidermis and the dermis, and absorption is reduced. And absorption is reduced again by secondary reflection and the upper part of the pen layer. Therefore, I think that it is more effective by reducing these reflections by putting the needle directly into the deep dermis and subcutaneous pen layer to incur QMR inside. First effect is the high frequency effect like needle shaping the equipment. Satisfaction immediately after the procedure depends on this first effect. You can see the lifting effects right after the procedure. I think this has something to do with some thermal energy effect. The second effect is caused by QMR. It must be said that it is an effect created by potential energy. That's why I tell the patient that you can still see the lifting effects more and more later, and you will feel it more clearly after about a month. As mentioned earlier, the procedure is very simple. We look at the patient, a 45-year-old female patient. She suffered from nasolabial pulse and sagging jaw, common in that age group. She also wanted to improve the wrinkles under her eyes. She had experience with HIFU and RF, and she had a repulsion to foreign substance, so she had never done fillers or thread lifting. For these people, needle lifting can be an alternative. As the other lifting procedure, I designed the vector directions in steady state. Since it can be erased easily by wiping with alcohol during the procedure, the insertion site and the ending point of the needle are marked again with the felt marking pen. The procedure is so simple. I wear conductive glove first and wear little gloves over it. I stick the needle in and push and then pull. That's it. The initial lifting effect is great when the tip grabs the tissue and pulls it well. Think of it as putting it in the subcutaneous pen layer. You can put it a little shallower than the normal cork thread and think of it as a little deeper than the non-cork thread. As you can see, the design is similar to when you put the cork thread. Because it follows the vector direction, I think that those who have already done the thread lifting will find it easy to access. Next slide. This is a scene using a short needle to improve wrinkle around the eyes. The depth using short needle is slightly shallower than the long needle. You can insert it to the depth than you can usually do using a non-cork thread. Wrinkle improvement effect is better than expected. If you use it mainly for wrinkles around the eyes or lips, the satisfaction is quite good. The short needle may not pull easier than the long needle in the teeth. You can just grab it instead of pulling it. Similar effect can be expected just by grabbing it. Next slide. Isn't it a bit unusual to see this pattern? Usually, while lifting using the cork thread, if you draw an imaginary line connecting the ear troughs and the lips, and do not do it while penetrating the line. Since there is a risk that one side of cork may come loose as the mandible pulls while opening mouth, it is not performed well through this line. But this lifting is possible. Since the pulling body cord thread is not used, you do not have to worry about the movement according to muscle or joint movement. Next slide. These are pictures before and immediately after procedure on one side only. In fact, in my experience, the most effect can be seen after about a month. As I said earlier, the lifting effect in early stage is thought to be a thermal effect that is created at the same time. I'm explaining to all patients that they create collagen spring pillars in the skin. I think that it creates a strong collagen spring pillar inside by generating collagen with the cell regeneration effect due to response energy around the needle. But there is no hindrance to movement and there is no pulling body to make a lifting effect. Thank you for listening. If you have any questions, please send me an email. I will try to explain as much as possible. Thank you.
Dr. Yi Bom Shin will be presenting on the use of diverse skin boosters. He is the representative doctor of Plus Who, publicity director of KCCS and KSKCS, director of Korean Mammoplasty Society, publicity director of KACS, and also the 13th vice president of KCCS and KSKCS.
Glad to meet you. My name is Dr. Shin. 1. Lijuran is a new concept product. Of course, similar products is appeared, but Lijuran is high percentage PN product compared with the old product. I think cause is that technique, which technique is pharma corporation know-how. 2. PN is DNA fragment, which is extracted from wild salmon, managed by Dr. Pharma technique. PN improve natural skin by recovering the biological condition of dermis and epidermis. 3. In salmon semen, we extract PDRN. PN is a long PDRN. We use PN by medical handling, and PDRN is used by majorly cosmetics. So PDRN, I think, compared to PDRN, PN is more effective. For as we grow older, skin is dry, wrinkle, poor, lower elasticity, hyperpigmentation. As a result, skin layer is shiny. Everything is due the skin regeneration ability is decreased. So our skin is very fragile. Fiber. Weak skin is very loosening, but after Lijuran injection, skin is changed very tightly. Because I think Lijuran make skin synthesize DNA. 6. Lijuran injection site is intradermal region. Amount is about 0.03 cc or milliliter. So we never penetrate dummies. Lijuran injection site is full face, especially dark circle area and periorbital area is very effective. In neck, vertical wrinkle is very effective, and dorsal surface of hand is very effective. John. In this report, in neck area, neck elasticity is improved about 20%, and hydration is improved about 14%. 9. Anyway, who is suitable for Lijuran treatment? Answer is simple. Aging skin. Aging skin, this skin is skin turnover ability is decreased, but after Lijuran injection, skin turnover ability is increased. PDRN mechanism is for PDRN is same PN. Long chain PDRN is PN. Mechanism first one, anti-inflammatory effect and growth factor increase, and third, lamin and fibronectin is made. Last one is DNA synthesis. So many skin is made by Lijuran stimulation. Lijuran has 4 types: Lijuran, Lijuran I, Lijuran S, Lijuran HB. Lijuran is original, first product. Lijuran I's viscosity is very low, so periorbital area is injection site. Lijuran A's viscosity is very high, so we use in generally Arkansas. Lijuran HB is new product. Lijuran HB has hyaluronic acid and lidocaine. So hyaluronic acid, due to hyaluronic acid, very moisturizing, and due to lidocaine, no pain. No, a little pain. So Lijuran I is periorbital area we inject, so elbow is almost no exist. But Lijuran is slightly elbow. Lijuran is very high elbow, So injection site is Arkansas. In this report, say after Lijuran, collagen is increased. This report, after Lijuran, show fibroblast proliferation showing. This report say Lijuran skin texture is very improved. This report say after Lijuran, melanin and skin tone is very improved. 17. This report say after Lijuran, pore size and number is decreased. 18. This report say after Lijuran, operation scar is improved compared to contrast case. This report say after Lijuran with picoration, scar is very improved. This report say after Lijuran, periorbital area skin is very good improved. 21. This report say, so 21, so Lijuran we use 3 steps. One step is PN injection by Lijuran, and second step is skin booster, is PDRN, injected by Sono, and skin is very calm down. Why use Sono? I think Lijuran molecule is big, so penetrating method, Sono is very good choice method. But sometimes we use skin booster with laser and MTS device. 3 step. PDLN cosmetics we use daily. We sometimes embarrassed and sensitive skin patients. These patients after laser many side and adverse effect and change it to rash skin. So these patients take Lijuran 4 times, no side and adverse effect. And laser effect is more effective. Why? Skin is changed to very healthy and tightening. So we can use Lijuran in sensitive skin number 1, and redness skin, acne skin, dark skin, dry skin, especially most effective in sensitive skin. Sensitive skin is changed to very healthy and moisturized skin. Okay, this slide I show Lijumated is a Lijuran inject device. If we use this device, we can inject Lijuran very easily, very fastly. It's a Lijumated component, main body, syringe holder, and very important vacuum filter, and very important 9-pin needle. So if we use this device, we can inject Lijuran very handy and very easy, and no Lijuran loss, and weak almost no. This Lijumated have a 9-pin needle. So one shot we can inject 9 holes. So we can very fastly inject Lijuran. So very easily, fastly. this device contact skin and then push button. Needle suction and inject Lijuran. So we can inject Lijuran in intradermal region. Of course, we don't lose Lijuran almost. In program P1, P2 program. P2 program is less lost, but it takes a long time. So many patients we use P1 program, but enough time. If you have enough time, we will use P2 program. P1 program is very fast, but P2 program is no loss. Thanks for listening. Thank you.
Thank you for your enlightening lecture. Dr. Yibom Shin will be now ending the conference with a closing speech.
Great to meet you. My name is Dr. Shin, the Vice President of Korean Society of Korean Cosmetic Surgery and Medicine. I would like to conclude this year's fourth conference of KCCS and KSKCS with a heartfelt thanks to the President, board members, and staff that made possible the successful implementation and outcome of this affair. It was an honor to co-host this event together with Shinmian Clinic, Joseon University Hospital, Otolaryngology Department, and AMAS. I would also like to convey a special thanks to the accomplished speakers from 11 different countries for their delivery of meaningful lectures and sponsors for covering our activities. On behalf of the conference organizers, I would like to express my gratitude to all of you who have come together here from various countries for your cooperation, which has enabled a highly fruitful conference. I hope to see all of you in person at our next conference once the COVID situation improves. Have a wonderful rest of weekends. Thank you.
Thank you, Dr. Yibom Shin. I hope you all had a wonderful and memorable experience here today. Thank you to everyone for participating and taking interest in our organization's academic affairs. We will be hosting fellowship programs the following year beginning January 2022 called the Pascal Program. We would greatly appreciate your continued interest. Everyone have a nice remainder of the weekend. Thank you for coming.